and say childhood cancer. Most of them are like childhood asthma is 4 in 100, epilepsy is 44, 3.6 to 44 per thousand. These are from various studies. Congenital cardiac conditions, we all know it is 1%. Nephrotic syndrome, 12 to 16 per 1 lakh. Whereas if you see autism spectrum in the recent 2018 study by CDC, the incidence and prevalence is very high. It is 1 in 44 now. And the INCLIN study, which was done in India by Kerala CDC, that was quite a long time ago, that showed 1 in 88. After that, there have not been many studies to study the prevalence of ASD. ADHD and learning disabilities are some of the conditions which are very subtle. And we do not have actually enough studies in our scenario to understand what's the prevalence. But in foreign studies, learning disabilities are shown to be about 17% or 1 in 5, which means almost every classroom, there are at least 2 or 3 children. If there is a classroom of 50, there are at least 2 or 3 children with learning disabilities. And most often they're present as lazy, unintelligent, do not listen, stubborn, or parents keep complaining about them. These children end up having low self-esteem, or they may be bullies, or they may be bullied. These are some of the things that often remain under addressed, and they have long-term impacts in their relationships, families, education, occupation, all of these areas. And unfortunately, the most common disabilities don't appear physical. Most common disabilities are not cerebral palsy or physical disabilities. They are something that we can't see. They're not visible to the naked eye all the time. So what do we do as a developmental pediatrician? If I ask you all, these are the options. How many of you think we only diagnose children with developmental pediatrics for A, B? Okay. Any other options? D? All of them? Okay. So I think our hands are more or less in all of these. So when parents come to us, the first thing that we ask is, what questions do you have for me? And first they would start talking about their children. My child has not spoken, and we went there, we went here, and this is what has happened. Then I again ask them, what questions do you have for me? And usually they come up with their questions. They say, we watched this TV, we want to know if this is ASD, or we watched this video, or somebody has told me this. Is this what somebody has said, there is no treatment? Do we need, is that true? Or my child is not interacting at all and I'm very concerned about it. So because ASD is one of the most common conditions that we see in our practice, and my examples are mostly from that. So these are the most common questions. And what usually happens up till now is, because there are a lot of centers and there is not much awareness about this area as a specialty, parents usually end up going to therapy centers directly, or they may just wait and watch out of fear of encountering some stigmatizing diagnosis. So that is, even though majority of the parents in a lot of studies have shown that they understand that something is wrong very early, much earlier than a pediatrician or anybody in their family, still there is a significant lag till they come to seek help, at least a lag of 14 to 15 months. And that is where we need to sort of, because let's talk about early intervention then. So what do we do in our initial session? So what we do usually is first have a conversation with the family about what their concerns are, and have a detailed interview about their own developmental history and previously how the child was right from birth onwards. And then we use play-based techniques, or if required, formal assessments, but not all the time. And if the diagnosis, if we understand the reasons for their concerns, and if it is fitting into, usually we follow DSM-5 criteria to diagnose children if there is a diagnosis behind it, and if required, and if the parents ask, we do formal tests and a medical examination to rule out any neurological conditions, or even other medical comorbidities. A lot of these conditions have comorbidities like sleep related issues, feeding related issues, it could be appetite related issues, all of these things, and allergies, even vision, hearing, all of these come as comorbidities. And then we talk to them about why these concerns are happening, not out of our own knowledge, but out of scientific reasoning. And then we sit together, discuss together, collaborate with them, and plan an action depending on what works for them. So a lot of times the action is individualized. So in individual sessions, some before in the pandemic, we had lots of online sessions where we worked with parents and to observe therapies, as well as to observe the child, as well as to help them to work with their own children. And interviews is what we do. Play-based assessments, some look somewhat like this. So that was a kid who, it was a follow-up session. So earlier, so we worked on a lot on engaging him, because he fell on the autism spectrum disorder, and that was one of the follow-up sessions. A lot of our play-based assessments look like that. We do assessments to understand what level the child falls in different areas of development. In ongoing management, when parents come for follow-up, usually for at least once in 3 months, these are some of the things that we address, like what is the therapies, or how the teachers think about them, and evaluate a lot of other factors that are involved in the child's life, and not just what the child can do or not. And this includes how the child is at school, how the child is at home, how the child is with relatives, what does the child do, and what's happening at the therapies, where do they go, all of this. And also we connect with the therapies and the teachers that work with the child and who exist in the life of the child a lot of times. Then we also track the child's intervention plan, and periodically, and also all the factors that's impacted, medical comorbidities at every follow-up, and if medications, very rarely, which we use, are also monitored. And then sometimes we help parents to learn the strategies and work with the children directly. And also when parents come to us when they're having a transition in their life scenarios, they may be moving out of a place, the child may be shifting schools, or they're making new friends, anything like that, and help them in decision making. So these are some of the formal tools that we use. We work with all the therapists together and also train the parents here. Sorry. This was a video which is, I think, not playing. Yeah. So this is a parent who, during the pandemic, the child was in another district. So we trained the mother to work with the child through online modalities, and she is doing such a great job. She has been a very proactive lady, and has been diligently following up with us. We also work with parents to give them a break also so it's often a very big deal for parents to work with their children, and especially mothers, and they feel very overwhelmed in such situations. More so because they are the ones who are taking care of them, and even for working mothers. So giving them space to understand what's going on with them also makes a huge impact on the child's development and growth, and that becomes an important point of intervention for us. So in essence, these are all the areas. As a developmental pediatrician, I think in working together with different areas and forming relationships with different services is what we do, and eventually we end up having beautiful relationships with the families that we work with. And because these are long-term relationships, and it's so it doesn't become only the child and the doctor point of view. We are sort of involved with a lot of things that happen, and a lot of times follow-up sessions look very informal for us. So essentially, through all these processes, we are addressing these areas. This is a modification of the International Classification of Functioning Health and Disability by WHO, which describes any health condition, chronic health condition in all these areas. These are a different and simpler terms for the terms that WHO has used. These were formulated by Can Child Research Center as the F words, the six F words that are used to address child development, and through this model, what we do is it gives us a common language to talk with different professionals involved in the care of the child, and also helps us talk about these things very simply and very easily to parents as well. Influencing each of these areas in turn influences the health condition. If you see, all of these are bidirectional. Sometimes helping the child have fun can also make an impact on the health condition, or helping the child make friendships also makes an impact on health condition. A lot of times nowadays, disability management is slowly shifting towards helping the child to participate more in different areas, because there is a lot of evidence to show that it is directly impacting the functioning of the child in a lot of areas. So there are formalized and systematic methods to do these that are coming up and being used in a lot of other countries as well, and we are hoping that we could take this forward in our area as well and take a more biopsychosocial approach. So does this treatment make a difference? Nothing can be done with childhood disabilities. There is no treatment for it. These are some of the things that some parents have told us, that they have heard these things and they come sometimes to us, sometimes sharing that this is what, and asking questions if this is true. I would like to share a short video on children with Down syndrome and what they were able to do after interventions and after addressing their concerns.
कहीं भी जाते हैं, किसी के भी साथ जाते हैं, किसी के घर में जाते हैं, तो उन्होंने देखा कि साथ में जाने नदी को साथ में जाएंगे नहीं तो नहीं, दुकान में जाते थे, शादी के लिए जाते थे, किसी के घर में जाने का होता तो घर में जाते थे। क्योंकि जैसे जाएंगे तो दो चीजें हैं, बच्चे भी समझ सकते हैं कि बात में और कैसा बिहेव करना है। जैसे समुद्र कितना पड़ता है, तो आपने बहुत सारे काम कर स्कूल में वो पढ़ाई 6 टाइम तो उसमें पढ़ाई होती है, इसका जो सीखने का तरीका है उसमें थोड़ा सुधारना मैथ्स देते हैं टीचर, वो जो आंसर होता है उसको कॉपी करके देता है या ट्रू एंड सही और गलत जैसे
Yeah, so that's our Down syndrome stories for us. And there is so much that we can do with children. It's just that they learn differently, and identifying how they learn becomes the uh, cue for us, and supporting them in the way that they learn. The major differences lie in the learning processes. It may not be typical all the time, and that becomes where we come in. So another myth that is very common is it is better to ask the parents to wait and watch rather than go for therapy. Why this is a myth? Because early intervention and brain plasticity, these are some of the things that have there has been so much research on these things right from 1960s and 70s. There is a very famous Jamaican study which was done over a period of 20 years, following up children who were given early childhood stimulation up to 2 years, 0 to 2 years of age, in different groups, those who were disadvantaged, advantaged, those who had issues, those who had financial issues. And over a after a 20-year period, significant differences in the outcomes, like how they earn, how they do their day-to-day things, how is their mental health, are there any mental health problems like depression, incidence of depression, and OCDs and all. There has been a big impact and a difference in these areas, which was very significant. And uh, that is one of the very well-known study that has shown that brain is very plastic in the early years. That means there are critical periods in the brain development in the first few years of life. For different developmental areas, there are different periods, but most of them lie in the early childhood. And making any influence in this stage leads to reorganization in the neural circuits, and we influence the pruning process that happens during that time in the brain development. Lot of things that we do in that period have long-term outcomes and make a big difference to a child's life. That's why we say, let's not diagnose early, but let's intervene early. Intervention doesn't have any side effects. It's not a rocket science. There are simple differences that parents can do at home itself. And there are a lot of programs that have come up, which can be used even by primary pediatricians in their clinic practice, and give a few strategies that will help children develop in a different way. It will prevent behaviors from coming up as they grow. And there are so many already ready-made, ready to serve on the plate uh, programs that can be used in pediatric office practice. So why sometimes do we ask the parents to wait? It's often, like I said before, the average age of diagnosis of ASD in India is found to be 42 to 55 months, when autism can be diagnosed as early as below 2 years of age. There is always a lag. There has been a lag of 14 to 24 months after parents first start getting concerns. Why is this happening? There are a lot of some of the studies in India as well as in other countries. There has been a study in Gujarat which sort of explored these reasons, and sometimes it is found that lack of screening tools, lack of time in the regular pediatric practice, or lack of sometimes these conditions are so subtle that they may not be obvious when we are in a busy pediatric practice. So what is screening tools actually have been found to be useful. We sometimes may think that screening tools take up more time in the office practice. Rather, we just ask for how is the child doing, what developmental milestones have they achieved. They usually, when we ask directly what is the child doing, is he sitting, the parents may just say no. But if you ask what is the child doing physically, how does the child move about, you get a lot more information from the parents. And then screening tools that help you identify these things make life much more easier for the families as well as for the doctors. A lot of times the word screening actually means that you need to screen each and every child that comes to the clinic, whereas most of the times there is inappropriate use of screening tools, where we had done evaluation. I mean, we had done a questionnaire with the pediatricians, and about 90% of them use screening tools only when they suspect developmental disabilities, not in every child that comes to them, which needs to be sort of changed. And systematizing these practice in pediatric office practice, like using structured developmental surveillance tools, might be really helpful. There are a lot of tools available like ASQ, Age Status Questionnaire, MCHAT, Bailey's screening tools, and PEDS. and which have shown good sensitivity and reliability. But in the new kid on the block is GMCD, where Guide for Monitoring Child Development, which actually uses the recent concepts in child development. And it has been evaluated in the middle income countries as well as in India, and it follows principles of family centered care, where the parents and their concerns and the risk factors that come because of the family background, all of that are taken care of, and it takes about 15 minutes to use in the pediatric office practice once the training has been done. So the training is offered by whoever has made that tool, which may last for about 2 to 3 days, and but after that it's a free tool, and it can be used by everybody once the training is completed. So any of these things, some of these scales require observation, some of these are just questionnaire based. So GMCD is questionnaire based. So yeah, I'm almost done. So in essence, developmental pediatrics is actually the interface between pediatrics neurology, pediatric psychiatry, pediatric social work, pediatric speech therapy, pediatrics occupational therapy, as well as the hospital and community, and between treatment and prevention. And the assessment philosophy has changed from testing children, giving them scores and giving them mild, moderate, severe as a score, and to obtaining a more comprehensive understanding of children's functioning and environment, and acting at different points in the child's life, not just with the child, but with a lot of other factors that are present in their life. And early detection and early intervention help us do our job better. So thank you so much. Learning differences and different learning styles. Let's all I think, honor that. And thank you so much for this opportunity for this. 3 more minutes. So if there are any questions.
Thank you, madam, for the beautiful presentation. Any questions?
Thank you, ma'am, for the wonderful and a detailed presentation. I'd like to request Dr. C.H. Niranjan Reddy Garu to felicitate Dr. Sanashmati Garu. For the next session, let me call upon the chairperson of the session, Vishweshwara Memorial Lecture, Role of Pediatrician in the Care of Underprivileged, Dr. Ram Ganesh Garu, Professor of Pediatric, Andhra Medical College, Visakhapatnam, on the stage to introduce the speaker of this session, please.
Good morning, everybody. It's a great privilege for me to introduce a great speaker, Dr. Satish Ganta Garu. Even though he is a intensivist and neonatologist working in Little Stars Hospital, Hyderabad, we have called him not as an intensivist, but for his extensive work done on the topic of children underprivileged. So we are going to have his work and his lecture. I invite you, sir, to please come out to the stage and start the lecture.
Thanks, Andy.
One second. I forgot to read all these things.
No.
It is my duty. He is a director, neonatologist, and pediatric critical care. Screen. Little Stars Hospital, Hyderabad, CEO of Choice Foundation, not for profit NGO. And qualifications are MD Pediatrics done in 1994 from KMC Manipal, Neonatal Fellowship, Royal Hospital for Women, Sydney, Australia, Bailey Sales, accredited Developmental Pediatrics, -- Australia. Pediatric Intensive Care Fellowship, Sydney Children's Hospital, Australia. Wow. A big wow to you, sir. National SSR NICU Accreditation Program, 2014. National Instructor FBNC Program, 2014. National Examiner Faculty and Fellowship Exit Exams. National Executive Member Development and Support to Care DSC. Foundation for Newborn and Children India. Teacher, IAP Intensive Care Chapter, College of Pediatrics. One of his students, I forgot his name, is telling that he is an excellent teacher and excellent instructor to the PGs. Congratulations, sir.
Thank you, sir.
Welcome.
Thank you so much. So this talk of mine, it's absolutely nothing to do with intensive care. This is something more purely out of passion, and it's something that everybody in the audience can relate to, be it medical or non-medical. So this is something about what we can do as a person for the underprivileged children. There's a lot that needs to be done. And if I can even inspire 10% of the audience, I think na janma dhanyavayindani nenu anukuntunnanu. So at the outset, I'd like to thank Murali, Bhavan Garu, and the whole team of the IAP AP branch for inviting me for this prestigious Vishweshwara Memorial Lecture and Oration. And I thank Ram Ganesh Garu for the beautiful introduction he has given. So, but as I said, this is nothing to do about intensive care, sir. So I would like actually to take your opinion as well as your inputs as to how we can do this better, So yeah, no problem. Yeah. So I'll go through the journey that we've been doing since 2010, last 12 years. And as I said, I'd like your opinion in the way we're doing it, at the same time, how we can get it better. And it's small baby steps. And we intend to finish pretty much all the orphanages in Telangana by the end of this year or January of 2023. But I think with God's grace, we should be able to do it in AP and then move on to the other states as well. So my pitch is basically about the facts and figures, our vision and mission, and what we do at My Child Health, the operational models, and what's the outcome or the impact factor that we've done so far, and what we've improvised in My Child Health Plus, and then the collaboration with the government of Telangana, and what the outcomes are, impact factor of the other project that we've been doing, and then how as a team we've been successful and happy. See, as I was just telling one of my friends here, it's not about what what accolades you've got and all those things. It's how much satisfaction you have at the end of the day. I think that is something that I really am proud of. Okay, so these are the statistics. Can you please correct that? Yeah. Okay. Thank you. So there are about 25 million children born annually here in India. That's 1/5 of the population of the world. And every minute, one of those babies die. So that's a big stat, very, very big stat. And as you know, the under 5 mortality is almost 35 per 1,000 live births. So there's still a lot of way. We all talk about intensive care, gadgetry and everything. That's all fine. It's nice to have those things. But somewhere along the line, our basics have still not been met. So these are staggering numbers, 31 million orphaned and abandoned children as per the UNICEF. That was as recent as 2 years ago. And in that, there are 20 million children, children with special needs and children with disabilities, 20 million. Huge numbers. Okay. And that's the bigger number. But when you come down and break it down to as simple as what Smriti has beautifully sort of eloquently spoken about what needs to be done, things like autism, things like, ADHDs and other things. Children suffering from various psychiatric disorders, close to 50 million. It's a huge amount. If you actually get to starting to treat those children, it does cost a lot of money. But is there anything being done, or precious little? Okay, so the 3 common disorders, and as there's one more beautiful statistic, 75% of children with disabilities don't attend schools at all. So we always boast saying that, yes, we are the youngest nation in the world. Yes, youngest nation in the world, less than 30 years, the maximum population is in India. But beautiful demographic dividend we have, young demographic dividend we have. But what is the future of these children? If we make sure that our demographic dividend is good, then we can secure the future of these children. So that's our mission. We do curative healthcare, where children who are sick in the intensive care, we take care of their finances. But I'm not going to talk about that right now. What I'm going to focus on is only preventive healthcare, preventive and curative from a underprivileged point of view. Okay, so this is the whole gamut of teams that we have. Total, 8 plus 6, 14 plus 7, 21 specialties are involved in the care of these underprivileged children. I'll just go through the details shortly. Now, first, almost 8 years ago, we started a program called My Child Health, where we had precision equipment, we had screening protocols, state-of-the-art software, and then we introduced a program called Psych Screen. So that was done long ago. But there's a lot of evolution because there is no precedent to this. See, we all did our school health camps. Sir, Andron Jesanga, school health camps, we went and we did a lot of this thing. We put the ophthalmology charts. We asked them whether they could hear or not. We all did that, right? But everything was all, and then the next year we forgot what happened with that. What's the progress of those children? How did those children fare in the next year? None of these things, the details, there's hardly any of that there. So what we've done is, no, let us do a paperless system. So that's what we've evolved in the last 6 years. And then later on, we went to another program called My Child Health Plus, which I'll shortly enumerate. So this is the whole gist of that program that we do for the rural health, where we start off with anthropometry vital signs. We add nutrition there. We have optometry, audiology, dental health, pediatrics, and psychology. So this, as I said, I would certainly like your opinion to see how we can add more and make it more robust. But these are the ones we've already digitized right now. And what we do here is, this is a comprehensive master health plan, and we get the precision screening tools into the school or into the rural areas. So they go there with with all the tools. So that is, so whether it's optometry, for example, if it's optometry. So it's not just the ophthalmoscope, the optometrist with the ophthalmoscope, with the refractometer, with the trial lens set, everything, the whole works. It's like that. Now, we have a SOP in place. That means I didn't want the pediatrician sitting in Hyderabad to do different from whoever is sitting in Bangalore. So we had to actually standardize it. It took a while, but we were able to standardize that. Then software. And as I said, everything is every document, everything is entered into the software, and whatever results we've had, we are able to reproduce it. That means what was done 2 years ago, I want to see what is the result right now. So that's what we were able to do. And then this is, Psych Screen is a very, very unique program. I'll talk about that as well. So these are the details if you see. Anthropometry. So what we thought was, what is the standard of care, right? We use WHO charts. Then we go on to IAP charts once they are more than 5, isn't it? So all those things has to be digitized. So the moment, the height, the weight, the head circumference, as well as the demography, that means the age of the child, is entered into the software. The height, the weight, and the head circumference, including the mid-upper arm circumference and the triceps skin fold thickness, using Harpendence calipers, is directly plotted on the graphs. So as soon as they're entered, you see the graphs. So the pediatrician who is already entered, they know whether the child is undernourished or malnourished or stunted or whatever. So right in the field, see what happens, we write the height and go away home. We know that the child is bad. We can't go back to the school and correct it, right? So I wanted to do it right then and there. So we were able to master that. So all the growth charts, we had to digitize every single growth chart. That means we had to take the nomograms. All the nomograms, we took them and then we digitized them. So that was done. The second thing was the blood pressure. We don't have Indian nomograms, do we? We don't have Indian nomograms. We have only AAP nomograms. So we took those nomograms, American Academy Pediatric nomograms, and we fed them into the system. Okay. And even now, how do we know who is hypertensive, right? That means we still have to go to those AAP nomograms, pull out the book. Again, three things. It depends on the age of the child, the sex of the child, and the height of the child. Only three things, right? So based on these three things, we decide which, this thing it falls on, and we want to know whether they are hypertensive or not. So we took those nomograms, we put the demography, and we put all the systems so that as soon as you click the blood pressure of the child, first time, second time, third time, an average of all the three readings, automatically it gives you whether it is normal blood pressure, stage 1 hypertension, stage 2 hypertension, or elevated blood pressure. These are the 4 classifications, right? So our system is able to detect. And if it is hypertensive, we, as per the guidelines, AAP guidelines, we make them sleep for about, or lie down for half an hour and then repeat it. And then if they are high still, then we go forward with the evaluation, as I said, whether it's an ultrasound, urine CV, or a 2D echo. So that's how we go about it. That's the granularity of the whole program, as I'm trying to tell you, is can we do it in the best possible way? That's why I was asking, sir, can you put your thoughts and see if we can make it better, Andy? Now, pediatric intervention, as I said, it analyzes, reports, every single thing. That's our field. I won't spend much time. But as I said, we have a set pattern and it goes about doing that. Dental intervention. So what we've done is, sometimes we might get a periodontist to do it. Sometimes we might get only a dentist. So what we've used is intraoral cameras. So intraoral cameras, they take a picture of the tooth and it is fed into the system. And what it does is, based on the picture of the tooth, it will decide whether it is stage 1 caries, stage 2 caries, or stage 6 caries, and what is the modality of treatment to be done. So that way, we don't want to miss out anything. And it's not only the caries. It's about caries, it's about gingival disorders, it's about fluorosis, so many other things. The next thing was visual assessment and intervention. As I said, we have the whole works. And at the end of the day, we should be able to pick up whether the child has. In fact, we even picked up children with, color blindness. We had Ishihara's charts to pick up whether they had color blindness or not. And then audiology, whether it's pure tone audiometry, autoacoustic emission, every child has either an OAE or a BERA. That's the standard. Everybody needs to get it done. And, I'll share the results with you. Very, very surprising results. This is a challenge. So what I spoke till now, honestly, was only 10% of the hard work. It was hardly anything. It was easy because there was a lot of, precedent to that. We knew what to do. It was so simple. But what's going to come now, it actually took us 90% of our time. That's psychology. How do you get to do that? That was a challenge. So we had an online questionnaire. Okay. So he said, for example, let us see, how can we identify? I mean, in the pandemic, have you all observed that the incidence of psychological disorders have gone up? They've gone up, right? As madam was presenting beautifully, autism is as common as asthma, right? Or if not more common, right? Am I right? Or the other disorders like epilepsy, it's much more causal, much more problematic. But, precious little is being done in diagnosis. In fact, I'll share a anecdote from American Academy Pediatrics. 2016, they've written a beautiful article and they've said 50% of the children in the US, I'm not talking about India, 50% of the children in the US who have been diagnosed to have ADHD, autism, or all the things, by 16 years, their incidence is 1 in 3 children. 1 in 3 has a problem. And the sad story is everybody went through their immunization, their regular clinics, everybody, and everybody has missed them. That's the sad story. I'm not talking about Indian data. I'm not talking about Indian statistic. I'm talking about US statistic. That's the sad story. That's the sad story. And even we are missing them, a lot of them. So how do you pick it up? I said, listen, let us have a questionnaire. So I took the SDQ questionnaire, the Strengths and Difficulties questionnaire. Then with the help of NIMH is Hyderabad, you all know, right? We added autism scale to that. We added ADHD scale to that. We added learning disabilities and ID, intellectual disabilities. And we made a questionnaire which is different based on the age group. Suppose if you say that you want your child to be sort of tested, right? Based on the age of your child, we send you a questionnaire. So you fill up the questionnaire. If the child is more than 11, even the child needs to fill up the questionnaire and your child's teacher. So 3 people fill up the questionnaire, and the software, the tool, it automates. We have about 8.5 lakh responses, and based on the response, the system will tell us whether the child is normal or abnormal. If it's abnormal, then you have to do a detailed assessment. That's the whole purpose. So we want to sieve out the seemingly normal kids so that we can put more effort into the difficult ones. And these are the problems that we screen. So what do we do with psych screen? Anxiety, depression gets screened. ADHD, autism gets screened. Oppositional defiant disorders and conduct disorders, ID, low IQs, sensory processing disorders, and developmental delays. That's the whole thing. And once that's done, stage 2, as I said, then we do the detailed assessment. So the detail where the psychologist sits through, sits for an hour or 2 and does the detailed assessment so that we exactly know what's the final diagnosis. Okay. And then all this, the moment, everybody enters their fields, all the 7 departments, you get an automated health report. My Child Health Report, we get an automated report. So that's what is unique about this. So as I said, anthropometry vital signs, very unique because everything is digitized. Hypertension, all you need to do is enter the number. The system will tell you whether it's stage 1, stage 2 or otherwise. And as I said, there's an accurate numerical and pictorial illustrative childhood psych screening, and everything is WHO ICD coded, mind you. So every disease, whatever, let us say there is myopia. So you have an ICD code. So if the child goes abroad, maybe to China or someplace else where they don't speak English, you know what is the ICD code for that particular child. And as I said, we get a consolidated report at the end with a recommendation for a comprehensive early intervention. So that's the whole thing. So the impact is, as I said, close to 10,000 children and 15,000 and odd children, whom we've sort of treated. So this is a rough snapshot of the close to 10,000 children. We have done this sample from 4 South Indian states, Telangana, Tamil Nadu, and I forget the name, I think it's Pilamedu, and then Yavatmal in Karnataka, and Davangere in, Yavatmal in Maharashtra, and Davangere in Karnataka. So this is the incidence for you to understand. These are both rural as well as urban children. These are rural as well as urban children, close to 10,000. Incidence of visual problems, and 20%. 20%. Kids didn't have a clue. Teachers didn't have a clue. Neither the parents of these children had clues. 20% is a staggeringly huge number. 3.5% of children were deaf. This is a huge number. See, 10,000. So, they didn't know that they were this thing. So all the time, the teachers were scolding them, thinking that, this child was an idiot and he was not answering the basic questions. If the child can't hear, God knows what can, how can they read? How can they, go ahead in their lives? And they didn't know at all. That's a sad story. And no surprises here, 70% had dental problems, 6.5% anemia. Half the children, actually there was a nice divide here if you can see. In the urban schools, half of them are obese. In the urban schools, rural schools only 5%. And hypertension, as I said, what's the number? 3.9%. This is pretty much on lines with the in the West. So that's the hypertension in the West. And if we don't do anything, if we don't pick them up, what will happen? Obviously, they'll have, by the time they're 20, they're going to have issues with the kidney or their heart. And 25 morbidities, and then early mortalities, right? So a lot of things which are preventable. Okay, 3.3% of ADHD and ID and learning disabilities, and the other 3.3 was behavior and emotional difficulty. Okay, so that's the one. And as I said, we work with the government of Telangana. So that is the preventive health care that we have done in schools. Now, with the government of Telangana, they have asked us if we can round up and do something for the orphanages. And schools, what do you say? You can't do more than a certain thing. That means I can advise the parents to get it done, but that's for the parents to get the treatment done. But here we were given the liberty to screen, diagnose it thoroughly. That means very, very comprehensively, and even get involved in the treatment aspect. So this is a complete roundabout treatment that we're going to do. And as I said, this is with the government of Telangana. So what we have done is we have comprehensive approach with rehab plans, and aim is functionality of these orphans or abandoned children with special needs, and disabilities. Now, this was the things that I added to that. What I have said, the 7 fields earlier, this is what we could add. So there are about 14 more departments that went in, include developmental pediatrics, neurology, psychiatry, psychology, remedial therapy, occupational therapy, neurophysiotherapy, audiology, orthotics, orthopedics. Every single child, there's so many children who needed orthotics, and we were able to give orthotics for all these children. Okay, so that is the protocol. So on day 1, what do we do? This is the primary screening that we do, and these are the investigations that we do. For every single orphanage baby, those are the investigations that we do, basic stuff for everybody. Then on day 2, at the end of day 1, we sit down and say, yes, the pediatrician has come up with these set of children who need further care. Let us say nephrology or audiology or whatever is the care. So this is what happens. That's when the other group of people get in and do the thing that needs to be done. And as I said, any child, whether it's a seizure child, EEG, ENMG, whether they need an MRI brain or an ultrasound or an echo. And as I said, we haven't stopped short of, children without a diagnosis, they need to have a diagnosis. The bottom line is, I want a diagnosis. The bottom line is, I want a diagnosis first. Let's think about the treatment later. So we've had close to 100 children, and we have done complete exome sequencing with MedGenome, complete. And we were surprised, the lecture is too small, we can't talk about those things, but so many new disorders. I mean, we didn't know that these many disorders were there. Complete exome sequencing was done, chromosomal microarray and the whole works. This is just a snapshot of how we do in the orphanage. Day 3, what do? We completely give them a digitized report, extensive treatment, whether it's medications, spectacles, hearing aids, orthotic fitments, all done with all the supplements given, and then rehabilitation. So we started the government has started a rehabilitation center in Hyderabad at Sishuvihar. So we assessed we got somebody employed, the occupation therapist, and then we helped them to guide them with the ongoing rehabilitation plan. So we plan to do this across the state of Telangana as well. So as I said, what's the impact factor? Impact factor, for all what we have done, and as I said, rehabilitation and functionality. So we had a set of orphans. Majority of the very sick orphans were there in about 5 to 6 orphanages, and they said, sir, the others are absolutely fine. If you can do only this, it will be great. I said, okay, fine, we'll do what you have requested. So 5 state homes with neurodevelopmental disability. Let us see what the problems are. 50% underweight, 30% stunted, 2.2 were hypertensive, 33% were iron deficient, 60% were vitamin D deficient, 10% vitamin B12, 4.5 folic acid, 10% were hypothyroids. Mind you, these are all, many of them are correctable, right? We all know that. And we brand them as bad. We brand them as, whatever the names that we use. And many of them are treatable. Vision, a whopping 86%, they couldn't see. All we needed was just spectacles. And their, scholastic performances improved. You understand that, right? 19% had hearing aid, need for a hearing aid, 19% of them. 14% with speech therapy needed, 80% dental, 90% had, all the needs of OT, physiotherapy and psychology. 80% of them needed orthotics. Just the orthotic bill was 14.5 lakhs. Just the orthotics bill. MRI, 90% of them, we did the MRIs. And as I said, 90% of them had the exome sequences. So with all the results, I sat with the collector and said, this is what the results we've had, we need to do. And then who said, let us do only this? They said, sir, can we do it for the other set of children? Sorry, 5 more minutes. Can we do it for the next set of children as well? I said, we can do, but you said they were all normal. లేదు సార్ ఇది చూసిన తర్వాత చాలా బాగాలేదు ప్రాబ్లము అక్కడ కూడా చేసి పెట్టండి సార్ అన్నారు తప్పనిసరిగా చేద్దామమ్మా అన్నాను సో దట్ ఈస్ అబౌట్ 200 children. See, underweight, stunted, yeah, okay. So that is again 40% had hearing difficulties. Just like how it was in the rural school health as well, 40% of them had hearing even here. I mean, they thought these children were normal. They thought they were okay. So this is the power of screening. This is the power of identifying early and then trying to intervene early as well. That is our team. And as I said, this is how we do day 1 protocol, day 2 protocol, and day 3 protocol. So within 2.5 days, we'll have the complete workup done for all the things. And this is the plan we are doing from Wednesday. From Wednesday, we are supposed to do 113, but the room can't hold more than 50, 55. So we thought we'll do from Wednesday, we'll start with Sangareddy. And then the following week, we'll do Narayankhed and Medak. That's the plan. But the whole work is we want to do it all over the state of Telangana. And then, God willing, other parts of the country. That's the plan. And this is the budget. Let's not talk about that. And as I said, that's the aim. Okay. So roughly in the school health in the rural areas, for 6 months, they have working days. And the other 6 months, we have pretty much, there's a lot of offs and exams and stuff like that. So in the 6 months, at least 3,000 children per month. 6 3 is 18, that's 18,000. And then orphans with special needs in Telangana, I want to complete that number by the end. That's the thing.
It was an excellent presentation, Satish, Dr. Satish. See, doing such a type of work is very difficult unless you have a passion and interest in that. Everybody of us, our pediatricians, we are all interested in clinical cases. If you see more number of URA cases, more number of diarrhea cases, and you will get some money and all, most of us are interested in that things. And this such type of social work is a very great thing to be done, sir. I appreciate you for doing such hard work. 1 or 2 suggestions, not much.
మీరు ఏమన్నారంటే ఇందాక మనీ సార్ ఇది మనీ రాదు మనీ మనం పొయ్యాలి ఖర్చు పెట్టాలి చాలా ఖర్చు పెట్టాలి
That's what I am telling.
కానీ దీనికి వచ్చిన తృప్తి దేనికి రాదు సార్
That's what I am telling. Unless you have a passion and interest and love towards the children, you can't do that.
You want good sleep.
Definitely.
You want good sleep.
And another thing is, as you told, in the autism spectrum is from very, let us say, if it is 100 marks to the severest autism. Children who are having 10% of the autism are not recognized. They are being scolded in school, scolded by the parents and all. And also in our day-to-day clinic, we'll be seeing so many children. I'll be diagnosing mild autism cases in the clinic because when once the child enters my room, he tries to pull my stethoscope. He tries to pull out those toys and all. He tries to pull out my prescription. So he'll do all nonsense. Parents don't say not to do that. They'll just watching that. మంద కాదు కదా చించేనివాడిని అనుకుంటా. So when I recognize and tell the parents that yes, your child is having little autism signs, they will get hurted. They'll get hurt and they say, so no, my child is just hushar ekku maavadiki, is a very active child. So they don't they don't try to accept
Denial.
the problem.
Denial, sir.
They deny it. So in that aspect, and another thing is, as you were telling, the teachers are also scolding the children, but they do also don't know. So we should, my opinion is, we should start teaching the teachers
Yes.
in the school. So at
How
least
to identify.
once in a quarter or once in a half year, half and 6 months, select some schools and give some lectures to the teachers of that schools, and let the teachers be aware of that. And they should pick up the early cases of ADHD and hearing
And
defects
autism,
and all.
yes.
That is also another thing. Another thing, whatever work we are doing is in urban way. You are uploading this thing, anything. How
Rural.
about the rural people,
Rural.
uneducated parents? How do they do that?
Which one, sir? Oh,
About
yeah,
the
very good question,
uploading
sir.
the
Yeah. So what
data
we
and
do
all.
in the rural areas, what we do is, because they are not digitally savvy,
Yeah.
we have our data entry operators.
Okay.
So they sit with the parents. The questionnaire is so simple. Whatever the parent says, they tick.
Okay. That's
So
fine.
just like how we answer the questions, the parents also get to answer. And in fact, one school, this was in Mehboob Nagar, we covered every single KGBV,
Okay.
Kasturba Gandhi Balika Vidyalaya schools unnai kadandi, KGBV schools. So there, what we did was, our data entry operators and the psychologists, they sat with the questionnaire. So teacher, what is the opinion of these 50 students? So the students started, and then 1, 2, 3, 4, every student, her opinion was recorded in her own this thing, but digitally.
Okay.
So the child's response, the parents' response, and the teacher's response. If you are older than 11.
Okay.
Otherwise, just the parents and the teachers.
That's good. That's good. Excellent. Thank you, sir. Any more questions from the audience?
Thank you, sir. Thank you for such a wonderful and lively presentation. I would like to request Dr. Ram Ganesh Garu to felicitate Dr. Ganta Satish Garu.
Thank you, sir. Thank you all. Moving on to the next session. Now I would like to invite Dr. P.S. Pavan Kalyan Garu, pediatric pulmonologist, chairperson secretary of IAP Andhra Pradesh on the stage to introduce the speaker of the session, APPEDICON 2010, Oration Lecture Management of Childhood Asthma Science with Practice. Let us resume the session. Now I'd like to invite Dr. Muralidhar Reddy Garu, President IAP Andhra Pradesh, and Dr. P.S. Pavan Kalyan Garu, Secretary of IAP Andhra Pradesh, on the stage to introduce the speaker of the session, APPEDICON 2010 Oration, Lecture Management of Childhood Asthma Science with Practice.
I would like to introduce Dr. Somu Shivabalan. Somu Shivabalan is, Somu, it's too long to read his achievements. I'll just tell him he's finished his MD at Kasturba Medical College, then DNB, and then advanced training in Australia in pediatric pulmonology, and he's a visiting fellow, Department of Pediatric Pulmonology. And at present, he is working in Sundaram Medical Foundation, Chennai, and he was awarded Abdul Kalam Scientific Award, Fellowship of Royal College of Physicians. I cannot read, please. Only one thing, he's a very close friend of mine. We are together in MD. before all this, I'll tell you one thing. Don't visit his YouTubes because his YouTube is a marathon runner and does about 20 skips per day sometimes. Huh? So your spouses, if they see them,
Can start. How do I operate this? Kana. Back. Front. Back. Okay. Is the screen sorted out? Yeah. Thank you. Thank you, APPEDICON. Thank you, organizing team. First of all, my thanks to Muralidhar Reddy. We did our PG together. He's my partner in crime those days. And it has been 23 long years. We have met on only 2 occasions since then. And still the camaraderie we share and we exchange has been the same. And it's a real honor to be delivering a lecture in this among this august audience. I am really humbled. And first, I should also place on record my sincere thanks and pranams to my chief, our only chief, mentor, and my guide, philosopher, whatever. He is Dr. S. Balasubramaniam. I think he should be here. He is here to deliver his lecture. And though I got trained elsewhere in many places, it was he who initiated aerosol therapy and others, the knowledge in me. Thank you, sir. And the topic assigned is management of childhood asthma, the science and practice. You might be wondering what is science and what is practice. We use them interminglingly, but they are a bit different. Let me begin with my favorite quote: kill them with success and bury them with a smile. This just tells you that stay focused on your goal and achieve it. That's the best way to answer your detractors without doing anything against them. And one more interesting quote is by our late Prime Minister Rajiv Gandhi. I'm not a congressman, but still, only 15% of, some say 16, only 15% of every rupee spent on welfare reaches the needy. This was on a debate on Panchayat Raj when he was the Prime Minister. You might be wondering what these 2 quotes have to do with asthma. So even in practice, whatever science say, only something around 15% or 20% reaches the real practice. Real practice is not the people gathered here. There are many more who are practicing outside. That's what I meant. There is always an arm span distance between the science and practice, knowingly or, and sometimes only if this 15% or bits and pieces reaches the community, it will be catastrophic. So that we have to say, for example, the same quote, if it is being taken as kill them and bury them, imagine how it would be. And if it is taken like kill them with success and bury them with smile, without the context and concept being known, if it is read by a weak mind terrorist or a criminal, they'll be taking in the way of their convenience. So that's how the science also plays. We always have a finger pointing approach, the scientists and the practitioners. What the practitioners feel is science is by a bunch of people who don't practice, who are there to dictate to us. Whereas with regards to scientists, what they think is practitioners are a bunch of fools who don't follow any science. So actually, each of us should be complementary. Actually, we are fighting among ourselves, though not physically, at least by the thought and frequency. So actually, it is a hand-to-hand approach or a complementary approach. Actually, practice is nothing but repeated experience. And when it becomes evidence-based, that becomes science. And actually, science is evolved from practice. Though we think practice comes from science, science is evolved from practice. So for the science to get incorporated into the real practice, you need to convince people on proper understanding of what it is and why it has to be followed. Just by giving guidelines and strong statements will not work. They have to know the concept behind. So this is the history of inhalation medicine. This has been since time immemorial. Even during Charaka and Sushruta time, they used to smoke datura, datura chambers were kept for people who had breathing difficulty. Whereas what science tells us is only in 1778 the inhalers were used and inhalers were invented. In 1955, the Riker company started doing the compact inhalers. That is because his daughter was suffering from asthma and mothers of all intervention and inventions. So with regards to research, science, or anything which we come across in the day-to-day life, what happens is first is awareness, that leads on to acceptance over time. When we are convinced, it becomes adoption into our day-to-day practice. With regards to the research and evidence that reaches clinical practice, data says it takes around 17 years for it to get translated. 17 is a whole lot of time. The generational change can happen by then. So how and what we do to concise that gap, meaning we have to explain the background, convince them so that they accept and start agreeing on it. There are a lot of dilemma with regards to asthma. This is the proper topic. Lot of dilemma with regards to asthma. Children, they don't get heart attack. Children, they don't get hypertension. Children get asthma too. And then thought of preschool work children superior, inferior. Its relation is not of use. The moment we say always to explain all this time constraint, we say, okay, next episode we'll see, and everything goes for a toss. So I'll be focusing on a practitioner's point of view on what we are going through in day-to-day practice. So can young children have asthma? Yes, asthma is an inflammatory disease. It's an airway disease. Everybody right from birth has airways. So when you have airways, nothing prevents them from having inflammation. So naturally you can have asthma irrespective of age, provided younger the age, you think in terms of alternate diagnosis, have a phenotypic approach, though the treatment might remain the same over the period of time. Don't keep waiting endlessly. You can label them as asthma. That is your current understanding. So now we have to know that it is an inflammatory disorder. That is important. Underline the word inflammatory disorder, and it causes recurrent airflow obstruction. So what are the clinical manifestations of airflow obstruction? Symptoms wise, we say recurrent cough, wheeze, breathlessness, activity-induced symptom, nocturnal cough. The moment we say each one have their own qualifiers, it is not nocturnal cough means asthma. So each one have their own qualifier, but we take only in bits and pieces. Are you coughing at night? The moment they say yes, put on asthma as a diagnosis. So there lies the problem. So when they say recurrent wheeze, the real wheezer will fail to accept that he is wheezing. Whereas a person who is not wheezing, the mother will come and say the child is wheezing. So this is a common problem. So all the things which they say, if the parent complains wheeze and if the child is comfortable, it is unlikely to be a wheeze, it is likely to be a conducted sound. So if the child is not disturbed, parents are disturbed, the sound is there, then probably it might not be a wheeze. It can be something like a snuffle, rattle, strider, or a snore. So now with the age and advent of smartphone, ask them to record and show them what they feel to be the wheezes. And you also have a quick observation of what they say and what you think whether it is the same or not. So careful examination is important. Now the activity-induced symptom. Previously we said play-induced symptoms. The moment we say play-induced symptom, the question arises, how will small children play? Meaning less than 1 year play. Now it is activity. Activity can be exercise, it can be playing in younger children, crying, shouting, laughing, and also on giggling. If they have symptoms during that time, then you have to be careful. It need not be always a caveat. Children who are not climbed even 4 feet of stairs, If they do it suddenly, they can have breathless. So immediately we should not be labeling it as asthma. That is something to do with their fitness level, or sometimes even open mouth breathing. Naturally, what happens, the humidification aspect of your nose goes off, so the dry air can irritate. You can cough. Immediately, you need not say as a activity-induced symptom. So you have to have your clinical distinction there. The moment we keep asking, playing, in busy clinic, we ask, is your child playing well? The mother will say, he keeps playing with his friends for hours, doctor, but he's comfortable. So immediately say, no activity-induced symptom, it is unlikely to be asthma. When you see what he is playing, this is what it is. But that's what the parents will say. He keeps playing with his friend. With his friends, yes, always he is happy. He plays with his friends. We have a league of smartphone players like football players and volleyball players. We have to be careful on that. The other thing is recurrent cough. Anything we ask them will be recurrent. They would have come yesterday, they will be coming today. They will be saying cough is there on and on. Or they will say, since last month, the child has cough. More a month, the child has cough. What would be there is, February 1st, they would have come, the cough would have started on January 30th. So hardly 2 days, but in a busy clinic, they'll say, from last month, almost a month, doctor. So we also get carried away with the flow. So recurrent cough, try to qualify them. Usually ask them, what do you mean by recurrent? Immediately they will say, right from birth. The child will be 12 years. Then you ask them in 100 days, how many days the child has a cough? They will say definitely 20 to 30 days. So that cannot be from birth. So to counter check yourself, then you ask in 100 days, how many times the child doesn't have cough? Then if they say 80 and 20, then you can be pretty sure of whether to go by the history or not to go by the history. Otherwise, it is always confusing. Most of the recurrent cough is because of recurrent respiratory infection that cannot be wished aside. And here the recurrent cough meaning isolated cough, and most of the time it's a dry cough. If it is a moist cough associated with other signs and symptoms of respiratory infection, very unlikely to be an asthma per se. Of course, your infection can trigger a wheeze. Since because the infection had triggered a wheeze in you, it doesn't mean all infection is going to trigger a wheeze again and again in you. So that distinction should also be had in mind. The other thing is nocturnal asthma. Imagine ourselves, all our cold and cough, the more cough will be at night, any infection, because the nose gets blocked when you lie down, the postnasal drip and the phlegm gets stuck to your throat. Naturally, you have to cough to clear. So any allergic rhinitis or any non-allergic rhinitis or bacterial sinusitis, the postnasal drip is what causes your nocturnal cough. That you have to be very careful. So just because they keep saying nocturnal cough, immediately don't label it as asthma. The other common excuse we say is cough variant asthma. This is a very viable alternate excuse to put them on a medication. So in between they said, don't go by this term. Then again, the term has come into way. And now they say, whatever you label them, at least once there has to be a physician documented wheeze. So that is important. So cough variant asthma here, you have to know it is chronic dry cough. So immediately 2 days cough, night cough, immediately you cannot call it as asthma. It is a chronic cough. Chronic cough by definition, various definitions are there, anywhere between 4 to 12 weeks. So ideally at least 4 weeks you have to be coughing. It has to be a dry cough with no other qualifiers for any other disease, and there should not be any cold or sneeze or anything like that. Then probably for want of anything, time being, you can call it as a cough variant asthma. The other common excuse we say is, we gave this medicine, it got better. So we keep giving that medicine. So that therapeutic trial, sometimes it takes you for a ride. Why? Because most of the thing are self-limiting condition. Parent always believe only when you give a medicine, it gets okay. They say when you give the medicine, it gets over in 2 to 3 days. If you don't give a medicine, we also feel it takes around 48 to 72 hours. It is almost the same, just that the perception is different. So don't go by that belief that it was given, it got better. It could have been because of that. It need not be because of that also. So that distinction has to be taken. What is the risk factors? The moment we say risk factors, lots of things are there, but commonly we talk about the genes, family history, and also the history of allergy. Now we know like in parliament, 2/3 majority, if it is there, this gets passed out. So of the three, genetic, environment, or viral infection, if any of the two keeps hacking irrespective of the other, still you can manifest as asthma. So a person, even without a family history, because of the environment and recurrent viral infection, can itself get induced and transformed into an asthmatic. That has to be had in mind. And with regards to atopy, now we know a person who is wheezing and continues to wheeze with no other reason, even without atopy, is called as a true asthmatic. When there is a history of atopy, it becomes an atopic asthma. So, presence of family history and atopy is a risk factor. Yes, definitely. But absence is not a protective factor. That much you have to know. Immediately we'll say, oh, in my whole family, nobody had, as if it's a curse. So it's not a curse. Let them not worry. And if it is not there, it doesn't mean it should not be there. Can anyone say, my whole family was poor, so I will not be wealthy? They will not accept that. So family history is something like wealth. It can be a precedence. It may not be a precedence also. And now let's get introduced to something called epigenetic. Epigenetic is genetics might not change. Genetics will remain the same, but the manifestation of the same genes will vary over time. That's a modified expression of the same gene because of the environmental influence is epigenetics. It's something like this. The cat will remain a cat, but it will appear as if it is a lion, though it might not have changed itself to a lion. This is epigenetics for you. And when to investigate? In clinical practice, even in referral practice, asthma is a clinical diagnosis only. Investigations are reserved to diagnose mimics, comorbids, and in real difficult situation, sometimes even to convince parents that it is asthma and nothing else. And most of the time we do TCDC, ESR, put around here and there, and we call it as something else. So it is not so. If a MAN2 is positive, it just tells you it's a TB infection and not asthma. And ATT is only for infection and treatment of tuberculosis. And increased eosinophils or the skin test being positive or the RAST or IgE, they just tells you that is an allergic tendency and an allergic sensitization. That doesn't tell you it is causing the disease, provided there is a clinical correlation to that. And most of the time, the heterosan or the diethyl carbamazepine, eosinophil 8% and diethyl carbamazepine is given. Diethyl carbamazepine, it is an anti-filarial drug and not an anti-eosinophilic drug. In filariasis, eosinophil can get elevated. So when you give heterosan, that comes down, and it is not an anti-eosinophilic drug. That we have to understand. Everybody will come with an X-ray and say, oh, my doctor, they said asthma, and the X-ray is also normal. As if they are doubting the doctor, they will complain to you. X-ray, you cannot find out asthma. It can be normal. Sometimes there can be infiltrates here and there. And sometimes they are misdiagnosed as pneumonia also because of all these infiltrates. This so happens in younger individuals. Why? Because of the normal developmental process. The pore of Kohn and the pore of Lambert, that is the intraalveolar and the alveolar bronchial connections, are not well developed in children. They take around 3 to 4 years to develop. So when there are no collateral airway circulation, that predisposes them to stagnation and collapses. That's why this Pond-Spitted sort of pictures, which we call it as a bronchopneumonia, comes into vogue in small children when an X-ray is taken for a wheeze or whatever, or a respiratory infection. So that we have to have it in mind. With regards to treatment, when do we treat? We treat acute wheeze, that is sure, because if you don't treat, the parent makes sure that you treat them. And recurrent wheeze, of course, at least the acute component is treated. Nowadays, to some extent, your controller is being treated. The confusion arises when you get the first wheeze. First wheeze is always a confusion, more so in younger individual. The moment we say first wheeze in younger individual less than 5 years, we say and we vouch and we stamp it as bronchiolitis. Most of the time it is right. and it need not be always right also. The first episode of wheeze can be a bronchiolitis, can be your viral induced wheeze, can be the first episode of your asthma itself. Imagine the history, all the histories of asthma most of the time when the resident presents to you, they will say recurrent wheeze, first hospitalization at 2 years for bronchiolitis. So that would have been the first episode of the asthma in that particular child. So that we have to have it in mind, because bronchiolitis is inflammation of your bronchioles. That is a pathological diagnosis. I have never seen a bronchiole so far. Most of you are. So it is just the histopathological correlation with the clinical manifestation substantiated to it is bronchiolitis. So that what they say is URI leading out to signs and symptoms of LRI in child less than 2 years of age with no other obvious cause for the same is considered as bronchiolitis. So this will fit in with anything. So that we have to have it in mind. With regards to bronchiolitis, it's the lowermost area where bronchioles meaning they don't have the cartilage. So that is the only thing. Here the wheeze is because of airway narrowing, because of inflammation, and not because of bronchoconstriction. So what is the role of bronchodilators in this? Infant who presents with wheeze, even young children, more so if they are with moderate and severe wheeze with respiratory distress, give a trial of bronchodilator and see. Then only we know whether they are responding or not. See if there is an objective improvement, wait for 1 hour. If there is no objective improvement, graciously withdraw, call them as bronchiolitis and no, don't give. And if they are having an improvement, please don't label it as bronchiolitis or not give anything. So be careful on that. And the published results are variable and the efficacies of drugs are uncertain. Why? Because all these interventional studies, it is very difficult to differentiate between all the 3 causes of bronchiolitis, wheeze and viral induced wheeze and asthma in the first incidence. That's why all the studies, varying results are there. We don't have a long time follow-up of all those studies, what has happened and who had given the results. So that's the problem. So role of bronchodilators, even in young children, trial of bronchodilators with careful monitoring, watch for objective improvement, and if it is improved, give it on an SOS basis. And now the question arises, do young children have beta-2 receptor? Invariably, the answer would be, children don't have beta-2 receptors. Some lies are being told for ages and ages, and we also keep believing that. Previously, it was told so that children don't have beta-2 receptors. Now it is proved beyond doubt, children have beta-2 receptor. It is something like saying infants are obligate nasal breathers. Actually, they are not. They can breathe through the mouth. So it is no more obligate nasal breathers. This is also the same. People have beta-2 receptors. Just to know a bit about your airway, the difference between bronchus and bronchiole is only the cartilage is not there. But whereas the airway smooth muscle is there right across except in the air exchange area, and your beta-2 receptors are only in the airway smooth muscles. So it is nothing to do with the cartilage. So even bronchioles have beta-2 receptors. But the thing is, the nebulized or your inhaled bronchodilators don't reach beyond 14 generations. And all your problem happens below that, and it is not the bronchospasm. That's why in bronchiolitis, it doesn't help. Right? So it is not that it will never help in young children. It's just that if it is real bronchiolitis, it will not help. If it is not bronchiolitis, if it is something equivalent to bronchospasm, then probably it might even help. The other question is tachycardia. Children have a much higher heart rate than you and I, right? Even at 4 years, they say the heart rate is around 100. So when a child cries, screams, or look into our face, definitely it is going to have a bit more of heart rate. So the moment we say tachycardia, we should not be saying beta-2 receptor, beta-2 agonist will cause tachycardia. So already the child has tachycardia. We should not be giving. We need to have some caveats there. Be cautious if it is only isolated tachycardia, disproportionate tachycardia, or in a child with hemodynamic instability. Why? Because if it is something like a cardiac asthma, meaning if it is because of a cardiac failure, you have here a wheeze. When you give a bronchodilator, further congestion, further VQ mismatch, and further deterioration will happen. Otherwise, nothing is going to happen. So if it is tachycardia, it can be because of anxiety, hypoxia, and also various environmental conditions. And if you feel the child is fit enough and not contraindicated, you can always give. And now the Westerners say, give it in a comfortable and unthreatened manner. We take only that, comfortable and unthreatened manner. If it is comfortable and unthreatened manner, how it is, nobody has an idea. And we also get confused, crying child. They say airway resistance increases when the child cries. So airway resistance increases, so the delivery will be less. Yes, of course. Instead of giving nothing, at least something goes in. So you have to give. Crying is not a contraindication. The child is not a child who is wheezing and hypoxic is not going to smile and say, now come give. So you have to find a clinical distinction when you are going to give or not to give. This is unthreatened manner. This is what people, when they interpret as unthreatened manner. Child will be crying, granny and mother will be talking, and like a table fan, the spacer will be going here and there. Whether it will, the medicine will go by Wi-Fi, I don't understand. So it definitely doesn't go by Wi-Fi. So we have to tell them certain things have to be done in a certain way. So if not, just by underlying the word unthreatened, it will not work. Even the nebulizer, it will be the whole room will be nebulized, but for the child. So that we have to, and it will be like insecticide. Everywhere bush sound will be there, and the child will be crying the other side. So that we have to say. Most of the time they say, we gave nebulizer, it didn't work. It may not work also, but see if it is given properly before saying it is not working. So that we have to have it in mind. The other confusion is oxygen-driven nebulizer. The Western people told oxygen-driven nebulizer. Why? Because occasionally this can cause increased risk of arrhythmia because of hypoxia, paradoxical VQ mismatch, and these things can happen. This will be in 1 in a million or 1 in a trillion. I am not denying that. Just because that everybody threw up that compressors. It is good in a way because we have to go with your spacer and inhalers. Why? Because here everybody gives with a oxygen-driven nebulization, and the concept of oxygen-driven nebulization is that much of power should be generated to deliver this aerosol. For that, you need anywhere between 6 to 8 liters. Most of the time, when you put it 5 liters and more, that nebulizer thing gets snapped off. It will keep coming 2 times, 3 times. The nurse will connect, and then she will bring down the flow rate, so it doesn't get snapped off. So it now becomes not a nebulizer, it becomes a agarbatti therapy. Sound will be there and nothing will come by. The effective delivery of the drug will not be there, and the response also will not be there. So that we have to have it in mind. So we can have an oxygen blend thing if we abundance of oxygen, because 8 liters for 15 minutes, imagine it is almost 120 liters for nebulization. So how much of oxygen are we wasting? So that we have to know the concept. It can be oxygen blended nebulization. Whenever where possible, use a spacer. Otherwise, if the child is hypoxic, definitely it is oxygen needed, but it can be oxygen blended. To the side port, put 0.5 to 1 liter, and then go off with that. And in practice, what happens is most updated. I'm not trying to find fault with anybody, but we are confident. Though we are ignorant, we are confident. But some of us read. What happens is our confidence goes up. We get confused. Why? Because we are not Englishmen or the English-speaking people. We tend to read only the abstract and the end result and the author's comment. It will be written, not routinely recommended. Whether it is recommended or not recommended, we don't understand. Not of much benefit. Whether it is benefited or not benefited, nobody knows. Not so uncommon. Whether it is common or uncommon. So we get to confuse and we take it in the way we expect it to be. So that is the problem. That's why we have to have, and whether we understand or not, if you are interested, just go the text and the content of it. Then the question arises, why do we treat? Previously, it was called a preventer. Now we know you cannot prevent, they called it a controller. So control the symptoms and have a good quality of life. People think that when you start an inhaler for a proper reason, you should never get anything, any problem with your nose and throat, like cold, cough, nothing should come your way. So it is not so. And people also think it will prevent future development of asthma. That again is not so. Then we gave a scientific defense saying that airway remodeling. What is the model of the airway? Nobody knows, but we said airway remodeling will be prevented. We kept harping on that. Now we know even that is not the thing. What happens is you will have and start to have it early in your life, irrespective of you manifesting any symptom or not. And it is not eradicated even on giving good anti-inflammatory for the reason, and may proceed even before you know you are an asthmatic. And it is demonstrated in children who had outgrown asthma. So overall, what they say is inflammation and remodeling is like a railway track. One line is your inflammation, other line is a remodeling. If it is to happen, it will happen. I cannot predict, you cannot do much about it. What you are doing is, if you are having asthma symptom, treat that and go with it. It's like wearing a specs. If you wear a your eye will not get corrected, but still you have a good quality of life. So your inhalation therapy in asthma, it's much of understanding. If the parents get to know, they might get convinced on this. And how do we treat? If there is going to be a ear pain, we will say it is otitis, acute otitis media, and prescribe antibiotic. And the mother will ask, pain is here, why are you giving medicine in the mouth? Put something here, whether you are going to give ear drops or I will put some oil into it. So that's what they say. So when eye problem, naturally you allergic conjunctivitis, if you give them antihistaminic, they'll say eye drops. So ointment for skin infection. With regards to aerosol therapy, because of the airways, if you give them aerosol, they'll say, why there is problem here, why are you giving medicine here? So give something by mouth. That's what they ask. So you have to tell them it's an airway disease, direct action, immediate action, smaller dose, and less of side effects. So that much of understanding they have to. And what is the next question arises, can small children have nebulizer? How can a small child have an inhaler, doctor? That is a common question they'll ask. Will my child cooperate? Will my child be able to take this? So the child need not take all these things. Only thing you have to make sure you have to provide an appropriate device so that that goes in. Younger children with MDI and spacer and mask. Slightly older children, you can take about the mask. And most of the time, what will they do is, older children, they will either take both mask and the spacer, or they will take out the spacer, mask and direct inhaler they will give. So that we have to see how they are taking it. The idea of giving MDI with spacer is the delivery is much better rather than taking with your MDI alone. That's one of the versatile device. And always they will say, my child has grown up. Why spacer? They'll say, child has grown up, doctor. He has started going to school. He is going by his own bicycle. He is independent. So why is a spacer required? Spacer is not a walking stick or anything. It's just a holding chamber so that the local side effects are negated. The drug delivery is much better. Hand-mouth coordination is not there. So overall is a much better device rather than giving your MDI all alone. And the next thing is, when is the face mask required? The Westerners, previously they said 6 years, then they came down to 4 years, now they came down to 3 years. I'm not blaming the Westerners. Westerners meaning most of the studies are from there. So now the moment they say third year, the postgraduate in the emergency medicine will say, your child is 4 years, why are you giving it spacer? Take it out. So it's not the age that matters. Even your old granny and grandpa will not be able to take a spacer with a spacer without your face mask. So you have to hold by your teeth, seal by your lip, breathe through your mouth. So all these understanding and execution of that, though it looks simple, it is to be executed. So if that much of understanding the child has to execute, then you can do, irrespective of age. Otherwise, if a 5-year-old child is not able to do that, Initially, SPART is a mask, and then over time, if the understanding improves and the execution is better, you can take out the mask. Don't go by the age definition also, though they can be a guide to you. And the drugs are, as I said earlier, previously called preventer, now it is called controller. We know we cannot prevent, it can only be controlled. And the reliever controller dilemma always existed. And now the oral bronchodilators, we too prescribe, I too prescribe, but not in a majority. The amount of oral bronchodilators have come down significantly because older bronchodilators, what happens is, in West it is not available, over the counter it is not available. There's a smaller onset of action and the more side effect. And as a practitioner, what you should know is, more than 3 times if a bronchodilator is prescribed in a year, that itself becomes a recurrent wheeze, and that itself is warranting your controller therapy in strict sense. And most of the time, we keep prescribing bronchodilator without knowing there is a bronchodilator component to it, because it will be written for wet cough, for dry cough, and the component there will be your levocetirizine or your terbutaline. So that we have to have it in mind. Aerosol, as I said, it is a direct, smaller dose, rapid action, and minimal side effect. The moment we say inhaler, they'll say, oh, inhaler in this young child. As if we are given a death sentence, they'll be cribbing and crying. So we have to tell them it's like previously we all went by bullock cart. Now we are going by performance car and whatnot. So it is something like that. It is evolution of your delivery of drug, and it's not a curse in them. That we have to have it in mind. And they also keep talking about addiction. Is it an addictive device? Have you seen any child cry for the inhaler therapy in the morning? Amma, give, otherwise I will die, I will die. No, if that be so, then the complaints would have been much better. I always tell them, inhalers are something like brushing your teeth. We are brushing right from younger age, knowingly or unknowingly. Have you got addicted? Yeah, no. So this also doesn't make you get addicted. You have to tell them that way. And I don't remember seeing anybody crying for this medicine, tossing around for this medicine. Real wheezes, yes, for bronchodilator and the relief, they might cry, but not for this controller medication. So first we have to get convinced it is not a addictive medicine. And with regards to the cost, of course, it looks a bit huge. And then after COVID, people got used to the cough. Even yesterday, somebody was telling, and now this few hundreds this way and that way, they don't bother much. But overall, it looks a bit costly. But the emergency visits, admission, medication, of course, your doctor fees will be the minimum in it. The transportation and the amount of man-hour loss and the stress we go through also significantly comes down. So that we have to have it in mind. And now people will ask, why long-term controller therapy when my child is asymptomatic? My child is fine. Why do you want to medicate my child? That is the question. The answer is, asthma is an inflammatory disease. So a baseline inflammation is always there. We are trying to address that baseline inflammation. And the baseline inflammation need not be always symptomatic. When they are always symptomatic, then it means significant inflammation is there. That itself is narrowing. But when it is not significant, some amount of inflammation is there. When there is a trigger in the form of allergen or a irritant that goes in for bronchoconstriction, that produces an exacerbation. That only you get relieved with your beta-2 agonist or your bronchodilator. So the baseline inflammation has to be taken care of. That's why you are also having now and then exacerbations. That's why even when you are normal, you take care of that. So aerosol therapy, when more than the drug, all these things, technique and all have to be emphasized. And contraindication, people always say that how will a small child take? What is the contraindication for bronchodilator inhalation therapy? When there is an indication, always there is a contraindication. Does it have a contraindication? Yes, it does. The only contraindication, absolute or relative, is a child not breathing. If you don't breathe, whichever way you give, it doesn't go in. So any child breathing, you can give aerosol therapy, meaning you have to find an appropriate device in place so that it works. And uncontrolled asthma, the moment you say uncontrolled asthma, last time night cough, this time night cough, immediately we keep increasing the dose of your steroids. That's what happens. After a point, we don't know how much to increase. It will be on the maximum dose, 2 puff 4 times, this, that, and all, and nothing will work. So they are also fed up. So remember this number, less than 12 years, don't exceed more than 400 of budesonide and fluticasone more than 200. And older child, budesonide 800 and fluticasone 500 per day. So 800 and 500, have it in mind, irrespective of age, don't increase these dose. Beyond this, initial increase in dose, there is an increase in response. Or the dose response curve doesn't keep increasing endlessly. Over a point in time, it plateaus off. Only the side effect keeps increasing. That you should know. Supposing if I'm having a Maruti 800 and Reddy has a BMW, I cannot be racing Reddy with my Maruti 800 just by pressing the accelerator. So by increasing the dose of steroids, we cannot always achieve control. We need to see if your diagnosis is right or everything else is right. So don't keep increasing the dose of steroid alone. So when there is uncontrolled symptoms, see if the diagnosis is right, see if the drug you have prescribed is right, and if your prescribed is right, see if the drug which they are taking is right, and the dose is right, device is right, and the delivery is right. We'll be always asking, are you pressing like this? Are you shaking? Are they taking? They will say everything, yes, yes. Ultimately, when you see how they are pressing, who is shaking and who is taking, it will be totally different. What will happen is they will be shaking, and where is the child? Where is the child? The child will be playing there. Then they will come, they'll give the medicine. Pressing is okay, medicine is okay, and child is okay, technique is okay, but they have pressed almost some 30-40 minutes back in stretching the child and thinking that the medicine is still inside. Medicine is inside, but the medicine is gone for sleep. So that we should have it in mind. And there are two more things. Always look in terms of comorbid that I'll touch upon later. And always there is a end list. Immediately we say asthma, they will ask what to avoid. What to you say this to give, they'll say, that is okay, doctor, tell me what to avoid. So, and parents who are casual, I also tell, asking such questions has to be avoided, I will tell them, but some will not like. And there are two things, irritants and allergens. Irritant are anybody it irritates, like your smoke and other things. Here, you can have an avoid list. Here, it is not genetically predisposed. It is not immunologically mediated. Whereas with regards to allergen, they are immunological mediated. Some extent genetic predisposition is also there. So for an allergen, you cannot give an avoid list. I am strictly allergic to brinjal. I cannot be saying you don't eat brinjal, you don't eat cauliflower. How can I say sweet chocolates, everything they label, and avoiding sweet? Yes, fine, you avoid. Next time they will come with something. He ate ice cream, no. So if the list keeps going on and on, probably what they are targeting is not right. That much we have to tell them. If you target it right, you should not be getting it again. So that distinction has to be there. The general avoid list can be for irritants and not for allergens. Allergens that will be specific based on the history and how they manifest. And with regards to comorbids, we all know the moment we say for comorbids, we say allergic rhinitis, GER, and VCD, and what is one more? Commonly, we say these four. There are many more comorbids. The problem here is comorbids can be the cause, they can be an effect, or they can be an independent bystander, or they can contribute in some way. So the bottom line is, if you find any comorbids, irrespective of whether they are cause or they effect, you have to treat them. So that have to be had in mind. The moment in this picture, imagine, if we see the big Emirate flight, even in this big picture, the smaller ones will get missed. Whether you miss it or not, it is definitely there. So the comorbids always have an effect like this. We tend to the parent would have come to you for wheezing, we'll be asking for sneezing. They'll be wondering what is wrong with this doctor. I'm talking something, he's asking something. And you'll be saying, give a nasal spray. They'll not be convinced. They say, I'm having cough. What has the nose to do with the cough? So this is a common thing. Then we also think, why bother all these things? We will see next time. And next time, one more exacerbation, they go to one more doctor. So that is the problem. And most of the time, the common comorbids have been understood, but the obesity is not been accepted as a comorbid at all. Obesity is a sign of prosperity, according to the parent. Even then, they will say, my child is not eating. right? If they say a small lean doctor, even the parents are not convinced. Wow, he's been starved for practice, I think. That's why he's not a good doctor. That's the impression they get usually. So now they say central obesity, Madhya Pradesh. So if the central obesity is more problem than your general obesity, and the obesity precedes asthma, all your allergic manifestation is worsened by your obesity, and your response to the steroid is also very less, because the phenotypically it is not a eosinophil induced inflammation, it is a different ball game altogether. So that we have to have it in mind. The other thing is smoking. The moment we ask for smoking, invariably to the father, they'll say, no, in our house, nobody smokes. I smoke, but not in the house, only in the corridor or in the balcony or in the toilet, as if that is in an outer space. So everything is in the same only. Previously, they call it as active smoking and passive smoking. Now they say first hand, second hand, and third hand smoking. First hand smoking is the eye smoking, so it is first hand. Second hand is eye smoking, Pawan being by the side, he becomes a second hand smoker. Third hand smoking is I and Pawan smoke, and we both go out of the room, and the reddy comes in and he is having the effect of a third hand smoking. So this is first hand, second hand, and third hand smoking for you. So now they say first hand or second hand or third hand smoking, the effect is almost the same. It is not the smoke that creates the problem, that's the irritant in the smoke and the smell that generates in that room. They say smoking room and non-smoking room. The moment you enter the smoking room, you know is a smoking room. That itself has an effect of a third hand smoking. That have to be had in mind. Here again, it is a phenotypically different thing. We think South Indians, not many people smoke. You are wrong. Many people smoke. And even school-going children, many are smoking. So that the history has to be taken diligently and also with some delicate handling. So that without, it is like pouring water and also pouring oil, giving inhaled corticosteroid and also smoking, nothing is going to work. Which aerosol works which way, nobody knows. So that we have to have it in mind. And with regards to controllers, that is your Montelukast and also inhaled corticosteroids, they are controllers for your airway inflammation, and they are not for all respiratory symptoms. Recurrent cough cold, going to school, getting cough cold, those things and all will not be helpful, and it is not an infection preventer or infection controller medication, and doesn't work for all recurrent and persisting respiratory problems. That we have to have it in mind. And the newer developments is your spacer. Spacer therapy is good, effective, easy, cost effective. Nebulization, they all are comfortable with the nebulization. Spacer, how will it take? Nebulization, when you can hold it for 10 to 15 seconds, 15 minutes, why can't you give it properly and effectively for 1 to 2 minutes? So it's a question. So that much of convincing and making them understand is important. And most of the time, I teach them inhalers even in acute exacerbation, and ask them to wait in the waiting area and give it. So one is not a publicity for me. Even people around, whether they are involved or not, they will also have a look on it, and they will get convinced that this can be given. This is not harmful. This is also effective. So that they act as a brand ambassador. If somebody else is doing and scared, they'll say, no, I had seen small kids having, and they are doing fine. So that much of thing can be done. And anywhere between 3 to 4 puff is equivalent to almost one nebulization if given properly. And every 20 minutes also it can be repeated, and they can be continued. The only absolute indication for nebulization will be very sick child and child with hemodynamic instability and hypoxia. If these things are not there, definitely a nebulizer would equally work in situation. And now the question is smart therapy. Smart therapy is single maintenance and reliever therapy. Previously, we kept saying that giving steroid and inhaled steroid in acute exacerbation is a quackery. So though we didn't say it in that harsh terms, we almost said that. And now they say any acute Vs also give steroids. The moment we say that, naturally the practitioner will say, we know previously they said no, it is all pharma gimmick. They want to promote the medicines now. So that is the natural thing they will remember. So now the GINA guidelines have also told more than 6 years it's MART therapy, and mild asthma, they have removed the distinction like mild intermittent and mild persistent. They say any child with recurrent Vs are prone for severe acute exacerbations also. So to bring down, either you give SOS of inhaled corticosteroids during exacerbation, or make it as a mild persistent form and give a regular controller therapy. That's why I told you more than 3 times of bronchodilator in a year, even oral bronchodilator for a proper reason, if you believe so, that itself brings a caveat or your criteria for controller therapy. So why anti-inflammatory reliever therapy? The MAT therapy is nothing but anti-inflammatory and reliever therapy. The exacerbation pathophysiology, if you see, it is characterized by inflammatory and airflow limitation. That's what I told you. So inflammation is also there, airflow limitation is also there. The SABA alone, that's a short-acting beta agonist, takes care of your airflow limitations, and that will take care of your bronchospasm, but no anti-inflammatory effect, right? And the late effect or the late phase inflammatory response is also not been taken care of. Acute phase inflammatory response is what you see. And after 24 to 48 hours, even up to 72 hours, you have the late inflammatory effect. And that SABA doesn't do anything. So the regular use or frequent use of SABA, they say more than 3 canister in a year. I would rather say more than 3 episodes in a year. Worsens or delayed inflammatory phase response, nothing is done, and causes increased bronchial hyperresponsiveness. So the chance of you responding much more severely in future episodes and you not responding in the way you have responded in the past is also increased multifold. It is always, I tell them, it is like you and me seeing frequently. I see you now, I see you after 3 months, I see you after 3 weeks. Frequent seeing, we don't forget one another. The bonding improves. Whereas we keep seeing after 1 year or 2 year or 3 year, we tend to forget. The same way, for them to understand in a much local sense, always tell them the idea is to bring down the severity and the frequency of symptoms. That's why you need to have a controller therapy. That's the idea of they also giving controller at that particular point in time in the form of MAT therapy in the presently being recommended. So simultaneously anti-inflammatory and reliever use, that's your MAT therapy, significantly reduces exacerbation and also the future chance of severe exacerbation in these children. And so SABA short-acting beta agonist is no more used in isolation. That's the recommendation for now in children over 6 years or so. So the GINA strategy is either symptom-driven in mild asthma as daily inhaled corticosteroids as controller, or SOS during exacerbations, steroid is being advised. In COVID and asthma, people all are confused whether to give steroids, whether to give inhalers, whether to go ahead with our regular medications. Now it's been said that treat asthma as what it is. In fact, asthmatic didn't have worse signs and symptoms of COVID. Probably who are on controllers, that steroid helped or what, nobody knows. But that didn't increase them as a risk factor except in uncontrolled asthma. So there is no increased risk of COVID-19 in people with asthma aside from uncontrolled asthma. That is the proven fact. And flu vaccine has been recommended in all asthmatic. And when they recommend by age criteria for COVID vaccine, go ahead with COVID vaccine. By CDC, COVID vaccine and flu can be given simultaneously, or any vaccine for that matter, or at least 2 weeks gap between flu vaccine and your COVID vaccine. That's the recommendations for now. We have a lot of dilemma in regards to the inhaler therapy. We always see them by appearance, plastic bangle, they don't have even a gold chain. Will they be able to afford it? Will they accept it? Will they understand? These are the dilemmas we have. So that's not a problem. So anybody and everybody, treat them the same and give them the knowledge of what they are supposed to hear and understand. And it is up to them, leave the decision to them. The only thing is, we should not be thinking they will not understand, they will not take, they will not accept. So let's not play God with regards to inhalation therapy. And the most important problem is, most of us know what we are supposed to do, but the problem is time. The studies have said the average patient spends less than 1 hour with the doctor, an asthmatic child, each year. And with this 1 hour, less than 1 hour, we manage the remaining 8,759 hours of the year. So that is the amount of time we give them. We can't be blaming us or the patient or anybody. That's the scenario we live in. So whenever required, at least prioritize and give them time so that they understand and they go through, so that you will also be able to communicate better and explain to them of what you are supposed to do. So overall, science is there, practice is there. Nobody is having ill feelings towards one another. But the thing is, for the science to get translated to practice, strong worded recommendation and yearly guidelines alone will not help. CMEs will not help. So we need to bridge the gap between science and practice, so that the practitioners get convinced on the concept and context, so that the awareness, acceptance, and the adaptation to the regular practice comes into vogue. Thank you.
Thank you, Shivabalan. It was given a very exhaustive, informative, given and delivered in a very humorous way. I see that you have not lost the art of convincing people.
Thank you.
I hope all the audience are convinced by what you said and they will be practicing. Thank you, sir.
Hopefully.
Thank you, sir.
Thank you.
Any queries?
No questions.
I would like to request Dr. Muralidhar Reddy Garu and Dr. P.S. Pawan Kalyan Garu to felicitate Dr. Somu Shivabalan. I would like to request Dr. Muralidhar Reddy Garu to felicitate Dr. P.S. Pawan Kalyan Garu. Moving on to the next session, I would like to invite Dr. V. Nangamaleshwar Rao Garu, AIMS Hospital, Chief Intensive Manager and IAP Secretary, Krishna District, on the stage to introduce the speaker of the session, Critical Care Management Protocols. First, clinical markers, Fuse Muse scorecard, which saves life. Please, sir.
Hello, good afternoon, one and all. We are having the Central Zone Conference at Hyderabad on June 11, 12, and 13. Central Zone includes Uttar Pradesh, Madhya Pradesh, Chhattisgarh, and 2 Telugu states. We request all of you to attend the conference and subscribe for the conference. We have the early bird registration, sorry, not subscribe, register for the conference. Early bird registration is 3,000 for pediatricians and students 2,000. Yashwant is there. You can contact him for the early bird registration for the Central Zone Conference at Hyderabad on June 11, 12, 13. I believe there's a phone pay.
Good afternoon, everyone. Critical care protocols. in critical care protocols. Am I audible? Yeah. Good afternoon, everyone. In management of critically ill child, the key is early diagnosis and management. For early diagnosis, everybody should have an idea or some protocols regarding how to recognize a critically ill child. This can be done by simply looking at the patient sitting in OPs by their behavior, respiratory rate, heart rate, and skin perfusion. By preparing with these parameters scorecards, and these scorecards will help you in busy OP practice to recognize the critically ill child or sick child in early stage. To prepare, how to prepare these scorecards and how to manage in ER room. And in ER room also, you should not fumble once child entered into the ER room. You should not fumble and running to from drugs and masks and devices from ER room to pharmacy to ICU. To avoid all these things, we should have some ER room protocols. How to prepare these protocols and how to follow these protocols. Today we have some panel discussion. In this panelist, we have Dr. Ashok Chaudhary, consultant pediatric intensivist, Blossoms Mother and Child Hospital, Vijayawada. I invite Dr. Chaudhary onto the stage. And next panelist, Dr. Srimukhi and M. Ravikumar. Come on to the desk. Now I invite Dr. Ashok Chaudhary to deliver his lecture.
So good afternoon, everyone. I'm Dr. Ashok, consultant pediatric intensivist working at Vijayawada. So I thank IIP Pedicon AP State Chapter and IIP State Chapter and IIP Krishna for giving me this opportunity to present pediatric early scoring system, which is a warning system score system, which is being utilized in all national health schemes in UK and US. This is actually a life-saving topic or a life-saving theory topic, but this is practically used in all hospitals. So next slide. So going into the details, pediatric early warning score system. So actually, what is the history? So history is the early warning scoring system. Early warning scoring system was developed in 1990s. It was developed in UK by a group of doctors named James Fagetson Hospital, which is in Norfolk, UK. And this was tried and tested, and it was presented in International Society of Critical Care Society, and it came into existence in 1997 from May. And this used the basic respiratory vital pattern systems and associated with the neurological assessment. So basic 5 parameters of heart rate, temperature, respiratory rate, blood pressures, saturation, and the neurological status. So these were the parameters which were initially used, and following on that, it was subsequently developed. So it was they have started giving 3 points, 0 to 3 points, and based on these points, the assessment of neurological statuses, the critical status of the patient was assessed. So there are different markers which are there, warning systems. The first being which I'll be discussing, which is pediatric early warning scoring system. The subsequent was modified early warning scoring system, which is used particularly for adults. And then one more, which is for modified early warning system for obstetric, which is particularly for obstetric patients. So, and one more is NEWS, which is National Emergency Warning Scoring System, which is used in UK. So these are the different warning score systems which are present. So today I'll be discussing particularly about pediatric early warning scoring system. So the basic idea is to utilize the objectified data and to identify early signs of patients before they deteriorate. And it can predict the deterioration 6 to 8 hours prior to the patient being developing in code activation. Either it might be a code blue situation also. So it is used to eliminate the preventable codes. Any preventable codes of either shifting the patient from ICU or from ward to ICU, or by the time child goes into code blue scenario. Pediatric early warning score system is not a validated score. It cannot be used in emergency department, NICUs or PICUs. It is still under trial, but it is actually useful for use in ward where the patient either is being continually monitored in ward, whether this patient needs to be shifted to ICU or it has to be continued the therapy and ward. So this is basically about the care of escalation. Does the patient need to be shifted, and at what time he should be shifted? So usually PEWS clinical assessment is done on basically 7 standard assessments. As I have told, the modified early warning score system has developed 5 out of that. And in pediatric, when it comes, we have 7 standard caring systems. And the score is again based on the vital signs and assessment findings of which are already being obtained. So we did not calculate much on that, but these are the vital parameters which we already see. And then based on that, we obtain the score. And based on the score, we tell whether the patient is critical or not. The different parameters is the same as in basic vitals parameters. The first being heart rate, oxygen saturation, respiratory rate and respiratory effort, the capillary refill time, systolic blood pressures and the oxygen saturation. In that, one more thing is the requirement of oxygen. Whether the patient is requiring oxygen or not is one thing which is being very particular in pediatric age group. So research shows that all these parameters are all valid measurements and they give the severity of the illness. How do you use this PEW score? For example, the score is a tool which is based on the age based. So there are different tools, different charts which are being divided based on the age group, and because the parameters of the vitals they differ from age to age. Using patients' vital signs, assessments, and each parameter is assigned a point. The points are added together, and it ranges from 0 to 26. The higher the score or the trend of increasing score indicates the higher risk of deterioration. If the score has been gradually increasing, so that indicates the child is actually deteriorating and he requires next level of care. Now, these are the different charts which are available, and we can see that different age group based on 0 to 3, 3 years to 1 year, 1 year to 5 years, 5 years to 12 years, and more than 12 years. So these are different parameters. And if you go back, the basic ideas in that is that you can see the heart rate, systolic blood pressures, respiratory rate, oxygen therapy, the saturations, respiratory efforts, and the CFT. So these are the 7 parameters. Based on this, the scoring system is designed. Now let's come down to how do you calculate a basic pediatric early warning score system. I'll give an example. A 9-year-old child who comes with fever and hypoxia is been admitted. So he is on oxygen delivery system. So what are the patient? What will the patient be obtaining based on the vital parameters which have been given over here? So 9 years old with a heart rate of 155, a systolic blood pressure of 135, a respiratory rate of 40. He's on 3 liters of oxygen and is saturating at 91%. So you can see there is mild, moderate intercostal retractions with nasal flaring, and his CFT is less than 3 seconds. Out of all the signs, what you're seeing, his heart rate is definitely high, his blood pressure is definitely high for his age, his respiratory rate is more. The only parameter which is normal is CFT. Now, based on that, if you plot it in his chart, you can see the PEW score is around 11. So the scoring system is being displayed over there. You can see. So his heart rate is definitely more compared to his age. That's the reason why he's been given 4 points for his heart rate. When it comes to systolic blood pressure, he has scored a point of 1 because it is definitely more compared to his age group. His respiratory rate is more. His oxygen therapy, definitely he's on oxygen therapy. So that is the reason why he's been given a score of 2 and is saturating at around 91%. And that gives a score of 1. And his respiratory efforts, definitely there's mild retraction. So that is the reason why he's given 2. And his CFT is normal. So his score is 0 over there. So total score comes down to 11. Now, how can the using of PEW care recommends what? So it definitely requires a guided assessment rate frequency and other interventions based on the total PEW score. And it is a score, it is not a single point score. So usually you have to follow a trend of these scores. So not a single point assessment. There has to be multiple assessments which based on the severity. And one more major tool advantage of PEWs is it encourages the communication and collaboration between the nurse. So which is a very important step because nurses team will have it, you can assess the severity of the patient's condition. And nurses continue to use their clinical judgment in this because you are seeing there are different, like the clinical retractions of the respiratory system. So intercostal retractions, flaring of nasal, everything gives a good clinical judgment to the nurse also. At this point, if a nurse or a care provider feels that additional resources are needed at any point, they should still act based on the patient's need and clinical judgment, not just based on the score. This is a definitely take-home message, so that any clinician or a nurse who finds that patient is definitely deteriorating, they do not wait for the score to worsen, and they have to take the clinical judgment in that point. So these are the different PEWS care recommendation. Based on that, if you see the score of 0 to 2 to 8. So this is a different spectrum. I think I will discuss based on that in each case based discussion. So this is the recommendation which recommends that pediatric early warning score calculates are based on the admission to the unit when the patient's condition is changed and when to assess based on the recent PEW score. So it should not be 1 point, that I have already told. So it should be a trend, and then there should be a review. There definitely has to be some review effort because it should not be only just 1 point PEW score. There has to be a review system, and the review system depends on the previous chart which I have already told. If the score is 0 to 2, you can see the assessment is done every 4th hourly. And the subsequent assessment is routinely done, which is by sisters. So usually if a sister has checked in her shift, which starts at 8 o'clock, so next shift, if it's around 2 o'clock, she can ask if the score is 0 to 2, she can check it after in the next shift. But if the score keeps on increasing, if you see the score which is at 8, the initial reassessment should be done at around 15 to 30 minutes, and the subsequent scoring and assessment should be done every 15 to 60 minutes, and it requires continuous monitoring. Whereas if the score is 0 to 2, you see the continuous monitoring is not needed based on the score. PEW score, a success is you have to pay very close attention to how to arrange the patient's interaction so that you will understand if a patient who is sick definitely requires close monitoring and reassessment to be done very frequently. And remember to pay attention to the patient's baseline score. So someone who has a score of around 0 and subsequently within the next 1 hour or 2 hours, if you have monitored again and the score has gone and jumped, but definitely that indicates the patient is worsening. So that is also a very important point to make it note. And you continue to use the clinical judgment, which has been already discussed. Your clinical judgment is far more important than PEW score. The score just adds on to your clinical judgment. Now, why do you use PEW score? So it is a validated research-based tool which has been used, and it was initially developed for pediatrics in Toronto Sick Kids Hospital, which is in Canada. The literature review shows that the score increases over 24 hours prior to the child deteriorating or being shifted to ICU. A retrospective view confirms that PEW can identify the patients at risk 11 hours prior to being shifted to ICU or when advanced to activate your rapid response team. What are the benefits of PEWS? It is a standardized and quantified nursing assessment, and it evaluates and tracks patients' trends over time. For example, a patient who has been this which I have already told, if the patient's score who has been maintained at around 5 to 6, as right now has scored a 6, I think that should not be a concern for you. But if a patient who has been maintaining a score of 0 and the next subsequent scoring system which shows a score of 6, that definitely is a concern for this nursing team and even for the care provider. And it facilitates an interdisciplinary communication. So that is very important through a common language and a framework, because the system is set in such a way that a nurse has a confidence to establish a rapport with the doctor saying that the score is so and so. Even the doctors also will ask about the reassessment of the score, and providing a standardized recommendation for care. And this gives a nationalized care because I've already told there are different types of emergency scoring systems. The one which I told is National Emergency Scoring System, which is developed in UK, has 2 different scoring systems which is being followed all over the United Kingdom. One which was developed in 2012 and the revised was done in 2017. The nursing feedback, so it pulls together multiple concerns into one number. So sister or the nursing sister team has one number to tell to the doctor, and it objectifies how the patient looks. If the number is somewhere around 8 or 12, so obviously we know the patient is sick. And it helps to quantify the gut feeling. Usually whenever we see the patient says that I feel the patient is sick, so that is just a gut feeling. But when you have a number with that, that gut feeling has a quantification with that, and gives the sisters permission to speak up front, because usually they are quite they feel that we should not be disturbing the doctor when the numbers is quite low, and they have an inferior complex to just go and talk to doctors. But if the number is quite high, they usually are 10 and they upfront go and discuss with the doctor. Then it empowers staff at the bedside to make requests for providing of escalation of care. This is very important because the purpose of PEW is to shift the patient as early as possible before they deteriorate. And one more is the data collection shows the nurses are more confident in their ability and they recognize the assessment finding relative to the clinical deterioration. And nurses are more confident to act on those concerns. And physicians are more confident in the nurses' ability to communicate consent effectively. So here the communication is a key. So the communication to the patient score, what they should be telling is about the total score, the assessment that led to the total score, and the total trend in a PEWS, because the last assessment the score was 0 and the present score has gone up. So that is a concern point. So you may need to guide the other providers, because this needs an integrated system. It's not just a sisters which have been which should be well versed with the system. It is about the doctor or the physician. So it is a system which should be incorporated into the system with the hospital staff. Even sisters to doctors, everyone should be knowing about the PEWS score system. Now remember, the higher PEW score or the higher the trend increasing indicates the increased frequency of monitoring of and considering the escalation of care. This is the classical or the important point which has been discussed, that any higher PEW score or a trend of increasing score increases the frequency of monitoring and considering to escalation of care. Now, utilizing the elements of ISBAR is identifying the yourself, then going with the situation. Now, for example, if the sister is being given the situation, so she should tell that patient who has been admitted in that row has developed a score of so and so, and what is the situation. Then it comes background. What was the background situation? How bad was the child? Before you assess right now, what was the assessment which was done 4 hours back? The patient should give us a previous PEW score and the present PEW score. Now, coming to assessment, her assessment should be in the state like, what are the assessment? What parameters have changed which has led to the increase in PEW score? That also has to be done, and that is called as assessment. And then R is called for recommendation. What does the sister recommend, or what does the nursing team recommend? So it recommends that close monitoring has to be done, or either it requires a resident to come and see the patient and take an assessment, or whether the escalation of care is needed or not. Now, the key messages in PEWS is there are simply 7 items which of severity of illness scoring system. So based on the 7 parameters of vital systems and the monitoring systems, the scoring system is designed. The higher the score is associated with the higher risk of deterioration, and it quantifies the trend and assessment findings to identify patients with increasing risk of severity and illness, and gives the team a common language to intervene when a patient is deteriorating. Now, coming to PEW score, for example, I'll just discuss around 4 cases. Now, this is a case where there is no PEW scoring system done. The patient is already diagnosed to have croup. Now, we have a patient named Devanand who is 15-month-old and was admitted with croup. At 6:15, that is around 4:15 p.m., the sister has noticed the child has decreased urine output and there is increased retraction. At this point, the sister has decided that she wants to put an IV cannula and starts giving IV fluids. So nurse has written down in her progress needs, because monitoring is everything and documentation is quite evident needed at this point. So she has written the resident has been made aware there is decreased urine output, and she is unable to assess the PEW score because the patient is continuously crying and the patient is anxious. So at this point, the nurse has chosen not to calculate the PEW score because the patient is not cooperating. And she has, during her score, which started at 8 o'clock. Usually morning shift at 8 o'clock, the sister has come. At 4 o'clock, she has not monitored this child, and she has just assessed, written that child is not cooperating, and she has not noted down the score. At around 4:30, the resident has been requested, because the sister has noticed the patient is actually having increased workup breathing, and there's he's inability, and he's not able to. We are not able to record a saturation. So the patient was placed on oxygen saturation, oxygen of around 4 liters, and the nurse, the in-charge nurse, has now calculated the score is around 15. So what happened is, at around 4:30, you can see the vitals. Based on the vitals, it shows the PEW score of around 50. So at 5 o'clock, the requirement of oxygen, which was initially at 4 liters, has gone up to 10 liters. The patient's heart rate and respiratory have also gradually gone up. So initially he was on 4 liters, now he's on 10 liters. You can see the heart rate, respiratory rate, and vitals all are showing an increased trend. So at this point, if the sister has done a recording, which was around initially at her shift, which was around 8 o'clock, and you can see the score was showing somewhere 6. And at 12 o'clock, the score, based on the vitals which she has recorded, it shows that 12 o'clock, the score was 2. And at 3 o'clock, the score was 9. At this point, if you see, the heart rate of 142 is definitely high. So that is a maximum score, what she has already scored of 4. And the retractions were still quite high. So number of which were to the max has been already reached at 3 o'clock, and the score was 9. And then at 4:30, at this point the sisters noticed the patient is not right, and they have reassessed, and the score was 50. And at 5 o'clock it was still 13, but if you see, the blood pressures were not recorded, but still I would say it is something more. As I have showed in the PWS care recommendation, any score of more than 8 is classical indication that it requires a doctor's intervention, and whether the care of escalation should be done or not. So at this point, if the sister has noted him at around 3 o'clock, but definitely the score should, when it was at night at 9, at that point, if the doctor has been would have intervened, then the score at subsequent around 4:30 would not have been 15. So the values indicates one point which I would like to make note on this is any parameters on all 7 parameters at any point if the score reaches to the maximum is an indicator that it needs escalation of care. So the nurse has been scoring the patients during the system, which I've already discussed, is that the patient was quickly shifted to ICU because he didn't show much of improvement. Now, second case is a bronchiolitis case, which is already diagnosed. Is baby Samantha, who is 7-month-old, who is admitted in ward and been already diagnosed as bronchiolitis, and she has come positive for RSV. She was on 1 liter of oxygen and she was admitted. She was requiring frequent suctioning. Her PSW score has been in the trend of 3 to 5 since admission, and her last PW score at 2 a.m. was showing at 5. And again at 4 o'clock, the sister assesses the patient, and these are the parameters. So her heart rate was 142. His all vital parameters were within the normal range, how the patient was already being. So her present score is also within the same range how the trend was. What does this indicate? Should the nurse be concerned? Definitely no, because the trend is showing the same. But what should the sister do? What should the intervention is? That she should closely monitor, and the trend of monitoring, because the score is somewhere around 6, as I've told in the previous slides. A score of 6 definitely needs intervention, and she has to reassess the patient within hourly or second hourly. So the nurse reassessed it around, which was done at 4 o'clock. Now again at morning 6 o'clock, she has reassessed, and she has done a proper suctioning. And after suctioning, the vital status at 6 o'clock is this. So which was initially the heart rate of 142 has now changed to 172. The BPs have gone up. His respiratory rate has definitely increased. His saturations are 99, and his requirement of oxygen has gone up from 1 liter to 3 liters. And you can see from 4 o'clock to 2 o'clock, his PEW score has gone up to 9. So at this point, so should the nurse should be concerned, and what intervention should be? So definitely the sister should be concerned, and the next intervention should be that she should be asking her resident to have it close look, and she should be not checking the frequency as 2 hourly, because initially she has checked at 4 o'clock, now at 6 o'clock. So her next assessment should not be after 2 hours. It should be within 15 minutes to half an hour. So she has to assess her score at around 6:30, and 6:30, this is the assessment. Her vitals have still not improved. His heart rate is still high. His requirement of oxygen has gone up, and you can see his respiratory efforts. He is actually having head bombing, everything. That indicates his score is definitely more than 11 or 12. So at this point, should the sister be concerned? Yes, she should be concerned, and should activate the rapid response team, and the doctors who are the resident who is over there should take over the case. And what intervention? He should be definitely be shifted to ICU. So this is been done. The patient should have reassessed at 8 o'clock. This is just an example. If the patient was not checked at 6 o'clock, the shift changes at around 8 o'clock. At this 8 o'clock, this was a very crucial phase. If the patient was not reassessed by the sisters, the patient would have deteriorated. And this is how the PSW score system helps. Now, this is the third case.
Sir, time is up, sir.
This is the last, sir.
Going into the other person's session.
Okay, fine, sir. Close it off then. So these are different cases. Sepsis is one thing, which I just wanted to tell, because in sepsis, usually they deteriorate quite fast. At 8 o'clock, you can see the vitals, they're all fine. Whether for a child who's been already diagnosed to have fever, I'll just brush it off. At 12 o'clock in the night, you see the vitals going up. At this point, the nurses has just activated, and it is turned out to be at just to tell you, at 8 o'clock and 12 o'clock, the assessment was done 4 hours with a gap of 4 hours, because at 8 o'clock his PEW score was 0, and at 12 o'clock it was 7. So with a score of 7, the sister should reassess with the next half an hour, and she has reassessed. The score has not changed. So that indicates the child is in sepsis, and the child was shifted to ICU. And one more thing is about asthma, because usually when the patient comes with asthma, they're actually having a high PEW score. That doesn't mean that they should be shifted to ICU. So this is a 4-year-old child. These are the vital parameters which when he was admitted in ward. So this is the chart. So you see at 3 o'clock, his vitals PSW score was 13, and subsequently At 4 o'clock, his score was 13, and after 6:30, because after giving max sulfate and nebulizations, his score has come down to 8. So still a score of 8 indicates that the assessment should be done next within half an hour or to 1 hour. At 6 o'clock, when this assessment was done, his vitals again worsened. At this point, the patient was shifted to ICU. With this, I complete. So any questions will be taken after the, I think,
Thank you, sir.
the rest my colleagues take over.
May I call upon Dr. A. Srimukhi to deliver critical care management protocols on anaphylaxis to redeem a life.
Good afternoon, everyone. I thank IAP AP State Organizing Committee for giving me this opportunity. So my topic for today's presentation is anaphylaxis to redeem a life. As a clinician, we definitely would have faced a case of this life-threatening event. Under accurate diagnosis and the right time of administration of a single injection can redeem a life and bring back the smile on our patients. So the objective of my PPT would be, first, I will review the definition of anaphylaxis and its epidemiology, discuss the most common etiologies and recognize its clinical presentation, summarize an approach to the diagnosis, and formulate an effective treatment and management plan. So firstly, let me start with a case scenario. This is a 6-year-old boy presents with itchy, watery eyes, running nose, and frequent cough, audible stridor, and a pruritic rash on his trunk and extremities 1 hour after ingestion of a cashew nut. So he has ingested other tree nuts in the past without incident. So what is the diagnosis? What is the next step in management of this patient? And what additional test would you order? What advice would you offer the family? Let's discuss this answers to these questions at the end of the session. So this is that child with the urticarial rash over the face. The World Allergy Organization has revised the definition of anaphylaxis in 2019. And there are 4 images shown down. And first is mild localized symptoms. And second is a generalized allergic reaction with an angioedema. The third image is anaphylaxis. Anaphylaxis is nothing but a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death. So systemic involvement is the key here. And severe anaphylaxis is a potentially life-threatening compromise in breathing or circulation. So the severe life-threatening complication comes under severe anaphylaxis. So there are 2 criteria for diagnosing anaphylaxis. The criteria 1 includes acute onset of the illness, like from minutes to several hours, with involvement of skin and mucosal tissue with at least one of the following. Skin and mucosal involvement plus at least one of the following, like respiratory compromise, hypotension, or gastrointestinal symptoms. So the next criteria 2 is recently included. This criteria tells us that even in the absence of typical skin involvement, acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient, then it is considered as anaphylaxis. So respiratory compromise or hypotension or gastrointestinal systems without typical skin involvement. So now comes the incidence and prevalence. There are no studies of regarding anaphylaxis or triggers of anaphylaxis done in India. So we don't know how much risk is there and what is the incidence and prevalence in India. But according to the Western studies, like in US and UK, the prevalence is rising in the last decade. And the lifetime prevalence may be as high as 2% in US studies, and it is showing 3% in UK studies. So some of these studies are showing that the prevalence of anaphylaxis is more in the northern sections of US, and this has been linked to the less exposure of the sunlight, and which leads to less vitamin D levels. And they are showing that there is interlink between vitamin D levels and allergy and anaphylaxis reactions. So mainly triggers of anaphylaxis are the key factor. If we know the trigger of the anaphylaxis, because in many cases we try to identify the trigger. If we identify the trigger, we can prevent the severity and we can prevent the fatality associated with this. So there are two types of triggers of anaphylaxis. One is IgE mediated, one is non-IgE mediated. However, we try to find out the triggers of anaphylaxis. We know that 30% of cases goes idiopathic. So the most common IgE-mediated anaphylaxis trigger is food allergens. These are peanut, tree nut, shellfish, egg, milk, and the next thing comes to medications, and the next thing is insect bites and rubber latex. So there are non-IgE-mediated. Sorry. There are non-IgE-mediated causes of anaphylaxis also. These can be physical stress factors like cold, exercise, heat and sunlight, and some radio contrast media also. So in children, studies show that the common cause of anaphylaxis or trigger is food allergy in 89.7%, and especially milk and wheat being the most common cause. So these are anaphylactic cofactors. These risk factors or cofactors, if present in the patient having anaphylaxis, increases the severity and the risk of fatality in that child. So age-related factors, and if the child is having a concomitant disease like asthma, cardiovascular diseases, mastocytosis, or allergic rhinitis, and if the child is on concurrent medications like beta-adrenergic blockers, because adrenaline, which is the single drug of choice, might take time to act. And if the other cofactors like exercise-induced and acute infection, emotional stress are present at the time of the anaphylaxis, these cofactors increase the risk of the severity and fatality in that child. So we know the pathogenesis of anaphylaxis is IgE dependent and non-IgE. IgE dependent is most classical and most frequent mechanism. In IgE dependent, we need a previous exposure of the allergen to the beta cell, which makes it sensitized. And so the mast cell or basophil, after re-exposure to that allergen, can cause mast cell mediator release. So these are the mediators produced by the mast cell, like leukotrienes and proteases and growth factors and cytokines. Leukotrienes, histamine, and proteases are responsible for the immediate action, and cytokines and chemokines and growth factors are responsible for the late phase reaction. So all these mediators cause these three mechanisms like vasodilatation of blood vessels, lowering the BP and causing hypotension and bronchoconstriction. And they also activate pathways like complement, clotting, and clot lysis. So there is a mild anticoagulation effect also in the pathogenesis of anaphylaxis. This is a study which was done. It is an article which has compiled the data of 1,865 patients and have shown that the signs and symptoms, the frequency of signs and symptoms of anaphylaxis in children, and 85 to 90% are cutaneous manifestations, and 45 to 50% are respiratory, and 30 to 35 are syncope and hypotension, and less than 25 to 30 are abdominal manifestations. So the patterns of anaphylaxis can be uniphasic, which is very common, typically presents within seconds to minutes and then resolves within hours. It can be biphasic in some cases. Recurrence of symptoms can occur within the 12 hours period, and it is protracted when the symptoms lasting for hours, days, and even weeks. So the key questions to answer whenever we see anaphylaxis cases: what is the trigger, and how much amount has caused this anaphylaxis, and are the symptoms and timing consistent with anaphylaxis, and what was the treatment given and what was the response, and what are the associated cofactors in this particular child, and what ER record of that particular child. So there are many differential diagnoses to differentiate from anaphylaxis, like simple vasovagal syncope and acute generalized hives or acute urticaria, acute asthma, syncope, panic attack. All these can mimic like anaphylaxis. Is lab diagnosis of anaphylaxis necessary? Anaphylaxis is mostly a clinical diagnosis, but why do we need lab diagnosis of anaphylaxis? It is for three reasons. First reason is to confirm the diagnosis of anaphylaxis and to exclude other anaphylactic mimics, as I told you. And the second reason is to identify the potential triggers of anaphylaxis. Third thing is to evaluate the patient with idiopathic anaphylaxis. We say idiopathic in most of the cases because we don't do the test and then we say idiopathic, but we have to evaluate the patient with idiopathic anaphylaxis and decide them as idiopathic. So what is the lab test for diagnosis of anaphylaxis? We need to do serum tryptase levels. These levels peak within 60 to 90 minutes after the onset of anaphylaxis and persist up to 6 hours. So this can be obtained within 1 to 2 hours of onset of the symptoms. Total tryptase or a beta tryptase can be done. And if generally the total tryptase level is less than 1, and if it is less than 10, we consider it as anaphylaxis, and if it is more than 20, we consider it as mastocytosis. We have to keep it in mind, and we have to check for the other signs of mastocytosis. So these are the other tests which are done to exclude the diagnosis. So second thing, and the most important thing, to identify the trigger of the anaphylactic episode, the allergy skin test, which is the most sensitive and specific test for diagnosing. We can do a skin prick for airborne and food allergens, and intradermal test for a drug allergy or venom allergies. So the other thing, if the child is not hemodynamically stable, or in that cases, we can send a allergen specific serum Ig levels, immunocap, in these children. And allergen challenge tests can also be performed, and mostly they are performed with medications and sometimes with foodborne allergies. For food, allergic skin prick test is more preferred than challenge test. So how do we, the third thing I told us, we need to evaluate a patient with idiopathic anaphylaxis, search for the previously unrecognized trigger. And the other thing, we have to measure the baseline tryptase levels when the patient presents with the anaphylactic reaction to confirm it as anaphylaxis. And we need to observe the skin closely for urticaria pigmentosa lesions to rule out mastocytosis on any bone marrow disorder. And so last thing is we have to consider a bone marrow biopsy to see for the mastocytosis. We need to do cell markers and histology in the bone marrow. So what are the preventive strategies for anaphylaxis? We always hear that prevention is better than cure. And in anaphylaxis, this preventive therapy like immunotherapy has decreased the fatality and decreased the severity and decreased the episodes better. So allergens. So this first thing, before starting immunotherapy, we have to know the history based on the exposure, and then we have to confirm the sensitization by doing a prick test or immunocap. So immunomodulation has been proved and is most commonly done in house dust mite, pollens, and cat and dog immunotherapy is proven. But if in food, oral immunotherapy is still in trials. Insect venoms, immunotherapy works, and it is already proven and approved. In medications, we can do desensitization for medications if it is necessary to give, or we can just avoid it. In idiopathic anaphylaxis, for frequent episodes, sometimes consideration of oral glucocorticoids and antihistaminics as prophylaxis for a longer period is necessary. So the principal therapies of an acute attack. What should we do if a child presents with an acute attack of anaphylaxis? First, immediate action, we should call for help. Second thing is assess the airway and secure if needed, and assess level of consciousness, assess the vital signs. The main choice or drug of choice is epinephrine, and we know the action of epinephrine is alpha and beta adrenergic receptor blocker. So this reverses vasodilatation, this reverses the inotropic or chronotropic, increases the inotropic and chronotropic action, and helps in as a bronchodilator. So this is what is needed for anaphylaxis treatment, and 99% of all the cases of anaphylaxis have responded to adrenaline in all the studies. And this is one study which shows that absorption of epinephrine is faster with IM injection than subcutaneous injection. IM takes around 8 + 10, 2 minutes, and the subcutaneous takes around 34 minutes. So this indicates that administration of epinephrine with IM is better. So what are the other things to know? Adrenaline, every time, anytime in anaphylaxis, adrenaline have to be used in 1:1000 dilution. There are 3 pens which are available. Now it's also available in Indian market nowadays. So these are EpiPen Junior, which is 150, EpiPen 300, and EpiPen 500. So this is nothing but each shot of EpiPen Junior 150 delivers 0.15 mg, and which is used in less than 20 cages from 7.5 to 20 cages of child. And 300 delivers, one shot delivers 0.3 mg, which can be used in 20 to 40. And 0.5 mg is indicated in above 40 cages child. So availability of this EpiPen is better and it can be easily carried, and it's more effective. For emergency treatment, but in some places it's still limited in resource setting limits, and so for emergency purposes we can use ampules of 1:1000 and never dilute this ampule and make it 1:10,000. So in management of anaphylaxis in infant, one key point we have to remember is, like, whenever some children, while giving adrenaline, we see that there is an increase in the hypertension, increase in the tachycardia, and increase in the pallor in the child, and we misinterpret this as anaphylaxis not be treated. So the main key factor is measuring the blood pressure during the treatment of infant will guide us the effectiveness of treatment, and this helps to see if the additional doses of adrenaline are required or not. So what are the actions we have to remember after giving an adrenaline? Never allow the child to stand or walk. And the other thing is, we have to also keep in mind regarding the retracted or protracted or biphasic reactions. In cases who had previous history of severe or protracted anaphylaxis or previous concomitant illnesses, or who live alone or stay in remote cases, we have to keep these cases in mind and give them adrenaline required. Mostly try to admit or give them repeated adrenaline doses if required. So the additional measures to consider if IV adrenaline infusion is ineffective. Generally, adrenaline, 99% of cases, it covers it. If it is not responding, then we have to see for upper airway obstruction, we have to give nebulized adrenaline. And for persistent hypotension or shock, we have to give normal saline or glucagon, because glucagon increases the adenyl cyclase normally, not through receptor mediated. This helps in cases of if the child is on beta agonist. For persistent wheezing, bronchodilators and corticosteroids can be given. So outdated epinephrine loses its efficacy. We all know that epinephrine, improper storage and exposure to sunlight will degrade it, but expired epinephrine is better than no epinephrine. This is a homemade epinephrine kit. This can be used like in 1 ml syringe. We can load the epinephrine and stored in a spectacle box. In the spectacle box, this is more economical, and we can use it when there is no availability of EpiPen. These are the ancillary measures, like whenever we are treating a child, not only adrenaline, we have to remember about the peripheral IV fluids to treat hypotension, and if the child H1 and H2 antihistaminics, and combination is more effective in reversing the hemodynamics of anaphylactic shock. Inhale bronchodilators if wheezing is present, and vasopressors if it still continues, and corticosteroids and glucagon or atropine. So what causes death? Laryngeal edema, circulatory collapse, and myocardial infarction. So these are the 3 R's we have to remember: recognize symptoms early, respond quickly, review what caused the reaction, and always preparing an anaphylaxis emergency action plan is necessary. So the relevant allergens, what symptoms to look for, what medications to use, all these have to be educated to the parents. This is the case scenario I have told you in the initial part. So what is the diagnosis? It's definitely anaphylaxis. What is the next step in the management? Epinephrine. Since the child is 6-year-old, around 20 kgs, 0.15 mg IM should be given. And what additional test would you order? Definitely skin testing for tree nuts, because the child had reaction after cashew nut. What advice would you offer to the family? Carry epinephrine kit, distribute anaphylaxis emergency plan, avoid tree nuts if possible. This is the take-home message. Thank you.
Good afternoon, everyone. Good afternoon, sir. Thank you, APPEDICON and IAP Krishna, IAP Prakasam for giving me this opportunity. Today, my topic is pain, how to abate the agony. As you all know, pain is very common in pediatric patients, but it is often neglected, thinking like it doesn't, child doesn't feel pain often. So, but actually it has very lot of long-term implications. So we'll go to the slides. So my objectives of today's talk would be reviewing the definition of pain and assessment of pain, which is very difficult in pediatric age group, and to see what is WHO pain ladder and the non-pharmacological therapy, pharmacological therapy of analgesia and the patient controlled or nurse controlled analgesia and the procedure analgesia briefly. Coming to definition, actually it is defined as an unpleasant sensory and emotional experience, which is actually associated with actual or potential tissue damage or described in terms of the damage. This definition is given by International Association for the Study of Pain in previously in 1977 it was given. It was revised slightly in the year 2020. As you all know, like pain is different in different human beings. It all depends on the various behavioral, psychological and emotional and biological factors. So if a patient tells like he's experiencing pain, it has to be respected. Coming to incidence, like it is estimated like around 35 to 80% of pediatric admissions will have pain at some point of time during their admission. It can be a disease related, say example, following a trauma, the child can present with pain or any inflammatory conditions, joint arthritis, those things. Or it can be related to the therapeutic things which we do, like lumbar puncture and bone marrow test, or diagnostic procedures, and sometimes like therapeutic procedures, like following IND abscess or when you are inserting a drain for a pneumothorax. All these conditions are associated with pain. I'll just give you a small history. 11-year-old girl came with fracture forearm. She underwent surgical reduction, closed reduction, and she shifted post-operatively. So the questions would be definitely the child will be in pain. The questions will be like, how will you assess the pain in her, and what analgesic would you suggest? Would you start with initially, and then how will you escalate if she continues to be in pain? We'll discuss about the analgesia and then come back to the case scenario later. There are certain challenges in pediatric analgesia, as we all know. Like as I said, like it is falsely believed that children doesn't experience any pain and they tolerate pain better. And it is also it is believed like if a child is sitting quietly in the corner of the room, we usually think like child is comfortable sitting and he's enjoying like that, but that may not be true all the times. Maybe the child may be in pain and he is not expressing, he is not himself. Normal child will not be sitting quiet in the room. So, so these things we need to consider. And the other thing is the difficulty in pain assessment. As we all know, it is very, very difficult to assess actual degree of intensity of pain in a patient, and that too in a pediatric patient, it is much more difficult. And the other thing which we see commonly from clinician point of view. We think like there is we are concerned more about the side effects of the pain medication, right from the tramadol to opioids. We believe like children get addicted to narcotics, but therapeutic doses which won't cause that. And the other problem which we face in pediatric analgesia is we lack positive reinforcement from the patient. Patient can't tell, like may not be responding appropriately, expressing himself the pain. The next question is, why do we need to treat analgesia? It is mainly to relieve pain, anxiety, and also to prevent accidental removal of medical devices, like our most catastrophic thing, the ET tube or ICD. And the other problem with the persistent pain is it can have long-term psychological and physiological consequences, including immune suppression, prolonged delayed recovery from the surgery, and long-term psychological effects as well. Like they will be feared of pain, and then they'll try to avoid the medical admissions. And the most important thing is which is a legal thing. In the 2010, there is been a declaration which is called Declaration of Montreal. Access to pain management is a basic human right, and it has to be respected. Coming to assessment of pain, there are certain challenges in assessing pain, as I told you previously. The first thing is we all face in all different pediatric cases, because of various degrees of development of the patient. Like we see from birth to 18 years. So their way of expression and their way of conveying their pain is different. And sometimes a child can have the underlying neurodevelopmental delay, and sometimes the disease itself can cause some neurological consequences. In these scenarios, it will become more difficult for us to assess the pain of the child. And the intrinsic bias in our pain assessment, as we lack some objective assessment in pain, and lack of training of the caregivers, and lack of time, which is more important. Most often when during the rounds, during the rounds, it is often expected from a resident to present the pain score, which we don't do. We see the other important things, and we neglect the pain scoring. And lack of understanding of the adverse effects and availability of the drugs as well. Most of the times, like opioids are not available. Then in the assessment of pain, there are the gold standard is the self-reporting scales, which can be done in a patient who is cognitively normal, that is in a more than 6-year-old child who is developmentally normal. So these are the gold standard ways of assessing pain, which includes visual analog scale, numeric analog scale, Oucher scale, Ong-Becker scale. And in the younger kids and in developmental delay kids, we rely on behavioral and observational scales, which are not very accurate but informative. So these scales are flag scale and comfort B scale. We normally use in our unit Wong-Becker scale for a big child, and numeric rating scale as well. And flag scale we commonly use for small kids. Visual analog scale, it is a scale, is basically a horizontal line. At one end there is no pain, and the other end there is worst pain, score of 10. We'll ask the patient to point out like what is the degree of pain they feel, and then we measure it from 0. And based on that, we'll assess the pain. Numeric rating scale is same, but there is a number which we need not measure actually from the 0. Wong-Becker scale, it depends on the facial expressions. There are 6 different facial expressions to rate the degree of pain. Then comes Oucher scale. Oucher scale is actually involves both a numeric rating scale in a vertical parameter and then the facial expression scale. Coming to flag scale for a small kid and developmentally subnormal child, here pain is assessed based on 5 parameters. the face, legs, activity, cry, and consolability. Each parameter is rated 0, 1, 2 after observation of the child for a minimum duration of 20 minutes. And the caveat is the child should not be on neuromuscular blockers when a child is ventilated to assess this. There is a slightly different version of FLAC scale, which is R-FLAC scale, which is developed recently from 2012, which can be used in a cognitively impaired child. Actually, here the assessor will slightly change the scoring system based on the behavior of the scale and the inputs from the parents. The other scale is Comfort B scale, which assess pain in 6 different parameters using alertness, calm, agitation, respiratory response in a ventilated patient, crying response in a non-ventilated child, and the physical movement, muscle tone, and facial muscles. All these parameters are given ratings from 1 to 5, and the total score will be 30. The minimum score is around 6. Consider escalating the pain management. Coming to the treatment, pain management is actually a multimodal analgesic. This is the principles of pain management include the WHO pain ladder, which was initially developed in 1980s for cancer pain in adults. Then it was later adopted for pediatric patients as well. Now it is approved for acute and chronic pain management in pediatric age group. The funda is combination therapy is more effective than a single therapy, and minimizing opioid use to prevent side effect doesn't mean that child should be perceiving pain. Pharmacological and regional anesthesia and non-pharmacological methods are there. Coming to pharmacological, non-opioid analgesic, which we commonly use, and they come first in the WHO pain ladder. They come first. When we go previous, in the step 1 we use NSAIDs, and step 2 we use mild opioids, and step 3 higher strong opioids, IV opioids, and step 4 we consider PCAs and nerve blocks. As you all know, NSAIDs, including paracetamol, can be used for pain, and they are the first step. These are the common drugs: paracetamol, ibuprofen, naproxen, and ketorolac are also approved for use in pediatric age group, as well as celecoxib. The advantage with celecoxib is it doesn't have GI side effects like gastric ulcer and bleeding manifestations, and it has a better renal safety profile when compared to the non-selective COX inhibitors. Coming to opioids, which morphine is a commonly used drug. It can be given both IV and oral. Oromorph can be given every 4th hourly. IV morph is given intermittently as well as infusion. Fentanyl is other common drug which we use for all ventilated patients. Fentanyl infusion is readily available. And then remifentanil, I have no experience with remifentanil. I have never used, but it is very short-acting analgesic as well as sedative, which can be used in the peri-extubation period. The problem with all opioids is we need to monitor the child. We need to monitor them thoroughly, because it can cause all bad effects like respiratory depression, hypertension, and then with morphine we have more of pruritus. All these drugs can inhibit the gut motility. They will be constipated. If any child is on opioids for a longer time, so say example more than 24 hours, we should be on a laxative plan. Methadone, previously it was not available in India. Now from 2018, it is approved and it is available in India, but I haven't used it. Then comes tramadol. Tramadol actually it has multi-pronged mechanism of action. It doesn't cause respiratory depression and hypotension. The most common side which we all know is vomiting, and then it will also cause some pruritus. It can be given both IV and oral. Though CDC says it is not approved for children under 12 years, but it has been used all over the world. Coming to the next drugs, adjuvant analgesics, which includes tricyclic antidepressants, gabapentoids, and alpha agonists, and NMD antagonists. All these drugs, TCAs and gabapentoids, can be used as an adjuvant, and they are the primary drugs sometimes when it is neuropathic pain, say, or Guillain-Barré or any other neuropathic condition. Alpha agonists, they have come up now. They are now commonly used in all ICUs, both clonidine as well as dexmedetomidine, and they are readily available anywhere. The advantage with them is they doesn't cause respiratory depression. They can have some mild hypotension and then bradycardias, but with continuous infusion, these things will wane off. Like they will be seen like initially when the drug is started. The good thing is clonidine can be given orally also. Actually, dexmed and clonidine, they are better as an adjuvant analgesics than a primary analgesic. Then comes NMD antagonist, ketamine. The advantage with ketamine is it doesn't cause respiratory depression. It doesn't cause hypertension, though it may cause some airway compromise because it increases the airway secretions. And the good thing is it's a very good analgesic for topical surface analgesia. So it is very good for burns dressing. And coming to non-pharmacological therapies, it includes breastfeeding and non-nutritive sucking for a younger baby, and distraction techniques, and yoga, acupuncture, and psychological therapies, and then rehabilitation services. Coming to small note on patient control analgesia, it is nothing but giving small doses of opioids IV intermittently by the patient themselves, or sometimes if the patient is very young, the nurse will assess the pain and then she will give intermittent boluses doses of the opioid. Commonly used drug is fentanyl. Morph also can be used. Here there is a computerized program which gives like baseline continuous infusion of the opioid, and intermittent opioid bolus can be decided based on the weight and taking into safety profile into consideration. And there will be a lockout time. Like whenever the patient presses drug, it may not always deliver the drug. It depends on the lockout period which we set prior. That is on based on safety profile, and the maximum number of doses in an hour is also fixed. And then how we monitor? We have to monitor them. We have to reassess pain continuously, and we have to see what is the ratio of patient pressing the button for opioid and the actual drug delivery to the patient. 1:1 is ideal, but anything more than 2:1, we used to reconsider our opioid dosage. We need to go up on our opioid dosage. Last thing, procedural analgesia. It is a standard of care now, so we are liable if you don't practice it. Prior assessment needs to be done whether the patient is safe enough to go for the procedural analgesia. Actually, procedural analgesia includes procedural sedation as well. They need to be continuously monitored. This is the American Society of Anesthesiologists assessment scale. Class 1, 2, 3 are safely we can give procedural analgesia and sedation. These are the common indications for procedural analgesia for the for imaging, and then minimally painful conditions like IV cannulation, lumbar puncture, and then dental procedures, and painful conditions like burn dressing and abscess analgesia. These are the commonly used drugs in these conditions. This is one more. This is the last slide, probably last but one slide. This is on needle pain, which is often neglected in our part of the world. Topical anesthesia works very well for needle analgesia. It is given 30 minutes prior when you are using EMLA. And actually comfort positioning, which we don't do, which normally we hold the baby tight and then do the procedure. But it's better to be the child in the mother's lap in a comfortable position, and age appropriate distraction techniques, like the child now in the picture is seeing his favorite videos in the VR box. There is a good distraction technique for in the pediatric patients. Take home points: pain is common in pediatric patients. It is not like child doesn't experience pain, and assessing pain using age appropriate scale is very important. And multimodal analgesia is the key. and round the clock regimen. Actually, most of the times we give the drug PRN, which is not always delivered to the patient. Analgesia medicines are to be given round the clock, and we need to continuously reassess pain and then escalate the therapy. The primary endpoint is child doesn't hurt anymore. Thank you.
Very good presentation. Actually, this topic planned as a panel discussion, last minute change it to presentation. Anyway, Dr. Ashok, you presented very well the preparation of PEWs and MEWs. Not only in ICUs monitoring, you can prepare these charts in OPs, you can be placed in OPs, and that can be taught to the entire staff so that patient will get benefit by recognizing early stages. And at the same time, Dr. Srimukhi, anaphylaxis, acute, this is a life-threatening. Ravi, a very good presentation regarding pain relievers. You have also presented the recent painkillers. Very nice presentation. Thank you. Thank you all.
May I ask all the speakers for fill station? Please come for fill station. Nagamaleswara sir, please fill state the speaker, sir.
We will move on to the next session. I would like to invite Dr. V. Raghuram Reddy Garu, pediatric from Guntur, on the stage to introduce the speaker of the session, antimicrobial combos, perfect and imperfect.
Good afternoon, friends. My pranams to teachers and Dr. Balasubramanian sir. Yeah. So, for success of antimicrobial therapy depends on choosing right drug, right dose, right route, and right duration. but we are confused with the available rational and irrational combinations in the market. To enlighten on this topic, today we have a doyen in pediatrics, Dr. Balasubramanian sir with us. Dr. Sir is a medical director and head of Department of Pediatrics at Kanchikamakoti Child Trust Hospital, and is a course coordinator for IAP IDC PhD Fellowship and honorary pediatrician for South Railway Headquarters Hospital, Chennai. Over to you, sir.
Thank you, Dr. Ram. Good afternoon to all of you. I think I'll be standing between the lunch and you. I thank the organizers for the opportunity to talk on a very unusual topic, antimicrobial combo, perfect and imperfect. The focus in the session, which I guess should be for 25 minutes, I'm going to define what is a combination antibiotic. I'm going to discuss the need for them. Do we need them at all? I'm going to give some examples of combination antibiotic therapy, some good, bad, and ugly. And then I would certainly give a summary and some suggestions for rational combination antibiotic therapy. What do you mean by a combination antibiotic? By definition, if you use two ingredients which are added together, that is, you want to make A plus B into A plus B square. That is what is antibiotic combination. And these two ingredients need not be antibiotics. For example, you have the amoxiclav, which we often use. Clavulanic acid is not an antibiotic. It only inhibits beta-lactamase. So you can combine an antibiotic with another antibiotic. That is a combination antibiotic. You can combine an antibiotic with some other chemical. For example, you give probenicid along with penicillin, beta-lactam inhibitors. All these are combinations, and they are not really antibiotics. So this is what is meant by an antibiotic combination. Let me take you through to some case scenarios where we would discuss whether such a combination therapy is required at all by walking through some case scenarios. This is a true case, a 10-year-old boy who came with seizures and fever. He was encephalopathic, and he had classic Brudzinski's and Kernig sign, and he had meningitis. And CSF was done very typical of bacterial meningitis with the polymorphonucleocytosis. And the lab technician was to coccus seen. And we, as a policy for acute bacterial meningitis, we start on ceftriaxone, vancomycin, or infusion. Somebody might ask, it's overkill. Sir is telling something which is not required. What is the purpose of this combination? Is this rational at all? Why do you give such a combination when you have a child with bacterial meningitis? Why are you not giving a single drug? The reason is there is an increase in the penicillin-resistant pneumococcus prevalence across the country. 40% in our own institutions, around 45% of the pneumococcus which we isolate are resistant to penicillin. And in a child who has got a serious life-threatening infection like endocarditis, brain abscess, meningitis, there's no point in talking about rational antibiotic therapy. You have to save the life of the child. So you have to be aggressive. So you don't have to be aggressive for impetigo, for cellulitis, but you have to be aggressive with meningitis. An empirical initial choice, what you do in the first day is going to make a difference between life and death to the child. So this is quite correct. Case 2. This is a true story again. 3.5-year-old, he was previously normal. Only thing is there was a sibling death. That's what the parents gave history. He had fever for 5 days. He had progressive palpable lesions in the skin and lower limb swelling. This is what was the picture on arrival. He comes in shock, pulseless, hypotensive, right? Tachycardia, 180, high fear, 103. Now, what do you do with this child? You, of course, diagnose toxic shock syndrome. The question arises, what antibiotic you give? Do you give meropenem vancomycin? That's what we do in any critically ill child. Ceftriaxone vancomycin, clindamycin to cover staph and toxins. Cloxacillin, ceftriaxone, and clindamycin. What do you use? In this child, I'll tell you what we use. we use meropenem and vancomycin. Somebody might say this is overkill. We did give meropenem and vancomycin, child survived. Then what happened was that though in the straightforward case, the child is not in shock, I would have preferred to give only ceftriaxone, vancomycin and clindamycin. Why do you give such a combination antibiotic? Why do you use big guns in such a situation? One, it is life-threatening. Second, you want to do several things other than killing the bug. For example, you have to neutralize the toxin. Any toxic shock syndrome, if you give only antibiotic, it will not help. You have to add clindamycin or linezolid. Both have a toxin production decrease action and also toxin neutralizing action. And you have no time to lose. Again, you have to be aggressive. Case 3. And in this child had septic shock and fever with rash, and then child required all this. Ultimately, this child had the blood culture growth of Pseudomonas. Necrotizing fasciitis, commonly due to Staphylococcus. In this child, it was Pseudomonas. Fortunately, child survived. It was sensitive to ciprofloxacin. We de-escalated. And this child ultimately turned out to have primary immunodeficiency, hypogammaglobulinemia. So, immunodeficiency, again, you have to cover multiple pathogens and give multiple antibiotics and combination antibiotics. Case number 3, very frequently seen, 10-year-old boy, 3 days of abdominal pain. And later, he develops right lower quadrant pain, initially periumbilical, right lower quadrant. He has vomiting and fever. He looks simple. He looks sick. Fever is there. And you have rebound tenderness. Even the ultrasonologist agrees there is rebound tenderness. Probe tenderness is there. And you make a diagnosis of acute appendicitis. Right? The question is, what antibiotic? The surgeon is going to take it up for surgery. He's going to do a laparoscopic appendicectomy. And somebody starts on triple drug therapy following the recommendation given in the earlier editions of Nelson. Ceftriaxone, amikacin, metronidazole. Do you really require this? Somebody might say ceftriaxone covers gram-negative. Amikacin covers also gram-negative. Synergism between a beta-lactam and a aminoglycoside. Metronidazole to cover bacteroids, anaerobes. So you give all the 3. Is it right or not? What is the rationale here? Here, it's a peculiar situation. The child doesn't have a life-threatening illness, but you have a disease where there is likely to be colonization with multiple microbes. Just to give you an example, a perforated appendix, the bowel would have released so many organisms. Bowel contains bacilli, and it would have released organisms into the peritoneum. You will find aerobes, anaerobes, multiple organisms, polymicrobial infection. This is the problem in this area. Another typical example is your brain abscess, a chronic sinusitis, orbital cellulitis. It's usually not due to a single pathogen. Multiple organisms may be there, aerobes and anaerobes. So that is a rationale for these 3 drugs being used. You can use it. Nowadays, we use only piperacillin tazobactam, which just covers everything. Okay. Or if somebody is very sick, you may use meropenem, which will cover everything, including anaerobes. Here again, somebody would say, are you really right in starting the antibiotic without cultures? You cannot wait for the culture. Child is having appendicitis. Culture will come 3 days later. Child should not be allowed to go in for septic shock. So that is the rationale for a combination antibiotic in this case 3. Case 4, common one. 8 days old fever, lethargy, vomiting, on breastfeeds and formula. Birth weight is okay. You decide to admit and do a septic workup. Somebody does everything, CBC, CRP, blood culture, lumbar puncture, everything. Before that, a CBC shows leukocytosis and the CRP is say 100. And you decide to start antibiotics. The question is, what antibiotic you should start? Are you going to use a single antibiotic or multiple antibiotics? If I put the question to the audience, I'll get multiple answers. Let us see. As somebody would say, WHO recommends ampicillin, gentamicin, ciprofloxacin, amikacin. In my center, ciproflox works very well. Somebody might say, all these drugs are useless. I use only piperacillin, tazobactam, and amikacin. 4th, somebody will say, in our hospital, most of the bugs are all either Klebsiella or MRSA. and somebody might use vancomycin and meropenem. Okay. The question is a combination antibiotic justified in such a situation? The answer is, in our institution, outside born, sepsis, sick child, unfortunately, we use today only meropenem and vancomycin. The reason is very simple. Your ampigenta, I am afraid, should not be used at all in neonatal sepsis. 90%, I am not saying this from our institution, I can tell you all India data is there, published literature is there in Lancet, in JAMA. 80 to 85% of neonatal sepsis isolates, rural, urban, south, north, west, east. There is a registry which has clearly shown 85% will not respond to your ampigenta. You allow everybody to die. So no ampigenta for neonatal sepsis anymore in India, whatever textbooks and WHO recommendation might say. Ciprofloxacin, amikacin, yes, if your center has got epidemiological data that there is a flora which is sensitive to ear strain, you can use that. Piperacillin, tazobactam and amikacin, plus and minus is there. What is a plus? Less costly than the vancomycin, meropenem, and piperacillin is, we are comfortable with the beta-lactam antibiotic, but the disadvantage is that piperacillin tazobactam does not penetrate well into the CNS. Somebody has got meningitis, particularly you want to attack the meninges also in this child. You won't be able to do it by giving piperacillin tazobactam. Vancomycin, meropenem, carbapenem has got excellent CNS penetration. And in a sick child with neonatal sepsis today, you start always with the highest antibiotic, provided your diagnosis is correct. You should not be giving meropenem and vancomycin to somebody with HIE, with hypoglycemia, without sepsis. So if there is sepsis, hitting hard is absolutely rational. So here the rationale is you want to cover multi-drug resistant organism based on epidemiology. It is not epidemiology in Ongole, epidemiology in Nellore, it is epidemiology all over India. So you save the life of the individual by hitting hard initially. Third, you must be knowing all the developments in antimicrobial resistance before choosing combination antibiotic. After discussing these 4 cases, let us see, why do you use a combination antibiotic? One, sometimes you may use a combination antibiotic to cover a specific pathogen. Very simple, tuberculosis. You don't treat tuberculosis with one drug. Even chemoprophylaxis today, the National Tuberculosis Program, it is going to become 2 drugs, rifampicin and INH. Things are changing. 2, synergism. That is, you want both the drugs to act together like political, parties joining together and trying to win elections. Sometimes they lose badly also. Synergism. You use a beta-lactam along with an aminoglycoside, the best synergism, and it is very, very useful in endocarditis and in meningitis. Third, for immunomodulation antitoxin effect, I mentioned an example of toxic shock syndrome. I would also mention one more example of your staphylococcal skin scalded syndrome. It is enough if you use only clindamycin. It's not sepsis, it's only toxin mediated disease. Only clindamycin will do. So you can actually produce an antitoxin effect. Immunomodulation. Of course, somebody recently sent a message, azithromycin deficiency is not the cause for chronic cough or acute cough. Okay, azithromycin has got excellent most of the good effects of azithromycin are not because of antibacterial action, but because of immunomodulator. Take any stage, T cell, B cell, neutrophil, phagocyte, everywhere azithromycin has got an action. That is one of the reasons why azithromycin has been so successful. In fact, there is a shocking study in New England Journal of Medicine about a year back. They gave azithromycin to African children below 5 every 6 months. It reduced the under 5 mortality. Okay, if that is so, the under 5 mortality in India should become 0. In the last 2 years, everybody in India would have received azithromycin. Okay, immunomodulation. So that is another effect. Fourth, you want to pass the exam first time. Like that, when you start an antibiotic, you better start both to succeed. Combination. Commonest is, of course, beta-lactam with an aminoglycoside. To cover multi-drug resistant pathogens, okay, Acinetobacter, Klebsiella, Pseudomonas, it's better to use 2 drugs rather than 1 drug. For nosocomial infection, hospitals are the most dirty places in the world, right? It's full of Staph aureus, Klebsiella, Acinetobacter, and Pseudomonas, and Serratia also nowadays. So to cover that, you have to necessarily use multiple drugs. Serious infections. Somebody is having shock with sepsis. You won't be joking and saying, no, I want to be rational. I want to give Ampigenta. They will sue you. For prevention of drug resistance, by using more than 1 drug, for example, in tuberculosis, if you use only INH and rifampicin, you will fail because during the course of therapy, drug resistance will develop. It holds good for organisms like melioidosis and brucellosis also, and Pseudomonas also. To cover multiple pathogens, I gave an example of appendicitis, chronic sinusitis, brain abscess. It's not simply one organism, it's not Staph aureus. There may be more than one, Streptococcus, Fusobacterium, anaerobes, etc. So when you want to cover multiple pathogens, you have to necessarily use a combination antibiotic. Let us look at some common indications where I find a lot of prescriptions for combination antibiotics. Let us audit them one by one. Enteric fever, confirmed. Salmonella typhi grown in culture. You have umpteen number of preparations containing cefixime, ofloxacin, cefixime, azithromycin. And in Nepal, there is a recent study. If you use gatifloxacin and azithromycin, it reduced the duration of fever by 12 hours. How many hours? 12 hours, right? So all this, is it rational? Absolutely not. Monogamy is better than polygamy in enteric fever. Single drug is good enough. Till today, I have not used 2 drugs for enteric fever ever. In fact, if I have a doubt whether it is enteric fever or scrub typhus, I may give a combination of ceftriaxone and doxycycline. Not these unholy combinations ever. 2, child with pyoderma, cellulitis or abscess. Favorite combination of pediatric surgeons. I hope nobody is there, right? Ampicillin and cloxacillin, Ampiclox. Useless combination. It will only produce diarrhea, right? Why use both? Use cloxacillin or use cefadroxil or cephalexin, which are orphan antibiotics. So don't use the combination. Dysentery. Ceftriaxone with amikacin or ceftriaxone with gentamicin, or ofloxacin with gentamicin or ofloxacin with amikacin. Here again, scientifically it is wrong. Why? Amikacin is an organism which an antibiotic which does not do anything with any organism inside the cell. So intracellular organisms cannot be acted upon by aminoglycoside. Shigella, Salmonella, aminoglycosides have no place. Use only ceftriaxone or azithromycin. UTI, piperacillin tazobactam with amikacin. You only increase the risk of renal toxicity. Only piperacillin tazobactam or only amikacin will do. Leptospirosis. In fact, many of my KKCT students are there. In the about 15 years back, leptospirosis is diagnosed many a time in the laboratories, not in patients. Some test will be positive, and the patient will be put on penicillin plus gentamicin or ceftriaxone plus amoxiclav. Giving penicillin G with ceftriaxone is criminal. Giving 2 beta-lactams for leptospirosis. Leptospirosis will respond to any antibiotic. Azithromycin, doxycycline, amoxicillin. You can get away with leptospirosis very easily. Severe patient, of course, ceftriaxone and penicillin are equally effective. MSSA pneumonia, blood culture positive, pneumococcus is there. Using vancomycin, amoxiclav, linezolid is kill. Is enough if you use cephalexin. Cephalexin will do against MSSA, methicillin sensitive Staph aureus. At the most you may use cefpodoxime. So all these drugs are not required. Neonate with ESBL sepsis, you have carbapenem resistant. Use tigecycline, sorry, not togicycline. Tigecycline and colistin. It is antagonistic. Please do not use the combination of colistin with tigecycline. Failure rates are very high. Acute watery diarrhea, Jil combinations. Jil combination. It creates a sense of good feeling only for the physician and for the medical representative who comes to visit you. Many Jil combination, useless. Aminoglycosides, useless. PUO, meropenem with ceftriaxone. Why combine the two? Meropenem is king. Why do you want a servant along with the king? Ceftriaxone is not needed. Appendicitis, piptas plus metronidazole plus amikacin. No need. Only piperacillin tazobactam is enough. If at all you use ceftriaxone, metronidazole, amikacin. Ceftriaxone or cefotaxime with sulbactam for meningitis. This favorite combination is being sold. Sulbactam doesn't penetrate the CNS. Useless. You can use only ceftriaxone or cefotaxime. Cefixime with clavulanic acid, cefotaxime with clavulanic acid for ESBL. Useless. You have to go for your carbapenems rather than this combination. Having discussed all this, what are the factors which should influence your decision to use a combination antibiotic? Number one is the severity of the disease. Number two, the phase of the infection. Number three, the germ type and the antibiotic type and the epidemiological pattern and the concomitant diseases in the host. So that is what should come to your mind before you decide one drug or a combination drug. Synergism, I mentioned, is very, very useful. You can use the principle of synergism very effectively. Endocarditis, you always use penicillin plus gentamicin or ceftriaxone for gentamicin. For streptococcus viridum, synergism. Neonatal sepsis, Staph aureus bacteremia, more than one drug nowadays is recommended. Pseudomonas. And, by combining this, there is increased uptake of aminoglycoside into the organism. So this is rational. Antagonism, using penicillin or amoxicillin, doxycycline routinely. This had increased the mortality in pneumonia for pneumococcus. So as far as possible, we will avoid that. And this antagonism is more in immunocompromised individual. You have to be careful. And chloramphenicol with beta-lactam. Nowadays, we don't use chloramphenicol with amoxicillin or amoxicillin. It's actually antagonistic. I already said tigecycline and colistin should not be combined. What are the disadvantages when you use all these drugs? Anything can happen. One is they may fight with each other, like political parties coming to power and then fighting. Before the election, they'll all be together, right? Adverse effects. You are definitely going to increase the risk of adverse effects. For example, if you use vancomycin, okay, along with any beta-lactam, it always increases the risk of nephrotoxicity. Super infection, you may end up having a fungal infection instead of a bacterial infection. You start treating a bacterial infection, you end up having a fungal infection. Resistance may develop during the course of treatment. This frequently happens in tuberculosis, Pseudomonas infection. Last is increased cost. It's going to increase the bill for the patient. And let us look at the sum of the perfect combination. My title is perfect and imperfect. I must also give you some good examples. Trimethoprim sulfamethoxazole, you use two drugs together. Unfortunately, very difficult to get Bactrim and Septron today. You have to search. Amoxiclav, extremely good combination. Amoxicillin and clavulanic acid. Of course, overused, but it's very, very useful. Whenever there is an infection around the throat, cellulitis, wounds, human bites, which are more dangerous than animal bites. A lot of anaerobes are there in our mouth, which is the dirtiest place in the body. Overused, but it's very, very efficient. Ceftriaxone for doxycycline. You have a child who has got fever for 6 to 7 days. You're not sure whether it is entry fever or scrub typhus. You can't wait for the cultures to come. You can't wait for IgM to come. Right? On a clinical basis with the laboratory data, particularly if there is thrombocytopenia, high CRP, yes, we can give both ceftriaxone and doxycycline to cover both typhus and typhoid. It's not an irrational combination. Ceftriaxone plus metronidazole, good combination for appendicitis. Ceftriaxone plus clindamycin for somebody who's got a necrotizing pneumonia or a lung abscess to cover MRSA, to cover anaerobes, to cover pneumococcus. That's good enough, even for osteomyelitis. Miro plus Vanco plus Clinda for necrotizing fasciitis to cover Pseudomonas, cover MRSA is not overkill. You have to save the life of the child. Ceftriaxone plus azithromycin, though I criticize azithromycin, unfortunately, most of the organizations across the world, They recommend this combination for severe pneumonia above 3 years of age. The rationale is to cover all your mycoplasma and legionella, right? Second, it has got immunomodulatory action. So any child in ICU, you're not wrong, severe pneumonia, bacterial pneumonia, in adding azithromycin. Ceftriaxone plus gentamicin or vancomycin for infective endocarditis, time-tested combination is very, very rational. Ceftriaxone plus cloxacillin plus metronidazole for the brain abscess, triple drug therapy. Ceftriaxone to cover all your gram-negatives and streptococcus. Cloxacillin to cover staphylococcus. Vancomycin to cover anaerobes and MRSA. Metronidazole again to cover anaerobes like bacteroids. Doxy or cotrimoxazole plus rifampicin. Brucellosis single drug will not work. You have to use a combination drug for 6 weeks. Ceftazidime plus cotrimoxazole. Melioidosis, not very uncommon in the eastern coast. Mangalore, Visakhapatnam, Orissa, Bengal. More cases are being reported. You have to use a combination of ceftazidime, which is once a good drug for Pseudomonas. Multiple antibiotics are recommended for TB and atypical mycobacteria. Astrianome plus ceftazidime avibactam, the only gun available for your New Delhi strains, Acinetobacter and Klebsiella. And polymyxin plus meropenem are the ones which are recommended even if the strain is resistant to carbapenem. By giving both, you are increasing the chances of success. Of course, you have to monitor for nephrotoxicity. Neomycin plus polymyxin topical either into the ear or skin is very, very rational. In summary, I would say inappropriate initial antibiotic therapy, if you are too defensive, is irrational. It increases the mortality. I always believe that there are two troubles for us. One is a starting trouble, another is a stopping trouble. A starting trouble, you all know golden hour. Within 1 hour, you have to give the antibiotic. If a child is sick, yes, go in for the best available combination. But you must know when to start and you must know when to stop. Use of 2 antibiotics, in spite of my supporting the use in sick, critically ill patients, literature still says single drug is as good as 2 drugs. Routine use is not supported by evidence. That's what literature says. And in the end, I appeal to all of you. It's called Avarohanam, Arohanam and Avarohanam. You must know when to escalate and when to de-escalate. So start with big guns initially, use the right combination. And once you have microbiological evidence to the contrary, de-escalate. For example, you start with Miro Vanco, but your E. coli is sensitive to cefotaxime. You can de-escalate to cefotaxime if the child is improving. And there should neither be starting trouble or stopping trouble. In the end, it's like politics. You must choose the right party or the right combination. It holds good not only for politics, but also in antimicrobial therapy. Thank you very much. Please make your feedback. I have 2 minutes. If there are any questions allowed, I'll answer.
Thank you, sir. That's a excellent, informative, practical, thought-provoking lecture.
Sir, DCJ may say don't use ciprofloxacin below 16 years, but you have antimicrobial evidence in the laboratory. And if you have local epidemiology, you are justified in using ciprofloxacin IV. Even intrathecal we have used for ventriculitis, etc. It's not a demon, sir. Ciprofloxacin has been there for 3 decades. All the so-called musculoskeletal side effects of ciprofloxacin are highly exaggerated. It's a pretty safe drug.
Enteric fever.
Enteric fever, ciproflox doesn't work.
So in case in enteric fever, if it is with the viral high titer, single drug like ceftriaxone alone sufficient, or parenteral from ceftriaxone along with ceftriaxone oral also we have to add simultaneously.
there is no need to give 2 drugs for enteric fever. If you have proof for a typhoid or paratyphoid, 1 drug is enough.
Okay, sir.
Fortunately, most strains in India continue to be cephalosporin sensitive. Ceftriaxone, if the child is ill, followed by de-escalation to cefixime, completing 14 days course is enough.
Okay, sir.
Oral azithromycin as a single drug
Okay,
is as good as cefixime orally. In fact, in our own unit, I wouldn't recommend it. In our own unit, in our hospital, we have a protocol. Any sick child, we give ceftriaxone. We discharge with azithromycin 7 days orally instead of cefixime. Though this has not been validated in many studies, it's not irrational provided you have culture evidence. We have never used 2 drugs for enteric fever.
Then antiviral drugs, they won't be used as a combined drugs. Most of the times, as a single drug, we use.
The reason is very simple, sir. In fact, we have published our own data from our hospital. We compared the use of 1 antibiotic for typhoid and the use of 2 antibiotics for typhoid. The duration of fever and the time taken for deferescence was not significantly different between the two groups. And there is no data in the world which supports the combination, sir, except the recent paper from Nepal. But I wouldn't use 2 drugs. I wouldn't recommend 2 drugs for enteric fever, sir.
Why antiviral drugs, sir? Antiviral.
Antiviral drug, of course, I didn't mention about it. Acyclovir is the most often used antiviral drug, which is definitely useful in herpes simplex encephalitis. If it is only meningitis, it's not recommended. Unconscious patient only, you should use acyclovir. Aseptic meningitis, no acyclovir, because acyclovir is very effective in neonatal sepsis. Late onset sepsis may be due to HSV. You have to treat aggressively. You have to send the CSF PCR and treat it. You can't afford to miss it. Antibiotics won't work. And of course, in complications of chicken pox, severe herpes simplex gingivostomatitis, you may have to use acyclovir. Oral in mild cases, in CNS infections, IV, followed by val acyclovir orally, which has got very good bioavailability, as good as acyclovir.
Thank you, sir.
Is there one out of topic question, sir? Because your word goes a long way for the older delegates. Combination of mefenamic acid plus paracetamol.
Combination of mefenamic acid is Ganga Pani.
It is going.
It should not be used. It should not be used.
But it is rampantly used in the last dengue season we have seen.
Mefenamic acid is not a safe NSAID. And why worry about fever? What if it is 103? The child is otherwise active. What are you going to do? Let us not kill children with NSAIDs when they are going to recover on their own with viral infection. Even in dengue, what are you going to do? Treating fever is not going to help. Fever is fever. The fear is what somebody was joking. Somebody was asking, what is the most common symptom of COVID-19? It is not fever, it is fear. And that's what we have been treating for the last 2.5 years without success.
One
last question, sir. So one last question here, sir.
Practice. I understand it, but does it attract medical legal client attention? And because
if you have a culture positivity and if you have no other alternative, if you use quinolone, I will defend you even in the Supreme Court. That's all. See the problem. I'll just give you an example. All of us know Stevens-Johnson syndrome can develop secondary to anticonvulsants. Yes or no? Yes. Anybody can develop, any drug can cause Stevens-Johnson syndrome. If you have a correct diagnosis of complex partial seizure, you start carbamazepine with EEG proof, with correct diagnosis, you explain to the parents the risk of Stevens-Johnson, rash, etc., and the patient develops, you can save yourself. The problem is, if you use cotrimoxazole for somebody who has got half a day fever and the fellow develops Stevens-Johnson, the court will not leave you. But if you have a UTA, which is where the organism sensitive to only to ciprofloxacin, even if it is a newborn, if you use it, You can defend yourself in the court of law.
I mean, does it come?
When there is no safer alternative, you can use it.
Can I say it is off-label use?
Pardon?
Off-label use, sir.
It's not off-label use. It is label use. What is the question? Let this DCJ allows the combination of ofloxacin and azithromycin. We should sue them actually. We should sue the DCJ. It should be the other way. See, they have just, the DCJ unfortunately has introduced this rule 15 years back. And they don't have the time to revise. I don't think it is criminal to use quinolone. Only thing is, you must have a clear-cut indication with microbiological support. That's all. Because if you ask me, do I use quinolones? Yes, I do use ciprofloxacin for Pseudomonas, for cystic fibrosis, immunodeficiency children, and I do use ciprofloxacin for MRSA if it is sensitive. I do use ciprofloxacin in a few cases of UTI. When I have a culture report which says it is sensitive only to meropenem, only to ciprofloxacin, I don't give the child parental meropenem. I explain and start ciprofloxacin. Nobody can sue me.
Thank you, sir.
Thank you.
Sir, one last question, sir, here.
Sir, time is up.
One last question, sir.
Kindly restrict to that.
Yes, sir. Right. How long can I wait for the response in enteric fever with ceftriaxone?
5 to 7 days, sometimes even 10 days. Only thing is, patient should stick on to you. That requires a lot of skills on your part to counsel.
Social.
I've seen typhoid fever touching not touching normal for 10 days also. If I have culture positivity, the child's appetite is okay, toxemia is not there, child is not vomiting. That 101, 102, I tell them don't look at the temperature chart. Child is better. That is one. Jokes apart, I'll be worried if you have a culture report of ceftriaxone sensitive typhoid and the temperature doesn't settle down by 7 days. I'll start thinking of complications, which include osteomyelitis, acalculous severe cholecystitis, an abscess somewhere, or even hemophagocytosis. I wouldn't be sitting quiet. The child is all right, I'll sit quiet. Child is not all right, I don't think I'll sit quiet. I'll start looking for complications. And I may, if the child is very sick, I may even escalate to meropenem.
Okay. Apart from ceftriaxone, you are going to go for meropenem.
No, I'll stop ceftriaxone. If I don't use 2 drugs at all.
Meropenem.
I will use only meropenem. If the child is very sick.
Yes.
Chloramphenicol, we don't use, sir. We don't use. I think we have safer drugs than chloramphenicol today. 100 mg per kg, ceftriaxone.
I request Dr. Raghuram Reddy.
Thank you, sir.
To felicitate Bala Subramaniam, sir. I request Dr. Raviteja to come here. Raviteja, please. Sarnfeld stage. Yeah.
Now, I'd like to invite the chairperson of the session, Dr. Raviteja Garu, Assistant Professor at RIMS, Ongole, to introduce the speaker, Dr. S. Ramprasad Garu, for the topic MIS-C management.
kindly display the CV. Babu, PPT lone second slide. Good afternoon, everyone. Yeah, I would like to invite Dr. S. Ramprasad Garu for the next session. So he is currently clinical director and consultant neonatologist and pediatrician. He's a Rainbow Children Hospital, Vijayawada. And there are so many degrees behind his name and so many journals, articles in
It's okay, we'll
journals.
start.
So, sir.
A lot of people
Thanks.
are hungry now. If you delay, they also go for lunch now.
Please, sir.
So, at the outset, I thank APPEDICON, IIP Ongole, and organizing committee for giving me this opportunity. So, coming to the topic, multi-system inflammatory syndrome in children. So we all know the COVID-19 sparked by SARS-CoV virus 2 has created a lot of malady in the world. First wave, second wave, third wave. What about fourth wave? Yesterday I thought it's over, but today I saw the news that in Berlin there are 4 lakhs cases reported. And in China again, it's around 2,000 cases reported. So are we heading to fourth wave? So let's see. All thought that children are initially not affected with multi-system, COVID virus, but soon it has affected in the form of multi-system inflammatory syndrome. And after effects of COVID shadows include initially in April 2020, when COVID first wave was coming down, there are the European centers reported 30-fold increase in Kawasaki diseases and increase in multi-system inflammatory syndrome. There is increase in autoimmune diseases like type 1 DK have been increased, and a lot of children because of lockdown have become autistic. Autistic spectrum disorder has increased. So this is all the COVID shadows what we have seen in the last 2 years. And let us see, 7 years child has presented with severe pain abdomen, suspected appendicitis, but deferred by anesthetist of high-grade fever. 8 years old has a girl has fever of 5 days, generalized rash and myalgias. Total count was normal. Platelets was 68,000, referred as dengue fever. But child continues to have persistent fever at least after 5 to 7 days also. A 2 years old girl had fever with loose stools and seizures, referred as a cause of meningoencephalitis. And a 12 years child boy admitted with headache, hypertension, referred as ICU. So at a lighter note, who antara? Missy antara, kaad antara. So it's all turned out to be multi-system inflammatory. Varied presentations are there with this Missy. So as a newborn doesn't have name, this pretty much newer disease doesn't have name, and all could they have created new names. Especially the UK group has termed as pediatric inflammatory multi-system disease temporarily associated with SARS-CoV virus 2, and US and CDC group has named as multi-system inflammatory syndrome. There are different names, but no, there are very wide varieties of presentation of these. Few children has presented very sick, requiring ventilator requirement. Child was given immunomodulated therapy, but not responded, went on to CRRT, requiring anakinra. And at the end of the spectrum, the child presented only with fever and responded to oral steroids. So there is wide variation for this multi-system inflammatory syndrome. Initially started after the first wave, temporal association. Let's see what is that. So after the, this is the first wave, COVID-19 wave. After 4 to 6 weeks, this is the MIS-C increase in the MIS-C levels. So there is a temporal, especially in the second wave also. I mean, after the initial, this is a COVID-19 peak. We are seeing here the MIS-C peak. So there is a temporal association of around 2 to 6 weeks after the COVID infection. These cases of multi-system inflammatory syndrome has been increasing. And in India, it is reported by our Balasubramanian sir. They have reported one case in 19 children in Chennai, and in Mumbai, they have reported this way back in 20. So why some children develop very severe diseases? Why some children doesn't develop any mild diseases? What is the pathophysiology? So there has been This was the previously thought pathophysiology, but recent evidence has changed in the last 2 months. There are new studies have come in. So this is the previous study which showed initially they had phase 1 where acute COVID infection, followed by phase 2 severe in adults, but not minor in children. Children will skip this pulmonary phase, and the initial infection itself will cause macrophagic activation syndrome, leading to cytokine storm and all the multi-system inflammatory syndromes. But recently what they have proposed is there are 2 types of pathogens. One is this ACE-dependent pathway, and another is antibody-dependent enhancement. What is this ACE-dependent pathway? So what happens is whenever there is viral infection, the virus spike protein, this is the viral spike protein which attaches to the epithelial surface of ACE2 receptors. The peculiar thing is here, there is one transmembrane protein surface 2, which splits the spike virus protein of into S1 and S2, which helps in the endocytosis of the virus into the cell, causing cell death, and this creates a lot of cytokine storm in the blood vessels. And second one is the antibody dependent enhancement. This is not a new thing we see in dengue virus and also in Zika virus. What happens is whenever a child gets infected with virus, they produce 2 types of antibodies. One is neutralizing antibodies and other one is non-neutralizing antibodies. So these non-neutralizing antibodies which are generated, they attach to the virus. In fact, that doesn't neutralize the virus, but helps in the filtration of this virus into the cells, stimulating macrophages and cytokine storm and MIS-C. So children who have higher amount of these non-neutralizing antibodies, we have seen antibodies 200, 150, 200, 250 also in these viruses, they have higher risk of MIS-C. Now, one thing is this transmembrane protein receptor, which have very keen inoculation of virus into the cell, is androgen dependent. That is, increased level of testosterone will stimulate the enzyme levels. So hence the severity of this COVID was seen mostly in the males compared to females, and also adults, and when there is puberty age group, it has been more and compared to children. So this pathophysiology is for almost for adolescent, and this antibody dependent enhancement is common in the children. So that's how it has been proposed now. And why some child have mild disease, why some child have severe diseases? So if the child is having early interferon response lead to rapid viral clearance and less inflammation, and there is delayed interferon response and slow virus clearance leading to severity of MIS-C. So that was the proposed. And now along with MIS-C, there is MIS-N. So what happens is in MIS-N, there are 5 things can happen. I mean, if a pregnant mother, this is red circle with plus is positive mother. If a mother is positive, in the first week, child can be asymptomatic, but can get infected from the mother 2 to 4 weeks after the birth. This is called late onset neonatal COVID-19. This is a COVID infection. Now, in the second case, mother is COVID negative. Baby also is COVID negative, but had COVID-19 because of the family relatives. Third mother is COVID positive. Child is also COVID positive, might attain infection at the time of birth, COVID positive. And this child is a potential candidate for developing multi-system inflammatory syndrome in the 2 to 4 weeks of birth. Type D mother is positive, but child is completely asymptomatic. This can happen. And last one, it can also happen that mother is positive, may be exposed to infection in the pregnancy, will transfer the antibodies to the baby, and they present in the first week with the MIS-N. And we have seen a lot of cases like this. And according to the WHO reports, so the definition includes fever in less than 21 years, fever for more than 3 days, with the symptoms of either mucocutaneous inflammation syndromes like non-purulent conjunctivitis, rash, hypotension and shock, involvement of cardiac myocardial dysfunction like pericarditis, valvulitis, or coronary artery abnormalities. And in the lab, we have seen elevated troponin and proBNP, evidence of coagulopathy by elevated PT-APTT, and this is the most important, acute gastrointestinal problems. Most of the children presented with gastrointestinal problems in the MIS-C. And again, if you see the inflammatory markers, raised ESR, CRP, and procalcitonin levels, and the evidence of COVID-19 either in the form of RT-PCR positive or seropositivity. Sometimes you don't get both these things, but the parents might be positive. So exposure is also important. So if you see our data, so in the 1 to 5 years, there are about 43% of children, and 6 to 12 years, there are about, again 45%. So mucocutaneous, there are 61% of children who had mucocutaneous symptoms. Shock present in 77% of children. Myocarditis 36% was there. Coagulopathy 100% children had raised PT APDT, and GI symptoms were 67%, which is the most common in other studies. And mean CRP was very high when compared to ESR, and mean antibody titers were 63. 6 patients were negative. That's what I was telling. Were negative for both RT-PCR and antibodies, but clinical picture and their association on mothers, parents having exposure have been made the diagnosis of MIS-C. So clinical features, inflammation, it affects all the system. Whichever the system is affected, those symptoms are more common because it doesn't left any system. All the systems are involved, especially if you take heart in MIS-C. In our study, children presented with shock in almost, 78% presented in shock. LV dysfunction, especially less than 35% of severe dysfunction, around 16% presented. Coronary artery abnormalities were there in 29%. Pulmonary hypertension was also there in 4% of children, and raised cardiac markers are there in 29%. So it's very important that any sick child, if you see in OPD, especially if you suspect MIS-C, if the child is in shock, please don't, you have to give fluid bolus, you have to start inotropes, but please take care of look for the cardiac dysfunction in all case of shock this season, because that could be a potential case of MIS-C. Careful fluid and inotrope titration, because if you don't want to fluid overload the child, and early immunomodulation, because just giving antibiotics doesn't is enough for these MIS-C cases. Early immunomodulation is the key for treatment in these cases. We'll come to that in the last. And lungs. So as an acute COVID infection, pneumonia and ARDS is very uncommon in MIS-C, but the breathlessness is mostly because of pulmonary edema, LV dysfunction, or pleural effusions, and cough as a symptom is rare. Other systems like CNS, hematology, it could be very mild like headache, dizziness, to severe symptoms like child having seizures, encephalopathy, and coma, and almost few cases brain death was also there. If you take hematology, there will be cardiac thrombus, intracardiac thrombus was there. It could be thrombus in the sagittal sinus thrombosis or deep vein thrombosis. Those sort of spectrum of cases were there. With simple cases like increase in PT, APT2, formed thrombus was there in some of the selected cases. So skin, as I said, skin and mucocutaneous symptoms were detected. So any type of rash except vascular was found, morbilliform, scarlatiform, any type of rash was found in these cases with MIS-C. And mucocutaneous sign, especially conjunctivitis, subconjunctival hemorrhage, cracked lips, as in Kawasaki disease. Especially what we have seen is any child who present with this sort of subconjunctival hemorrhages, they are very sick, and they become very sick and require a lot of immunomodulation. They are refractory to primary immunomodulator therapy also. So, and this is an interesting presentation in our MIS, and this child presented on day 2 with this clear demarcation, and we see left femoral carotid, there was thrombosis. Actually, this child ejection fraction was 20%. Day 2, child present with ejection fraction of 20%, and there was a thrombus in the left femoral artery. And we have started this child on IVIG, but we couldn't save this leg. We have to amputate this leg. So that was one of the presentation. Another child presented with fetal tachycardia outside, and when the child was born, they were observed for 24 hours at the peripheral hospital, and after 48 hours, child was referred here because tachycardia was not coming. Heart rate was around 220, 230, and when child came here, so we have to synchronize cardiac version this child to get the normal rhythm. And when we saw the COVID antibodies, it was high, where our child was given IVIG, then only his inflammatory markers came down. And another child, inborn child, presented with polycythemia. Day 1 child continues to become bad. Child had very bad increasing respiratory distress, ventilated. Again, child developed when this was a peculiar case when 2D echo was done. Coronary artery abnormalities in the day 2 child, we didn't saw till now, and coronary artery abnormalities were found. So the child was given, COVID antibodies was positive and given immunoglobulin. Then child had settled down. So few interesting cases. That's what newborns also presented very sick because of these inflammatory syndromes. So what other diseases mimic like this? So MIS-C Kawasaki disease, toxic shock syndromes, SLH, or the few differential diagnoses for this MIS-C. And if you see the age of affected persons, around 8 to 10 are commonly affected. Median age of around 9 to 10 is the for MIS-C, whereas Kawasaki usually it's less than 5 years, and toxic shock usually it's more than 10 years. Gender difference, yeah, males are mostly affected in MIS-C and the females are mostly in toxic shock syndrome. If you see the symptom wise, there was hypotension is there in all present, but it's usually it is present in toxic shock syndrome. It was also there in MIS-C. Fever was there in almost all these differential diagnosis feature. Gastrointestinal symptoms were the most common, almost always present in the MIS-C, where it could be present in rest of the cases. And mucous membrane element is most classical presentation of Kawasaki disease, and it may be there in other diseases also. And the underlying etiology, if you see, assumed to be post-infectious SARS virus antibody, this one. And we have typical of streptococcus and staphylococcus in toxic shock syndrome. Lymphopenia is one thing which has been seen in most persistently in all cases of MIS-C and also in some few cases of toxic shock syndrome. And predominant manifestation, that's what I was talking. For MIS-C, it was gastrointestinal. For toxic shock syndrome, it is more of rash and hypotension. And management will discuss. So other tropical infections, what we have to discuss is MIS-C and dengue. So mostly they share a lot of common features. So persistent fever after day 5 to day 6, which is usually unlike in classical dengue teaching. If it is persistent, we have to think of MIS-C also. High CRP and ESR, usually dengue will not have unless they are going to hyperferritemic sepsis. Normal PCV, we have high hematocrit in dengue, and lymphopenia is classical of MIS-C. So we have, and MIS-C and Kawasaki disease also share similar features. So older age group of MIS-C when compared to younger age group of KD, Kawasaki disease, very high CRP is seen in MIS-C. Again, lymphopenia is seen in MIS-C, and usually MIS-C case of thrombocytopenia, whereas Kawasaki disease case will have thrombocytosis usually. So that differentiates MIS-C from Kawasaki diseases. So what I did is we have one approach: fever with any child with gastrointestinal symptoms, shock, acute abdomen, CNS. If the inflammatory markers are raised, so neutrophilia, lymphocytopenia, hyponatremia, hypoalbuminemia, low platelet count, we will send the second line investigation. So this we have discussed in our presentation with our residents. On that night when I was in new duty, we have received a child with 8-year boy admitted with fever, rash for 5 days duration and hypotensive shock. Our resident was very clever, so he learned all the lessons. He immediately diagnosed it as MIS-C because CRP was 150, total count was elevated, hypoalbuminemia, hyponatremia was there, D-dimers were elevated. So he didn't inform me, and he started giving IVIG and methylprednisolone, and then he called me. So just when I went and saw the child, there is a peculiar thing about this type of rash, which is sandpaper-like rash, and there is cellulitis of the leg. So usually this is a toxic shock syndrome. So it's always important that we have to keep MIS-C as a diagnosis of exclusion. We have to think first infection, we have to treat the infection, then only we have to keep. So look for focus of infection in all cases. Don't jump and start diagnosis of MIS-C. Empirical antibiotics is in all cases of MIS-C with shock. Usually these cases will have COVID serology and PCR positive in MIS-C, and conjunctival hemorrhage and bradycardia may indicate MIS-C. Usually conjunctival hemorrhage, if it is there, it strongly points towards MIS-C in our cases. So coming to the management, there are recent guidelines which have been ACR, American College of Rheumatology. This is version 3 and released in 2022 February, and Elsevier article. So what they say is overall the treatment would be child with hospitalized confirmed MIS-C, initial stabilization that could be including starting inotropes, ventilation if required, giving first dose of antibiotic after sending culture, initial stabilization and supportive therapy. If COVID antibodies are positive and if you strongly suspect coronary abnormalities are there, you have to immediately start immunomodulation with IVIG with 2 gram per kg. Usually upper ceiling dose was 100. Now previously it was 70. Now it has increased to 100 grams. And adjuvant therapy with glucocorticoids, we'll discuss that one. Usually for mild cases or child in shock, I mean, you can start 1 to 2 mg per kg, but if it is refractory, you can go up to 10 to 30 mg of pulse dose of methylprednisolone. These are the drugs, alpha-1 inhibitor, anakinra. We have a little bit experience with that one. We have used for 7 to 8 patients. Infliximab, tocilizumab. These are the infliximab is TNF-alpha inhibitor and tocilizumab is interleukin-6 inhibitor. So these drugs have been used in refractory cases of this one. Antiplatelet therapy, because we have coronary artery abnormalities, we have to start aspirin in low dose of 3 to 5 mg per kg, maximum of 80 mg. Take care of platelet count should be at least more than 1 lakh. And anticoagulant therapy is also important if you have a thrombus or if you have these conditions like mild to moderate ventricular dysfunction, especially ejection fraction less than 50, that is moderate. Coronary dilatation with jet scores of 2.5 to 10. D-dimer 5 to 10 times elevated, and the thromboelastography with maximum amplitude of more than 80 mm, the clot size. We have to start prophylactic dose. What is prophylactic dose? It is 1 mg per kg of per day of enoxaparin. And if you have this child with moderate to severe LV dysfunction of ejection fraction of less than 35% with giant coronary aneurysms of jet score of more than 10 and D-dimer more than 10% elevated, then you have to therapeutic dose. That is 1 mg per kg per dose of enoxaparin BD. How many days? Let's see. So that's the overall management. So coming to the management of this MISI. So you have to identify whether the child is sick child or the child is a stable child. For a sick child, start all the guns, IVIG 2 gram per kg over 12 to 24 hours. Remember, in a sick child, you may, if cardiac dysfunction, ejection fraction is low, you may give for almost 36 to 48 hours to prevent fluid overload in them. IVIG, injection methylprednisolone 10 mg per kg per day, maximum 1 gram per day. Aspirin 3 to 5 mg per kg, maximum 75 mg per day. And contraindication, as I said, platelets less than 80,000 or bleeding, you should not start aspirin. And empirical antibiotics if strongly suspicion of bacterial infection. And when you send the blood culture, start antibiotics. Depending upon that, you can take a call. If the child is stable child, there like no shock, cardiac dysfunction, only fever was there and fitting the criteria, and it's non-KD Kawasaki phenotype, oral or IV methylprednisolone 1 to 2 mg per kg, that should be fine. And if the child was having KD phenotype, then IVIG 2 gram per kg per day with methylprednisolone and aspirin has to be added. So this is how the management of MISI goes. And if there is no response after 40 to 72 hours, persistence of fever or persistent end organ dysfunction, then what we have to do is the other immunomod. There is no second dose giving of this IVIG because it can cause fluid overload in a sick child or it can cause hemolytic anemia. So there is no second dose of IVIG. So anakinra 4 mg per kg per day, interleukin, we have given almost 7 patients. We have lost 1 child, but other child recovered very well. And it's preferred if there is organ dysfunction, especially hepatobiliary, metabolic acidosis, hyperferritemic sepsis is present. Anakinra is preferred. Infliximab is usually preferred if the child has features of Kawasaki-like picture, especially coronary abnormalities are there. Infliximab is preferred. And make sure that it should not be given with macrophage activation syndrome because the main culprit is not TNF-alpha. So, as I said, IVIG infusion over 12 to 36 hours, slower if there is underlying cardiac dysfunction, dosing according to the ideal body. Remember, its maximum ceiling dose is 100 grams. Now, change to methylprednisolone oral if the child is stable, accepting orally. You can continue low dose. If abdominal symptoms continue, you can continue IV also. Taper 25% every week, and you can give over 2 to 3 weeks. You can stop over 3 to 4 weeks also. And enoxaparin, as we discussed, if the coronary artery jet score is more than 10, documented thrombus less than 35%, you give therapeutic dose of 1 mg per kg BD. Discharge advice, usually these children should be discharged on aspirin for 4 to 6 weeks. Check the 2D echo every frequently second week, after 1 month, after 2 months, depending upon cardiologist advice. We have to check then only we have to stop aspirin when coronaries are completely normal. Echo at 2 weeks, that's what I was discussing, 6 months and 1 year. Anticoagulation. So for that child, newborn, we are given for almost 2 to 3 months. When the complete clot has resolved, then only we have stopped the enoxaparin. So it depends upon the complete resolution of the clot, where it is, and vaccination after counseling of IVIG and steroids. So coming to the last slide, take home message would be usually consider MISI as a DD in all patients with fever. but you have to think of alternate diagnosis. It's a diagnosis of exclusion, as I said. So CRP is a better screening tool than ESR. Both underdiagnosis and overdiagnosis is possible, as closely mimics several other tropical diseases. Timely diagnosis and early immunomodulation is very, very important. It is the key to the good outcome. Thank you all, and thank you, Team APPEDICON.
Thank you, sir. Thank you for the beautiful, elaborative talk on Missy, and thanks for accepting our invitation. I ask Dr. Raviteja Garu to felicitate the speaker.
Sir, thank you. That's a nice presentation. So most of my doubts are also cleared. So during after the second wave, because of non-affordability for some patients, we could not give IVIG, but they responded well with only methylprednisolone. Yes, but WHO has not changed its statement. WHO still says every patient diagnosed with MIS-C must be given IVIG. It has not changed its statement for the last 2 years.
Just follow up the child. You just follow up the child. So IVIG, yes, immunomodulation definitely has to be given for a sick child, but India, everything is
That division is not done by the WHO.
Versus IVIG and IVIG plus MPS, we've proven that steroids are as good as effective in preventing the complications, and short-term outcomes are good, but the long-term outcome regarding coronary artery dilatation is not yet there. So they're telling inaffordable places we can try as first line MPS, and even Indian guidelines have changed it to MPS for a stable patient. Only for sick patients we need to do combination high dose of MPS and IVIG, but stable
for
patients,
stable
only
child, you can give methylprednisolone. That's
only
what. Yes, that's what.
Thank you.
He has been doing a lot of work at Rainbow. He has tried many prospective pediatricians under his tutelage. I am very proud of him.
Prophylactic anti-insulins, properly, proton inhibitors, sir. So, thank you.
I'd like to invite the chairperson of the session, Dr. Jagadish Garu, to introduce the speaker, Dr. B. Revant Garu, for the topic management of viral myocarditis, the agony and the ecstasy.
Dr. Revant Balneni, he did his MD from JIPMA, DA from CMC, and ID PCCM from Kanchkam Koti Child Trust Hospital. He's the consultant pediatric intensivist and allergist working now in Andhra Hospitals, Vijayawada. Welcome, sir.
Thank you, sir, for the kind introduction. And without wasting much time, we'll move on to the topic. So So my topic today is acute viral myocarditis. And so though we'll feel it is a very rare diagnosis, but we often miss the diagnosis, and child land up in severe shock stage coming to the tertiary care hospital, and many won't survive that stage. So we'll go through various case scenarios, how to suspect viral myocarditis, how to intervene in the periphery center, and how to refer them to the cardiac center. So the objectives of my talk is when to suspect, how to diagnose, how to stabilize these children, and is there any role for immunomodulators in treatment, and how to treat refractory shock in myocarditis, and finally the outcome. So we'll start with the case scenario. So this is a 6-month-old child. The common presentation, we'll just every afternoon we see in the OPD. So 3 days history of cough, cold, fever, and suddenly they'll come with the breathlessness on day 4. So they also complain poor feeding, excessive crying. So what are DDs we'll suspect in this scenario? So anyone? It's a commonest scenario what we'll face day in and day out in the OPD. So could be any viral infection, any LRTA. So URTI going towards LRTA. So first diagnosis we'll think is bronchiolitis, pneumonia, bronchopneumonia, bacterial pneumonia, because poor feeding and excessive crying also they can think bacterial pneumonia. So on top of that, because of breathlessness was there, you have to suspect cardiac disease as well. It could be an underlying cardiac disease child presenting to us with the precipitated by a fever, or it could be an acute cardiac disease, which is myocarditis. So from that case scenario, we'll move on to 2 different scenarios. The same child, the scenario 1, he's having high-grade fever spikes. And on examination, you see child was febrile with a temperature of 103 degrees Fahrenheit, having a toxic loop. The respirator was 60, diffuse wheeze and Krebs. So wheeze is more than Krebs, and the significant retractions with low SpO2. So heart rate was 170, BP was normal. And on examination, you can find that 3 centimeters of liver down the right costal margin. But if you measure the span, which we only look for to differentiate whether hepatomegaly is there or not, it's normal. So in this scenario, what you did is you suspect? Yeah, bronchiolitis, then pneumonia. So any possibility of cardiac? Why? No, I'm not ruling out. Either can we think one DD as a cardiac in these children also? Yeah. So, but when you have tachycardia, you have to look it is appropriate to that fever or disproportionate to that fever. If you have disproportionate tachycardia, you have to suspect cardiac. But here with the 103 degrees Fahrenheit, you have heart rate of 170 for a 6-month-old child, it should look appropriate. So most likely it is respiratory. But in scenario 2, you can see the fever index is decreasing. So intensity is coming down. Child is at 100 degrees Fahrenheit, but respiratory rate is same. You have diffuse Krebs and minimal wheeze here. And heart rate was 180, which is disproportionate to the temperature of 100. So more likely in this situation, you have to suspect cardiac. What other things you have to look for in cardiac? Yeah, liver span is increased, so hepatomegaly was there, and your murmur. So if you have systolic murmur, sometimes you can get gallop as well. So in this scenario, what do you think? Second scenario. So is more likely cardiac is failure. So what are the DDs? So one could be an underlying heart disease because the murmur was there. It could be a VSD or PDA, something coming with the fever and presenting like this. Or it could be an acute post-viral myocarditis. Or it could be a dilated cardiomyopathy, which was subliminal previously precipitated with acute infection. So these are 3 DDs we have to keep when you have scenario like this. So what is the next plan of management of this second scenario? So child is in distress, suspecting cardiac. So any child comes to your OP, I'm not talking about in ICU management, I'm talking just in OP. If this child comes to OP, so what do you do next? Yeah, first stabilization. So stabilization part, because child is in severe distress, most likely hypoxia will be there. So we'll start on oxygen, so then move on to the investigations. Because there's no shock, you can go to investigation. If the child is shocking, you have to treat the shock here. So you can start how to support inside an IV line, take samples and X-ray. As I told, I take the X-ray. The X-ray was showing mild cardiomegaly with bilateral congestion features. And we have bedside echo. If you have we can do that thing. So echo was showing moderate LV dysfunction and EF is 35%. But there's no structural heart disease. There's no VSD, no PDA, nothing. So with this information, so what are DDs you have to suspect here? So moderate LV dysfunction, there's a mild cardiomegaly and X-ray. The first possibility is post-viral myocarditis. Second possibility, yeah, DCM presenting with acute infection. So the two possibilities you have to keep here. So with this background, so when to suspect myocarditis first of all. So already we have been discussing something about how to suspect myocarditis. So when to suspect myocarditis? Yeah. So signs of CCF preceding in viral infection, preceded by viral infection, we have to suspect. Then there is a common scenario, but it's not a common. This is a classical. What I given is a classical scenario. It is not the commonest scenario at all. It is classical. So the acute fulminant myocarditis, yeah, not present only with breathing difficulty, it will present with so many symptoms. So we'll see what are the presentation. So these are the recent publication from AHA circulation. So these are the characteristics of presentation of pediatric myocarditis. So in this we see the history of viral prodrome was there, and arrhythmias is less common, and sudden cardiac death can occur. And coming to symptoms, the most common symptom is most likely shortness of breath. But there are few children who can present with only GAT symptoms. Nausea, vomiting, or abdominal pain without any of these symptoms. Even without distress, they can just come walk to you with nausea, vomiting, and abdominal pain. So we need to suspect myocarditis even with persistent GI symptoms, not even having breathlessness, when it is not explainable with your common GI problems. Sun, rhinorrhea, cough, and coming to signs, definitely tachypnea, tachycardia, hepatomegaly, signs of CCF will be there. And there is a common study that found that in acute fulminant myocarditis, where the EF is very low and children is shock, but often the symptoms are not cardiovascular symptoms. It's mainly GIT. So coming to when to suspect, already we discussed it, disproportionate elevated heart rate and resting tachycardia. This is the commonest thing. If the child had resting tachycardia when there's no fever and child is comfortably sleeping, then it most likely to myocarditis. There is a new onset cardiac failure. Even without fever, nothing, child is coming to cardiac failure, new onset, you need to suspect myocarditis. Any chest pain, syncope, palpitation, a febrile child, you need to suspect. Persistent GI symptoms, not explained by common GI causes. And any cardiomegaly and pulmonary on X-ray. And last thing is new onset arrhythmias. It could be a heart block or it could be tachyarrhythmias. So what other investigation we proceed with this child? So you take an X-ray, we done echo, we confirmed it could be myocarditis or it could be DCM presented with acute infection. So then I move on to ECG, cardiac biomarkers. Most important thing, we suspect viral myocarditis, we need to check what virus is causing this. It could be a treatment perspective as well, and it's a prognosticative perspective as well. So what are common panels we'll send is, we'll look for respiratory viruses. Most common thing is respiratory viruses. We can send a nasopharyngeal swab for viral PCR. What we are doing is this PCR film arrays, bioarrays. So we can do that thing. Even GIT viruses can also cause. So if you're not able to find in respiratory panel, you can send a GIT panel to confirm the virus. And final thing is to confirm it is myocarditis or DCM. We have two options. One is the cardiac MRI, and second thing is myocardial biopsy. So biopsy is more invasive, so we can prefer MRI. But even with MRI, if a child is very sick on inotropic support, we cannot perform MRI. So we, based on clinical things only, we have to proceed. So how to stabilize this child? So you suspected low EF, myocarditis but DCM. The main way stabilization is antifibrotic medication. So we need to increase the inotropicity of the heart by giving milrinone or digoxin. So now we are not giving loading dose of digoxin. We are just avoiding that thing. We are just proceeding with the milrinone or dobutamine. So then once child is stabilized, BP is normal, we can go for diuretics. But when giving diuretics in a CCF myocarditis child, be careful that they can land up in shock. So try to give slow doses or infusion. And once the child is stabilized in the weaning phase of milrinone, IV drugs, we can switch out to oral AC inhibitors or beta blockers. So what are the echo findings in myocarditis? you can see mild to moderate or severe LV dysfunction or regional motion abnormalities. And there is a variable degrees of LV enlargement. If you have LV dysfunction, which is disproportionate to the LV dilatation, it could be myocarditis. In DCM, the dilatation and the LV dysfunction correlate each other. More dilatation, less CF. Mild LV dysfunction, there will be mild dilatation. So this is disproportionate here. And thickened myocardium due to wall edema. And pericardial effusion can be there, intracardiac thrombus can be there, and you can have mitral regurgitation, functional mitral regurgitation. That's why the child has systolic murmur. So coming to ECG, what are the findings in ECG? So already we know tachycardia will be there, it could be sinus tachycardia, but the most common important thing is STT changes. It could be depression, it could be elevation or T wave inversions. The same thing can be seen in pericarditis as well. The myopericarditis combination will commonly encounter. And low voltage QRS in the limb leads, and you can have conduction delays. Either PR interval is prolonged or QT interval is prolonged. And we can have any degree of arrhythmia. It could be heart block, it could be ventricular tachycardia, it could be atrial tachycardia. So this is the ECG where you can see the QRS is low voltage, and you can see ST changes here. So this is the X-ray which is showing cardiomegaly, and so there is congestion bilaterally. So we can see here, this is early phase of pulmonary edema. So where there is a congestion, perihilar congestion, and there is a cephalization of vessels, and presence of curly vein in the peripheral 1/3. Usually we won't see in the peripheral 1/3. So that's the thing. So coming to biomarkers, these are the most important things which will differentiate acute myocarditis from DCM. So we'll in dynamo whether we're dealing with acute myocarditis and DCM. The most important implication here is whether to give immunomodulation or not. The immunomodulation is proven it will be benefit in myocarditis, but it's not useful in DCM. So to spend that much amount of money by the parents, we need to differentiate strongly this myocarditis and DCM. So cardiac biomarkers, what you can use troponins and the CPK-MB, but the most importantly, troponins are most commonly elevated than CPK-MB, and the rise is depend on the duration of the illness. So on the timing of the testing. So in children, troponin T is reported as a specificity of 86% and sensitivity of 71%. So we can use troponin to differentiate myocarditis from DCM. But however, if you have normal troponins, it cannot rule out myocarditis. Take this point. So it can differentiate, but if you have normal, if you have high suspicion of myocarditis, you have to go ahead and treat. You have to correlate with other things as well. So some non-specific markers are there like CRP, ESR, which can depict inflammation. They can be raised as well, but it's not always seen. So coming to MRI, so MRI is the modality which can confirm myocarditis, and it can differentiate it from DCM. So what you can look for is high signal intensity T2 weighted imaging and increased T2 T1 times. So which will denote it is edema is there. And gold standard and thing to diagnose myocarditis is biopsy. If you see inflammatory cell infiltrates and myocyte necrosis, which cannot be explainable in any other case. In adults, the common differential diagnosis is MI. They will come with elevated troponins. This infiltration will be there in MI as well. But in children, it's rare. So if you see this kind of inflammatory cell infiltrates and myocyte necrosis, most likely it's myocarditis. So already we're discussing, say the child is presented with acute viral, post-viral illness with myocarditis, or it is an underlying DCM coming with acute infection. So this is the table we run to differentiate myocarditis from DCM. So the duration of illness in myocarditis from the onset of the viral prodrome is more. So it lags from 1 to 4 weeks. But in DCM, with acute infection, the child deteriorates. So it will come with less duration. And presentation with shock is more common in myocarditis because the function deteriorates very rapidly. But in DCM, the function is already impaired and they came with acute infection. So the shock is not that common. Arrhythmias is more common in myocarditis than DCM. And X-ray, there is a mild dilatation. But in DCM, we have moderate to severe dilatations. ECG changes are more common in myocarditis. And in echo, you can see that increased wall thickness in myocarditis, and the LV dysfunction is disproportionate to the dilatation of the LV. And cardiac biomarkers are elevated in myocarditis, and MRI and biopsy can differentiate them. So let's move on to the next case scenario. So this is a 6-month-old child presented with a history of fever, cough, and cold for 3 days, and breathlessness on day 4, poor feeding activity. So we've seen heart rate of 180. There is a low BP as well in this child. So this child is in shock. So there's a low volume pulses, cold peripheries, gallop was there. So this is a case of myocarditis with shock. So this child was seen by local pediatrician. He supported the child with O2 mask. Because of shock, he started IV fluid bolus. What will happen if you give bolus in a myocarditis child with shock? Usually child will worsen. So because of worsening pulmonary edema, child has worsening distress, and child was being referred to the higher center through ambulance. The transport time is about 1 hour. So by the time child reached our hospital, child is in gasping, profound shock, and hypoxia. So we have done the resuscitative methods, but we couldn't able to save the child. So how to modify this scenario? How can we do better in this scenario when you see a child in your OP or ER? So you have to suspect myocarditis if the child had the features. So acute onset illness with CCF, you need to suspect myocarditis, and we need to initiate inotrope as early as possible. This is life-saving. Instead of fluid bolus in this child, I should have gone for a inotrope. But some children can come with dehydration because of excessive vomitings, not taking food properly, feeding properly, they can be dehydrated. Then you can try fluid bolus. That is a slow bolus, 5 ml per kg or half an hour, not like your 10 ml to 20 ml per kg or 15 minutes. Even in hypotension, you have to give slow bolus. But before giving a bolus, if you start an inotrope, that's ideal. But the majority of times you cannot start the inotrope because you have to get adrenaline, you have to load that thing. So you can try a fluid bolus slowly. Meanwhile, you ask the sister to arrange for the inotrope. The most common inotrope we can use safely is adrenaline in hypotension. If the child is not in hypotension, you can start dobutamine. But if child is in hypotension, we need adrenaline. Adrenaline is the only recommended drug if the child is in hypotension. Adrenaline can be safely given in peripheral line. Remember this. There's the most common doubt for every local peripheral pediatrician is, no, I should not start adrenaline in this child. It can cause thrombophlebitis, it can cause limb ischemia, or it can cause arrhythmias. But rather than sending the child straight away without any support, by starting adrenaline, you can save that child. So it is safe. Even in our ICU, we'll give adrenaline in peripheral line. We have managed of MIC children even without central line because they have thrombotic risk. We avoided central line. So we'll put peripheral line, we'll go with the dilution of this much, 0.15 mg per kg in 50 ml NS. It will give 1 ml, will give 0.05 max per kg per minute. So this is the safest thing. You can start with this dose. We have run this dose for 24 to 48 hours, even without single thrombophlebitis. So take my word, you can start adrenaline safely at the peripheral level also. And transfer the child after contacting the local hospital. If they come and take the child with own ambulance, with all facilities, it is safer for that child. So basic consideration, even suspecting myocarditis and managing myocarditis. So though child looks stable in front of you, if you suspect myocarditis, you need to take the action. You need to try the child, whether child can be managed here or the child needs to be referred, because the monitoring is key here. The child can be in the early state of myocarditis, it can worsen rapidly. If the child start arrhythmia, it will collapse. So if you suspect the child is having myocarditis, see whether you can keep the child in your hospital. If not, refer to an ICU setup. The child needs an ICU setup with multimodality monitoring, ECG monitoring, vitals monitoring. So don't keep, if you suspect a myocarditis child, if you don't have facility to get an echo, please refer them. Because if you refer late, the mortality is high. Coming to supportive care, the respiratory support is main. So positive pressure helps these children. The PEEP is an inotrope here. The PEEP will decrease the afterload, will decrease the freeload as well. So it will act as an inotrope. And inotropic support, I told hypotension, adrenaline. If the child is in normotension, you can give milrinone or dobutamine. Diuretics only if the child is shock is stabilized. Don't give diuretics in shock phase. That's the commonest mistake. Child is desaturating, hypotension is there. Our priority is to make the saturation up. No, the priority is BP. Hypoxia, you can manage, you can intubate, you can connect to ventilator, you can bag the child. But once the child lands in profound hypotension, child will not come out. It will decrease the further cardiac compromise because the circulation to compromise, even coronary is compromised. The further ischemia, further drop in EF, child will collapse. So don't try to give Lasix bolus because it causes vasodilation. The BP will fall further. Some antiarrhythmic drugs. So depending on the arrhythmia, you can try what antiarrhythmic drugs, and pacing, intravenous pacing is possible. And you can sometimes you have to insert a defibrillator to the child. And the last one is the refractory cases. We have started adrenaline, we have intubated the child, we have supported him, but the shock is not getting corrected. We've done all the things, maximum number of drugs we have used, but still shock is not getting corrected. Then we need mechanical circulatory support. The most important thing is ECMO. So this is the algorithm which is showing the mechanical circulatory support. If you have cardiogenic shock and cardiorespiratory compromise, significant arrhythmias, the first option is ECMO. And if you have pulmonary function is preserved and only cardiac output is less, you can try short-term devices. This Impella, ECMO is, you can do. If the child is recovering, you can stop it, or not recovering, we need to go for other drugs. And last thing is, this is the durable devices for the chronic cases. Any specific therapy? Till now, we discussed only thing supportive therapy. Child is in shock, support it. Respiratory distress, support it. Give diuretics. Then mechanical circulatory support. But is there any modality which can stop the progression of myocarditis, or it can revert the myocarditis? So there are two things. One is antiviral therapy because it's most commonly followed by virus. And second thing is immunomodulated therapy. So before going to this therapy, we need to see what is the pathogenesis of myocarditis. So this is the pathogenesis of viral myocarditis. You can see here, this is a viral infection, which is the trigger. It can trigger the immune response. The first thing is the virus get eliminated and inflammation will heal off. Then your myocarditis will be normalized and your EF will be normal then. The second thing is your injury is very severe. So virus elimination done, inflammation is getting healed, they'll land up in DCM. So in children, when you see what the cause of direct cardiomyopathy, the 50% of the children will have preceding myocarditis. And second thing, the viral elimination is done, but there's a persistent inflammation. It is inflammatory cardiomyopathy. It's like autoimmune phenomena. Here you need immunosuppression, immunomodulation here. And the third entity is chronic viral inflammation. Will have inflammation as well. So this is called viral heart disease. This is a chronic viral myocarditis where you need antiviral treatment along with immunomodulation. The same thing, acute myocarditis, you can try antiviral agents or IVIG. In post-infectious second stage, autoimmunity, you have to use immunomodulation, including steroids. And if you have chronic viral cardiomyopathy, which can be caused by all these viruses, there's specific agents, specific antiviral agents are there. If you identify a virus and you prove that there's still myocardium containing the virus with biopsy, we can try all these drugs. So coming to immunomodulation, so we have seen the pathogenesis that autoimmunity is a future, high inflammation is a future. We can try immunomodulation, but there's no proven study yet. Even in adults, even in children, there are a lot of studies, lot of meta-analysis, systematic reviews has proved that still immunomodulation is controversial. One meta-analysis say that it is beneficial. Next, remaining other meta-analysis tell it is not useful. Even in short-term outcome, long-term outcome, it is not benefit. So the studies in less in pediatrics, even in adults, the RCTs are very less. So there is no conclusive evidence. Even 2021 guidelines by American Heart Association, they are tell it is controversial. So whether you want to give, you try. If you don't give also, it will not harm. So there's no proven benefit, but our unit protocol, we have treated so myocarditis say like 50 in the past 5 years. We have given IVIG and MPS for every children if the criteria for myocarditis are satisfied. Biomarkers are elevated, LV dysfunction is disproportionate to LV dilatation. There is no past history of this CCF in the past. So we have tried IVIG with MPS. We got a benefit, even childless and ventilator on 3-4 inotropic support, they recovered. But I cannot tell that this is because of IVIG child improved or the disease process is improving. We cannot prove that. So we have our experience is that IVIG and MPS is beneficial if you try early, but whether the benefit is because of this or the disease process itself is improving, I am not sure. So if you have a child with myocarditis, if you want to try IVIG and MPS, please try. It's not going to cause the harm. But whether it is beneficial for that child, that's no answer. We need a lot of studies, RCTs mainly. So coming to outcome, this is the largest follow-up biopsy proven study for myocarditis. In that, 50% of children has low EF. So they land up in DCM. And 6 to 7 died with fulminant myocarditis. And almost like 15-20% required transplantation in 3-year period. So what are the predictors of poor outcome? So we have seen we have managed myocarditis, then we have to know. So what are the predictors for poor outcome? Infant, less than 1 year, neonates with myocarditis is a poor outcome. High CPK at the admission. Ejection fraction less than 30% is moderate to severe LV dysfunction. And left ventricular dilatation and moderate to severe mitral valve regurgitation. This is the sign of poor outcome. Any atrial ventricular tachycardia in early stage or wide QRS in the late phase is a poor prognostic indicator. So coming to take home messages. So myocarditis children remain challenging condition even to diagnose and manage. And most children with acute myocarditis, initial preventive is other symptoms other than cardiorespiratory symptoms. So you have high index of suspicion to suspect myocarditis. Early diagnosis and treatment, initiation of treatment early, supportive care plus or minus immunomodulation can save the life. And timely referral, this is the most important point I want to stress. The timely referral is the most important thing to improve the outcomes. So if you suspect myocarditis, you don't have any facility to monitor them and treat them, consult the referral hospital, let them come and take the child. Don't refer the child straight away. The child is in shock, at least put the child on some support. If you start dopamine, fine. If you start adrenaline, fine. But you can safely start them in the peripheral line and maintain the child there itself, monitor the child and call the referral team to come and take the child. So it will save the life. Thank you.
Thank you, sir. It's a very lucid presentation. Any questions from the audience? Thank you, sir.
Thanks.
Madam, please arrange fill station.
I'd like to request Dr. Jagadish Garu to felicitate Dr. B. Revan Garu. And for the next session, I would like to invite Dr. B. Anjaya Garu, RIMS Director and presently at Katuri Medical College, and Dr. Tanir Garu, Assistant Professor of Pediatrics at Katuri Medical College, to introduce the speaker, Dr. Upendra Shava Garu, for the topic GERD current guidelines.
So, my dear fellow pediatricians and the students of PG students of various medical colleges, good afternoon to all of you. At the outset, I thank the organizers, particularly Dr. Muralidhar Reddy and Dr. Nagaya Naidu for inviting me for this function. I had the great opportunity to establish the Rajiv Gandhi Institute of Medical Sciences at Ongole. I worked for 7.5 years. I had the occasion to establish a medical college with the help of all practicing doctors at Ongole. I thank them on behalf of the next thing is myself for helping me in establishing this medical college. So today, we are going to have a very good lecture on GERD, gastroesophageal reflux disease. There are two entities. One is GERD and one is GERD. GERD is involuntary entering of the stomach contents into the esophagus without any symptoms. That is called gastroesophageal reflux. Gastroesophageal reflux disease, involuntary entering of the stomach contents into the esophagus with the symptoms is GERD. Now we are going to hear the important lecture which is very helpful for PG students. by Dr. Upendra Shava. And before starting the medical, before inviting the guest speaker onto the dais, I request Dr. Tanveer to read the biodata of Dr. Upendra Shava.
Good afternoon, everyone. It's a very good privilege for me to introduce Dr. Upendra Shava. He did his MBBA, MD Pediatrics from PGI Chandigarh and DM Gastroenterology from SGPGI Lucknow. And he is trained in advanced pediatric endoscopy at Hyderabad. And he is working as a pediatric liver transplant. He is working as a gastroenterologist in Vijayawada. I have attended many of his lectures. He's a wonderful speaker and very good gastroenterologist working here, covering even Guntur and Vijayawada. We welcome you, sir.
Good afternoon, everyone. First of all, I would like to thank IAP team for inviting me here to give a lecture on this common clinical scenario we routinely see in our daily clinics. So I would like to start the lecture without wasting any time. So this is gastroesophageal reflux disease. It's a very common clinical situation we come across in our daily clinical pediatric clinics. So as sir was saying, gastroesophageal reflux is a physiological phenomenon commonly seen in all young infants. It is just a passive reflex of the stomach contents into esophagus. So they don't have any other significant clinical features and are there well thriving happy children where we label them as happy spitters. So other condition is gastroesophageal reflux disease, where this gastroesophageal reflux is causing some troublesome symptoms to the children. So it may be due to significant calorie loss due to vomiting of the ingested food material, or as a consequence of esophageal injury or respiratory tract injury due to these acidic gastric aspirates and gastric contents. So there we call it as gastroesophageal reflux disease. So there are multiple protective mechanisms already inbuilt in our system to protect either esophagus or respiratory tract from these passive reflux of the gastric contents. And esophageal protective mechanisms include lower esophageal sphincter, where it acts as a mechanical barrier to prevent the gastric contents refluxing into esophagus. Along with this esophageal sphincter, which persistently maintains the tone except when we are swallowing, esophageal peristalsis causes relaxation. It acts as a one-way valve. So along this lower esophageal sphincter, others like crus of diaphragm both, and a small segment of lower esophagus is within the abdomen. It also acts as a lock. Whenever intra-abdominal pressure is increased, stomach contents tends to reflux into the esophagus, though this is a small part of abdominal esophagus gets collapsed and prevents reflux of this gastric contents. And also the angle between esophagus and stomach, gastroesophageal junction angle, we call as angle of His. It is acute and it also contributes to mechanical protection against reflux of the disease. These are the normal physiological protective mechanisms we have to prevent GER. So along with this, esophageal has other mechanisms like its clearance. It regularly has peristalsis to clear any small amounts of gastric contents reflux into the esophagus. And also these mucosa secretes bicarbonate, which neutralizes any remnant gastric acids in the esophagus. Even swallowed saliva also helps in buffering the small amounts of gastric contents refluxed into the esophagus. So whenever these protective mechanisms are disturbed, as in impaired salivary secretions or any impaired mucosal defense due to either commonly we see as eosinophilic esophagitis or corrosive injuries, post tracheoesophageal repair where esophageal anatomy is disturbed, or some hiatal hernia or any delayed gastric emptying, increased gastric secretions for any other reason. All these factors promote gastroesophageal reflux, causing gastroesophageal reflux disease. Similarly, airway is also protected with some mechanisms like upper esophageal sphincter similarly acts as mechanical barrier, and this reflex of gastric contents induce vagal stimulation, which causes esophageal glottal closure reflex and even sometimes centrally mediated reflex apnea to prevent aspiration of these gastric contents into lungs. So even pharyngeal clearance like cough reflex, and if small amounts entered into the aspiration, ciliary motility mechanisms clear the airways. So all these are protective mechanisms to prevent airway from these reflexed gastric contents. So and in contrast to adults, younger infants have some predisposing factors for getting more amount of reflex, like predominantly they are horizontal position, particularly young infants, and length of the esophagus is also short, and some anatomical defects of larynx or some neurological disorders, neurodevelopmental disorders, all these predispose younger infants for more risk of gastroesophageal reflux. And even exaggeration of asthma in is two important mechanisms were proposed for exaggeration of bronchial asthma in patients with GERD. One is direct aggravation of inflammation or hyperresponsiveness of airways by microaspiration, gastric contents directly aspiration into the bronchial tree and causing hyperinflammation. And other is vagal reflexes. These induce airway hyperresponsiveness and bronchospasm. These two mechanisms are proposed for exaggeration of asthma in patients with GERD. So coming to prevalence of GERD in infants, so it is almost 50% of young infants till 0 to 3 months of age, they have reflux, and slightly increases by 6 months, but by 1 year of age, almost only 5% of children persist to have GER, only reflex. And even children with the GER, only a small proportion of total children with who are having gastroesophageal reflux, only 5 to 10% of them have gastroesophageal reflux disease. Only 10% of reflux children have some troublesome problems. And by the age of 3 to 9 years, it further decreases to 2% yearly. But adolescents slightly have higher prevalence of GERD, almost similar to that of adults. It's around 3.5% of older children or adolescents have GERD. So when to suspect? These are the common clinical presentations of GERD. It's slightly vary in younger infants and older children. Younger infants predominantly present with discomfort, excessive crying, irritability, failure to thrive, feeding refusals or feeding problems. This typical dystonic neck posture we call Sandifer syndrome. Due to severe esophagitis, they arch back intermittently. And older children mostly present with typical dyspeptic symptoms, like in adults, chest, midline chest discomfort, heartburn, epigastric pain, even severe esophagitis can cause hematemesis, recurrent regurgitation, either with or without vomitings. Even some children present with long-standing GERD resulting in complications like esophageal strictures, peptic strictures, causing dysphagia. So all these are esophageal related complications. These GERD can also be associated with extra esophageal symptoms like respiratory symptoms, recurrent wheezing, stridor, cough, laryngeal symptoms like hoarseness of the voice, dental erosions can be seen in younger children. These severe erosive esophagitis can cause blood loss and anemia. These acute life-threatening events are also reported with GERD, exaggerations of asthma, recurrent pneumonias due to aspiration, and recurrent otitis media. All these are extra esophageal manifestations we sometimes come across in children with GERD. This is the same chart showing some features are predominantly seen in young infants. As we are discussing, excessive cry, irritability, vomiting, feed refusal, failure to thrive, all these are more commonly seen in infants, whereas adolescents and older children present like adults, like heartburn, epigastric pain, dysphagia, chest pain, esophagitis. These are more common in older children. So as we are discussing, some factors or some clinical conditions predispose infants or children more to GERD. These are neurological disorders. We commonly see cerebral palsy, some congenital myopathies. These children are at risk of GERD, and chronic lung diseases like bronchopulmonary dysplasia, cystic fibrosis, asthma. All these children can have more risk of getting GERD. And some anatomical problems like repaired tracheoesophageal fistula they have, and also esophageal caustic injury children, and some genetic disorders like Down syndrome. These are family history of either Barrett's esophagus, adenocarcinoma of esophagus, or family history of GERD. All these predispose these children for GERD. So these are the guidelines we usually follow in our clinical practice. The Indian Society of Pediatric Gastroenterology and Hepatology has published recently in 2021 regarding clinical management of GERD. Similarly, 2018, there is both European and North American Society combinedly published guidelines for managing. So in our clinical practice, we routinely follow these two guidelines, and now I will be discussing the same guidelines. So coming to diagnosis of GERD in children, history and clinical examination. As in all other clinical conditions, here also history and examination plays very important role and a pivotal role, because in this gastroesophageal reflux disease, there is no gold standard diagnostic test. So most of the time diagnosis depends upon our clinical suspicion and examination and ruling out other causes which can present like GERD. So are commonly used investigation to support our diagnosis are barium studies, endoscopy, manometry, nuclear scintigraphy studies, pH metry and pH impedance metry, even trial of proton pump inhibitors. All these help in supporting our diagnosis. So history, age of onset of ERC, age of onset of symptoms is very important. Physiological normal gastroesophageal reflux usually onsets after 1 week of age and within 6 months of age. If features of gastroesophageal reflux onset is more than 6 months of age or persisting even after 12 months of age, then our suspicion should be high for other diseases other than gastroesophageal reflux. So age of onset of symptoms is important. Less than 6 months. Onset of symptoms should be within 6 months of age. And feeding and dietary history should be taken in detail. How much duration the baby is taking feeds, what volume of the feed the baby is taking, what type of formula, is there any restriction of particular formulas or allergens, and time interval between two feedings. And regarding vomiting or regurgitation details also, nocturnal regurgitation is there, or is the vomitings immediately post feed or after a long time of feeding, after a long time giving after meals or feeds, and whether the content of vomiting is digested or undigested. All these basic simple history taking gives a lot of information in coming to differentials. And also we should look at the growth patterns. Physiological GER usually they don't have any growth abnormalities, only gastrointestinal reflux disease children can have growth faltering. Warning signs, particularly other causes for vomiting, we should search for other systemic causes of vomiting. This is a long list of differentials when child presents symptoms mimicking gastroesophageal reflux. Those seems very long list, but very important for clinical practice. All the gastrointestinal causes, GI obstructions, particularly in young infants like pyloric stenosis, malrotation with valvulus, intussusceptions, any webs, duodenal webs, or sometimes even unnoticed foreign bodies. All these can have obstructed hernias, and all these can present with recurrent vomiting or prolonged vomiting, mimicking like GERD. So we should have some clinical suspicion. Neurological conditions like hydrocephalus, intracranial bleeds, intracranial mass, any tumors can present with vomitings. So other gastrointestinal causes like food allergies, particularly severe form like eosinophilic esophagitis, inflammatory bowel disease, other GI conditions like pancreatitis, appendicitis can acutely present with vomiting. And infections like urinary tract infections, otitis media, hepatitis, all these are acute causes of vomiting, which mimics GERD. And other metabolic and endocrine causes, toxins, lead poisoning, other toxins, cardiac causes, renal causes, all these should be kept in mind. Most of the time, we can come to a diagnosis based on clinical diagnosis, clinical features and examination findings. So red flags, what we are discussing, red flags are important. Onset after 6 months of age and persisting even after 1 year of age, then it's most not likely to be GERD. So weight loss, fever, lethargy, and neurological symptoms and signs. So these are the 2 children we have seen in last 2 years presented with vomiting for 5-6 months. So multiple clinical visits, multiple endoscopies being treated at GERD. When careful examination showed them subtle focal neurological signs, when neuroimaging was done, these both are medulloblastomas presenting with recurrent vomiting and being treated as GERD. So clinical examination is very important. And any features of GI obstruction, we were discussing hypertrophic pyloric stenosis, webs, esophageal strictures, or malrotation with volvulus, all can present with recurrent vomiting. So abdominal distension, bilious vomiting, and other chronic diarrhea, even eosinophilic gastroenteritis can present with chronic diarrhea, blood in stools. All these are red flags. So when these features are there, we should be careful that this may not be simple GERD or some underlying systemic causes there. And features suggestive of pancreatitis, metabolic diseases, renal or cardiac, what we are discussing priorly, should be kept in mind. So just to guide us how to investigate a child, there is a simple questionnaire for infants. So though it is not, it is having a low diagnostic accuracy, but these are very simple questions. So how often does baby spits out? How amount he spits out? Very simple questions which can be taken from parents, and these can be used to segregate at least infants who need further investigation. Though it may not be accurate in diagnosing GERD, but it helps us to plan further investigations, narrow down our differentials. So we can use it in our clinic. So coming to investigations, barium studies, so mostly they are only useful to look for anatomical causes of this vomiting. So no significant role in diagnosis of GERD. So not used for diagnosis of GERD, to look for anatomical abnormality, as we are discussing hiatal hernia, esophageal strictures, even external vascular malformations can cause external compression of vessel, like abnormal subclavian arteries, right aortic arch. All these can present with recurrent vomitings in early infancy due to external compression of the esophagus, like hypertrophic pyloric stenosis, webs, malrotations. Barium studies are useful to look for these causes, not for diagnosing GERD. And it can also be useful in post-operative evaluation of GERD patients where they have undergone fundoplication, whether fundoplication is working properly, tight or very loose, that we can evaluate on barium studies. So video fluoroscopic studies is also one of the important investigation, particularly useful in oropharyngeal dysphasias. When child present, particularly neurologically abnormal children, they have both difficulty in swallowing and they are at risk of GERD. So in that situations, these studies helps us to differentiate whether that respiratory symptoms are due to aspiration during swallowing or due to reflux disease. So video fluoroscopic studies clearly shows whether child is aspirating while swallowing or not. So these are useful in particularly neurologically abnormal children. So these are the barium studies where initial first 2 pictures are the peptic stricture and corrosive strictures. This third picture is post TEF, tracheoesophageal repair, presented with stricture and recurrent vomitings. This is a post-cricoid web, and the last picture is eclasia. So the barium is useful to look for anatomical abnormalities which mimics GERD, not for diagnosis of GERD. Similarly, endoscopy is also not useful for diagnosis, but to look for other causes, except when there is typical erosive esophagitis, which is suggestive of gastrointestinal reflux disease. Most of the time, endoscopy is useful to look for other causes like eosinophilic esophagitis, where we can take biopsies and look for eosinophil counts. infectious esophagitis like candidiasis or systemic diseases like Crohn's can be diagnosed by taking biopsies, and even complications, GERD related complications like strictures, Barrett's esophagus can be diagnosed on endoscopy. And it's also useful therapy where peptic stricture, GERD, chronic gastroesophageal reflux can cause lower esophageal strictures where endoscopy can be used for dilatation of the stricture. So endoscopy is useful for looking predisposing factors like hiatal hernia, complications of GERD like strictures or Barrett's, and for other mimickers of GERD like eosinophilic esophagitis, infectious esophagitis, or systemic disease like Crohn's. So not for diagnosis except for erosive esophagitis. These are the pictures showing esophagitis of lower esophagus, multiple linear ulcers in the lower esophagus, and lower column showing hiatus hernia causing severe esophagitis. And last two pictures, one is which is mimicker of GERD, eosinophilic esophagitis. They have long furrowing in the mucosa, white plaques, and biopsy shows very high counts of esophagus. Even retained foreign bodies can present with recurrent vomitings. So pH impedance of all the investigations till now we are discussing pH impedance, multi-channel intraluminal impedance pH-metry is one of the most useful investigation in the management of GERD. So it can correlate symptoms with either acid or not. It can detect both acidic and non-acidic reflex. Plain pH-metry without impedance can only detect acidic reflexes, but almost 50% of children have non-acidic reflex also. Immediately post-PED, they have reflex, which is most of the time non-acidic. So this impedance manometry, impedance pH-metry, useful for demonstrating both acidic and non-acidic reflex, and determining the efficacy of acid suppression therapy also can be done. After giving therapy, we can repeat the test and see whether the reflex has decreased or not. It can detect full length esophagus. Plain pH-metry will detect only lower esophagus reflex, but impedance pH-metry has multiple channels, even up to upper esophageal sphincter. So higher proximal level reflux can also be detected with pH impedance metry. So it can also differentiate between non-erosive reflux disease, hypersensitive esophagus, and various functional heartburns where only they have symptoms, but manometry will be pH-metry will be normal. So pH impedance gives very useful information in management of GERD. So manometry usually we don't use in GERD, is not much useful either for diagnosis in the GERD, only when we suspect motility disorders in our differences like achalasia cardia, and pre and post-op fundoplication follow-up can be used. And in pH-metry placement of catheter, we can locate the lower esophageal sphincter with manometry. So manometry is not useful for diagnosing GERD. Only when esophageal motility disorders are suspected, we can use manometry to diagnose the motility disorders. So coming to nuclear scintigraphy, it is also same. Lack of standardization, and it's also not useful for diagnosis. May reveal delayed gastric emptying, which is one of the important predisposing factor for GERD. And pulmonary aspiration can be detected, but that aspiration could either be due to direct aspiration during swallowing, or reflexed gastric contents can be aspirated and seen in nuclear scintigraphy. So others, PPA trial, usually infants, we don't give trial of PPA, and even extraesophageal symptoms without any classical GERD features, we don't give trial of PPA. Only PPA trial is used in adolescents, like adults who typically presents with chest burn, retrosternal discomfort, typical features of GERD. In that situation, without any clinical suspicion of other diseases, we can give trial of PPI and see whether they are responding or not. So coming to the management of GERD, so non-pharmacological measures are initially tried. In infants, it includes feeding modifications like thickening of the feeds. They usually decrease visible regurgitation. At least complete response may not be there, but at least a volume of the regurgitation can be decreased. Low volume and frequent feeding can have, and avoiding of overfeeding, though there are no hard literature to show that these are useful, but as these are less risk and low cost, we try low volume and high frequent feedings. And empirical trial of hypoallergic formulas, because in infants sometimes these milk protein allergies and GERD present in a similar fashion. It's a difficult to diagnose. So when infants are not responding to conventional methods, like simple methods like feed modifications, we can try hypoallergic formulations for short period. So if he is responding to suspicion of food allergies increases. And coming to position, also left lateral and prone positions usually are said to the decreases reflex, but prone position, particularly in sleeping time, a high risk of sudden infant death syndrome. So most of the guidelines says during sleeping position, there's no not advised to prone position, only lateral position is advised. So in older children, as in like adults, lifestyle changes, avoidance of tobacco, caffeine, and management of obesity is advised. And other all are only in clinical, no strong evidence like complementary therapies, dietary supplements, prebiotic, probiotics. All these are studied, but no evidence to support their usefulness. So proton pump inhibitors, the first choice of drugs, particularly in erosive esophagitis. So as we are discussing, we don't use PPI in infants unless there is erosive esophagitis. So only older children, typical GERD, we can give trial. Erosive esophagitis, we give for 8 weeks. Typical GERD without erosive esophagitis, we give trial of 2 to 4 weeks. Long-term PPI, particularly required in recurrence of symptoms, neurological abnormal children. But in that cases also, we should periodically assess the children for need of PPA and try to reduce the dose as much low as possible. And these are the standard dose of various proton pump inhibitors. Esomeprazole is approved in less than 1 year children. All other are above 1 year old. So though they have adverse effects, PPIs, overall risk is low. Still, we should use them appropriately and judiciously. H2 blockers, they are less potent than PPI, but very short acting and rapid onset. So most of the time they are used for on-demand therapy for short periods, not for long periods. So PPIs and H2 blockers are not used, particularly in situations where only non-specific complaints like excessive crying, irritability, or only visible regurgitation, that is happy spitters or healthy spitters. In that situations we don't use, and only extra esophageal symptoms without features suggestive of GERD. In that situations also we don't give PPI or H2 blockers. Antacids, alginates tried, but no hard evidence for the management of GERD. Similarly, prokinetics also studied, but because of uncertainty of their usefulness and risk of side effects, they are not advised. Even in asthma, only particular subset of children have benefit from PPIs, like asthma with heartburn, nocturnal asthma symptoms, are steroid dependent, difficult to treat asthma, we can give a trial of PPI. And coming to surgery, indications for surgery, very less commonly we use life-threatening complications like acute life-threatening events or cardiorespiratory failure, and symptoms refractory to optimal therapy. All non-medical and medical therapies failed, or chronic underlying conditions, as we are discussing neurologically impaired children, chronic lung disease like cystic fibrosis, and children requiring pharmacotherapy for long period, for many years. In all these situations, we can think of surgery, and the gold standard surgery is laparoscopic fundoplication. So refractory GERD, we can try before fundoplication, we can try a transpyloric or transvaginal feeding. Whether these fundoplication will be useful or not, we can get an idea from vaginal feeding. And these two, radiofrequent ablation and endoluminal full thickness plications, all these are used in adults, but pediatrics, there are no studies. So when to refer to a pediatric gastroenterologist? As we are discussing, when alarm signs are present or refractory to optimal therapy, both pharmacological and non-pharmacological, we have tried. And even child requiring treatment for more than 1 year, then it is one of the indication where of higher investigations like endoscopy, manometry may be needed and requires referral to pediatric center. Gastroenterology. And these are the last two slides. Approach approach to child infant with regurgitation. So as we are discussing, thorough history examination and search for red flags is the first point. When all these history examination and no red flags all suggest your GRD, usually start with supportive treatment like avoiding overfeeding, thickening of the feeds. If no response, trial of hypoallergic formulas. If no response, then comes trial of PPI. If no response, then requires investigations, better to refer. If red flags are there, we manage accordingly. In older children, adolescents and older children, similar management, but after lifestyle changes and dietary education, we directly give PPI because milk protein allergies are less in older children. If no response, then requires higher investigations, better to refer to pediatric gastroenterologist. So NSU preterm infants have special additional risk factors like they have very short esophagus, hypotonic LES, poor and ineffective peristalsis. So they are more prone for GERD than infants. So they also required proper nutrition, elimination diet trials, and GI specialist opinions, trial of PPI, all these required. So finally, this is so GERD most of the time improves with spontaneously, which is just GER. So neurological disease, anatomical anomalies have high risk of GERD. Diagnosis mostly clinical. Only investigations need to be tailored according to the patient clinical features. And PPI major role in erosive esophagitis only. And empirical trial in infants may be tried to look for any protein allergies. Surgery only in special situations. Even surgery has a very high mortality and risk of failure is very high. Thank you.
Thank you, sir, for giving an exhaustive lecture on GER,
Thank you, sir.
and have some doubts, two or three doubts.
Sir.
Next thing is before development of the vaccine is unfolding. So before development of head holding before 5 months, the child will be in horizontal position. The length of the esophagus is 11 centimeters as against 25 centimeters in adults. The incidence of GERD is more common. After development of head holding, the incidence decreases. Decreases, particularly in case of infants who are unable to hold the cat. We'll always ask the mother to keep the child in the right lateral position. Right lateral position in order to, because the stomach will be at a higher position and it easily empty its contents into the intestines. But the right lateral position will cause more aggravation of GERD.
Yes,
That is one. The incidence of this GERD is more common around 12 years of age. What is the role of H. pylori in causing GERD? H. pylori.
H. pylori in infants, there is no much role. Sir, in adolescents, bigger children, it's almost like adults. Almost around 10 to 15% of functional dyspepsia we call. In that situations, there is role of H. pylori and functional dyspepsia. Correlation has been reported around 10 to 15% of children, sir. So in adolescents who are not responding to PPI therapy, we do endoscopy and get the biopsies. Once, if we document H. pylori and non-response to conventional therapy, then only we treat it for H. pylori. In younger infants, usually H. pylori is not reported to cause these GERD or functional dyspepsia symptoms.
So another important thing is in between 5 to 10 years of age, the incidence of bronchial asthma is more common. Normally, we will be using a beta-2 agonist like salbutamol. Salbutamol can aggravate GERD. And the GERD can cause bronchial asthma. In such a situation, what are the drugs that you want to suggest for a person who is having bronchial asthma plus GERD?
Yes, sir. As we were discussing, only 3 guidelines say that in 3 clinical scenarios, we use PPIs in patients with asthma. One is persistent nocturnal symptoms. If child is having nocturnal symptoms or very refractory asthma, steroid non-response or steroid dependence asthma in that, or if asthma patient is having typical GERD symptoms, retrosternal burning, in that 3 situations, guidelines say that we can try PPIs, not in all asthma patients. Thank you.
Thank you, sir, for your elaborate lecture. Thank you so much.
Thank you, sir. Now I would like to request Dr. Anjaya Garu to felicitate Dr. Upendra Shava Garu.
Sale. My textbook Clinical Pediatrics, fifth edition is already released into the market. So recently I am coming out of the clinical methods in pediatrics, exhaustive approach to various chapters, cardiology, nephrology, neurology, exhaustive, followed by a brief note on each and every disease. So the clinical methods in pediatrics illustrated. So recently it is going to be released very shortly. Next thing is I request all of you to support me. My entire period is dedicated to the teaching. So I'm not anything out of my practice. I thank the Ongole private practitioner for helping in establishing this medical college. I thank you very much on this forum.
Thank you.
Thank you, sir. Moving on to the next session. Let me call upon the chairperson of the session, Dr. Tanir Garu, Assistant Professor of Pediatrics at Katuri College, to introduce the speaker, Ms. Lata Kasturi, for the topic Pediatric Sleep Issues, a Myth or a Fact.
Good afternoon, everyone. It's a privilege for me to introduce Dr. Lata Kasturi. She is a sleep therapist. She did CCHS, RPG, SGET, RST, Pediatric Sleep Badge holder. And she is a sleep physiologist in UK, sleep scientist in Australia, and sleep technology specialist from USA. And also she is an adult and pediatric sleep educator and coach all through the India. We welcome you, madam, for this session.
Hi, good afternoon. Thank you everybody for having me this afternoon. So just wanted to thank Dr. Murli Garu for giving me an opportunity to talk this afternoon to such esteemed physicians. And basically, I mean, we're just trying to explore whether sleep is a science or a myth or a fiction. So I have a few cases that I wanted to share with you guys. So the objective for this session is going to be whether it's a fact or a myth. I'll leave you to decide at the end of all my slides. A little bit of introduction to sleep. Some of the disorders there are a total of about 82 to 84 sleep disorders. Of them, some are primarily for children. And today we're not going to discuss a lot of them, but we're going to discuss RBD, which is REM behavior disorder, OSA, which a lot of us are aware of, which is obstructive sleep apnea, insomnia, cardiac circadian rhythm disorder, movement disorders, and some of the parasomnias. There are a lot more. It's going to be, and each species in this world has, because there are some and nocturnal, and so it's also related to different species. And what effect is it having on little kids and other people? So that's where I'm coming from. And then there is a reduction in consciousness state while we are asleep. So that gives you time to wind down, and it's almost like detoxing your system. And most voluntary muscles become inactive, as we are all aware of. And only involuntary, like your breathing and your heartbeat and the involuntary ones will continue at that time. So what it does is it is playing a big role in cognition, memory, behavior regulation, and learning for all of us. So in my head, it's like, a computer that is defragmenting. If any one of us has seen the computer defragment, that's what it is doing. Like you've got your memories all over, you're collecting the memories, and at night when you're sleeping, it is carefully, condensing and making space. And what the brain is doing is that it is trying to consolidate memory, meaning all the old learning that it's connecting to, that's how strong your current learning will become. So every night it does that, throws away stuff that you don't need, and then again, consolidates the memory. So it's almost, like your computers that need recharging, the brain is recharging during sleep. And so lack of sleep, of course, can also have negative effect, and all of us have experienced it. A lot of you physicians have been up through the night trying to take care of patients, and you can tell the difference on how you feel, whether it's your mood, your hunger, your irritability, fatigue. It tells on everything. More likely to cause unintentional injuries, less likely to follow instructions because somebody is saying something, patient is telling you something. There is that, jet lag kind of a feel to your mind that you're not able to receive what the other person is saying. Then, when you're trying to teach some concepts, the other person is not able to grasp them. They're hearing you, but they're not listening to you. That's the difference. And they're more likely to, with children, they respond to sleep deprivation differently. They start acting up. So you start seeing a child having behavioral issues. If they're having apnea, for example. So they will start irritating other classmates, or they will start talking, or they'll do something wherein the adult supervising them is going to shout at them or give them a little tap on the bottom, and then they just wake up and they're okay for the next, say, 45 minutes to 1 hour. So you see sibling rivalry come up from there. And so those kind of behavioral issues show up all over in school and at home and all that. So then there are more meltdowns, little babies who don't sleep. I mean, I've traveled with my children across the globe, and I used to find it very difficult because they are in a change of, their circadian rhythm is all messed up. They're really upset. They don't know when to eat. They're hungry while they're sleeping. They're not eating while they're sleeping. So those kind of meltdowns. And then they can hurt themselves without even realizing. And then there's aggression, like I was discussing with siblings and friends and family. So now I don't have much facts to share from India, which I would love to have shared if I could. I did not find any while I was researching. So in America, an estimated 3 million children suffer from some form of sleep disorders. And 37% of these children are between the ages of kindergarten to 4th grade, and they have at least one type of sleep disorder. And most common symptoms are hyperactivity and lack of attention, which does get labeled sometimes wrongly as ADHD. So it's something that I guess we all need to be aware of as parents and adults, to not give them a label of something that is long lasting and can be a stigma for the rest of their life. Now, these often present, like I was mentioning, disruptive behaviors. They could have night terrors, sleepwalking, sleep talking, repetitive leg movements, and of course, the very well known in the adult world, OSA. And unfortunately, globally, sleep disorders, pediatric sleep disorders are not as well described as pediatric ones. So we are still trying to learn a lot, and we're still trying to make sense of what happens to our bodies while we sleep. So I mean, it's not hard for me to say that sleep itself is in its infancy, and then pediatric sleep probably is still in its gestational phase stages. So a lot of work, a lot of information, a lot of research can go into it and shared with the larger population across the globe. Now, some of the prevalence of pediatric problems is, this is again from USA, 25% to 43% between the ages of 1 and 5 have some form of sleep disorders, like we discussed earlier. And it has been observed that 46% of the children with developmental delays have some form of sleep disorder. So I was like, I would like to see some more research being done on the quality of life of these children, their families, and that be published, because see, 46% of them have some form of a sleep disorder, and that's huge. And again, we're not even discussing about India. This is just in America that they found. So 18% of these children have learning difficulties. And in the morning, Dr. Satish was talking about children being found with deafness and hearing, eyesight issues. So, this is equally, easy to ignore, and you can overlook that kind of a problem like sleep. So only 2% of children are getting diagnosed and treated on, in USA. And sleep problems are persistent. They do not self-resolve. There has to be some help. And that has to come from physicians like you, who can go and talk to parents, because oftentimes they're going to say, children, they're sleeping fine. They're sleeping 14 hours. But what is the quality of sleep? How many times the child is getting up? Those are the questions that we need to ask and try to help out the parents, improve their quality and the whole family's quality of sleep, I think. So then I went and started searching for some information about Indian data. And this is what I found. 93% of Indians apparently are sleep deprived. 87 complain that, lack of sleep is affecting their health in some way, shape, or form. And this is just the adults we're talking about. 58% believe that, their work and studying is getting affected by lack of good quality sleep. And 38% have witnessed their colleagues sleeping or napping at work. Okay, and 11% have taken time from work to make up the sleep deprivation. 11% confess that they take naps at work. So that's pretty staggering amount of information right there. Apparently 72% of Indians are waking up 1 to 3 times per night. 15% wake up over stress at work. And you can see, I mean, this is not an uncommon sight, I'm sure. And 33% of Indians snore. And finally, only 2% are discussing their lack of sleep with the physicians. My question here is, if as a parent, I don't know what to look for in my child, what am I going to tell my child, or how am I going to teach my child to develop good, healthy habits? So I think the onus is on us to bring awareness and talk to parents and talk to teachers and general community and make it more aware. This was another interesting piece of statistics that I found. So 23% of the current population apparently is 0 to 9 years of age. And then 58% of the current population is between 10 and 44 years of age. So we definitely are a very young country. And 47.9% are below 21 years of age. So what does UN say? It says that every one person in 6 on the planet lives in India at this point in time. And we are the youngest population, which means everybody in this room has an onus to take and say, yes, we need to help these kids because we don't know what we were doing. I don't know what I was doing. These kids don't know what they were doing. And hence we have to, come up and help these kids do better for themselves and us. The other interesting fact was that the sleep deprivation that you see between children of 3 to 6 years of age. And India, by far, the children sleep much less than every other country that is developed or developing on this list. So another area of education, training, teaching, all sections of the society. So why do we worry about kids? Because they have needs just like us. Their needs, of course, change just like ours across their lifespan. These changes could be a result of their environment, priorities, and hormones and gender. When we keep that in mind, you see that infants sleep about 16 hours. As they get older, they sleep about 11, then they sleep about 9, and teens will sleep about 8 hours, and adults between 7 to 9. Now, this affects their mood, their performance, and their health, directly or indirectly. So we have to really keep that in mind constantly. Now, sleep itself it's cyclic, 90 to 120 minutes in length each. It could either be 90 minutes for you or 120. There are 3 to 6 sleep cycles depending on your genetic makeup. It consists of 4 sleep stages: non-REM sleep, which is non-rapid eye movement, which has transitional sleep, that is 1, unequivocal sleep is stage 2, and stage 3, which plays the most important role, and that is between 20 to 25%. And that's where your growth hormones are released. So you really, really need to be understanding that aspect. So REM sleep, again, is rapid eye movement. And once again, it is 20 to 25%. That's where your memory consolidation is occurring. So this is what a regular sleep pattern looks like. This is for a week-old infant. This is the hypnogram for a 6-month-old. This is the hypnogram for a child, young adult, and an older adult. So you can see that stage 3 is decreasing for older adults. And in the first 6 months, the children don't have stage 2s at all. So they're growing. And so what does good sleep mean? What does it do? It helps, it says that you're falling asleep is good, staying asleep, waking up easily and non-drowsy during the morning. All that has positive impact. Negative impact is the rest of them: not getting enough sleep, ineffective sleep, sleep disturbances, environmental disturbances, and stress. So the whole, it's like those, wheels that have to go within the wheel. And unless they're in sync, you're not going to have good proper sleep. So now let's look at REM behavior disorder. We had an 8-year-old who came to our lab. I'm just going to go fast because I think I don't have much time there. So this 8-year-old came presented with snoring. He also had complaints of stomach upset, nighttime talking, and asleep. The child reportedly banged his head and rocked his body during sleep. And he woke up more than twice per night on an average and had trouble going back to sleep. Now his Epworth was 3. His teacher commented he was sleepy during the day. His only medication was Ritalin for ADHD. There was no history of developmental delay or mental retardation for this child. Now, on physical exam, the child was average built, had no acute distress, tonsils were not enlarged, everything else was normal. In lab, when we ran a study, the child presented with rhythmic movement disorder in the form of REM behavior disorder. We would see, I was scoring the study and it looked really strange because the body was like thrashing around in REM. So, and there were typical REM, and suddenly he would go into that. There would be some kind of an arousal, and he would start beating himself around the bed. So this is what the study looked at 10 seconds, and at 30 seconds, and at 120 seconds when the child was, thrashing around. So you can see the leg movements and everything. How do I do this? There's a video. I don't know how to turn that on. Yeah, there you go. So the minute he came out of REM, he would stop doing that. And when he went into REM, you could see that he was, thrashing around. So then we wrote it up and we sent it to the sleep journal, and this got, published. So the next is, I'm going to just talk about obstructive sleep apnea. The patient was 4-year-old male, past history of acute otitis media, referred to ENT for snoring, normal BMI, presented with pauses in breathing due to airway being obstructed, respiratory effort despite no ventilation. So 2% of the population, children, will come up with something like that. So the risk factors in adults is obesity, neck circumference, hip to waist ratio. Men have it more often than women. Family history, age of greater than 65, craniofacial abnormalities. And in children, it is adenotonsillar hypertrophy, obesity. And again, this data is from USA, so African American race children have it more often. We have no such information here. And I'm sure we can agree with craniofacial abnormalities and upper airway congestion should be same in India too. So obviously, I'm not going to read through this only because I know a lot of you know this. So what is interesting on this slide is that the largest relative diameter compared to airway occurs between ages of 2 and 8. And our little kiddo was 4 years of age, and the first child was 8 years of age. So coming back to our patient, you see the tonsils, they're almost kissing, not kissing, but they're almost kissing. And then we did a sleep study, and look what we found. He had obstructive apnea, he had RERAs, he had obstructive hypopneas, he had central apneas. You name it, he had them all. Now, what was his apnea-hypopnea index? It was 3.83. His REM apnea-hypopnea index was 7.02. His RDI was 7.34 and REM RDI was 10.21. Okay, so now let's see what happens. What is the correct normal HI? For a normal child, you need an HI of below 1 for them to be normal. whereas for an adult, it is below 4. For mild apneas, 1 to 5 per hour, and for adults, it's 5 to 14. For moderate, it is 5 to 10 events per hour, and for adults, it's 15 to 29. And for severe apnea, you just need 10. And this little kid had 7. So obviously he needed help. Now, treatment is first line of defense for children is tonsillectomy and removal of any obstruction. It could be adenoids or tonsils or both. And then, of course, corticosteroids, they could likely help the child reduce the inflammation and help. So the other thing is they may also get it back again because they may have had a partial tonsillectomy versus a complete tonsillectomy. So if they've had a partial one, chances of them regrowing are also there. So you need to remember that too. Now, this was another child. Look, take a look at this. This is so amazing for me. This child, the oxygen sats dropped to 47. Okay. And the tech was so scared they had to go in and stimulate the patient, wake up the patient because they were terrified of an 8-year-old dropping to 47. Then again, it makes you think, good God, I mean, you're talking about failure to thrive, you're talking about intellectual disabilities or not, or ADHD, whatever you want to call it. The first line probably should be to have a sleep study at a reputed lab where you've got people who know what they're doing. And then identify what could be the reason. If something as simple as an adenoidectomy, after you know what's happening, is done, you probably are going to resolve the issue. The child is going to go back on track very, very fast. But imagine a little kid who's so oxygen deprived during the night. So all your systems go haywire. Now look at the next slide. This is another very, I mean, it's the same child, okay? So we had to initiate what we called the emergency split night for this particular baby. And you see how bad the oxygen sats were. They were just dropping below 86. And then the technologist went and woke up the kid because you also see that the REM, which is dark, black in color there, that is the REM. And so the little REM the child had, the child dropped to 47. And so the tech went back in and stimulated the patient, put the child on CPAP therapy, and you see how beautiful REM. The child had consolidated REM, the child had consolidated stage 3, and look at his REM at the, they brought the child on pressure of 13. You can see at the bottom there, the child is in supine REM, and look at the happy waves and look how happy the the REM eye clicks are. So, I mean, the picture just says 1,000 words to me. So to say that peds don't have obstructive sleep apnea is definitely in my mind a myth. I leave you to make your own decision. Now, I don't know whether I can really talk about the other 3 circadian rhythm and movement disorders, but we will cover insomnia. So chronic insomnia is an inability to stay asleep or fall asleep. For us to term it as chronic, the symptoms must have lasted for at least 3 months and for at least 3 nights a week. And the child should have got adequate time to sleep. So it can be sleep initiation, duration, consolidation, or quality. And so the amount of time provided, age-appropriate time, and daytime functional impairment for the child. That's what you're trying to identify and look for. And there are 3 types. It is association type, limit setting type, and combined type. So this was 11-year-old male and went to a primary physician because couldn't sleep for as long as he could remember. Sleep history goes, he goes to bed at 10 p.m., has trouble falling asleep till 2 to 4 a.m. and is up at 6 a.m., takes a nap in the afternoon after coming from school, which pays back his sleep debt. So again, he's coming back to the same story of not feeling sleepy. So he stays up again. Grades were good, everything else is fine. So for this child, we went about trying CBT and trying to explain, sleep hygiene, sleep habits, and medication, which rightly should be the last resort. You could try with melatonin and hypnotics and all, but in pediatrics, prefer not to do that. So there's another one that's called sleep. It's called SOD, sleep onset associated disorder. Typically happens between 36 months of age. It's defined as sleep onset always depends on the presence of a certain object. It could be a toy, it could be grandma, it could be mom, it could be dad, anything. Circumstance. So if it's not like, like my children turned the lights off for the baby and put her in a quiet room. But when she came to India, it was not quiet. There were dogs barking, she couldn't sleep. So those circumstances, and then a person sometimes, just like you feed the child and the child will go to sleep between 6 and 36 months. So the clinical features are they'll get up in the middle of the night probably and will not go back to sleep until they get a cue. They'll be they'll delay sleeping, they'll be fussy, frequent nighttime awakening. So this is what it looks like. They get up in slow wave sleep. There's an arousal. And if the child starts getting patted asleep, every time the child wakes up, somebody has to pat the child. So there is no self-soothing. The child has not learned how to self-soothe. So that is sleep onset associated disorder. Limit setting was another interesting thing. We had this child, 2-year-old, came to the lab with a dad. And so want to stay in bed with the parent or display anxiety, separation anxiety, refuses to maintain a consistent bedtime, resultant negative behaviors that get reinforced due to parents' stress in a nuclear family. And by the same token, the possible interference of grandparents in a multi-generational families in India. So if my daughter comes and the baby cries, I said, no, why are you doing that? Why are you making the baby cry? Because for me, it's normal. For my daughter, it's a pain, right? So we've got to figure that out and behave ourselves as parents also there then. So now this child was happy set up. You can see no problem during setup, no problem settling down. The technologist goes in and turns off the light, turns off the TV. All hell breaks loose. She just refused to calm down. The technologist gave the parent and the child about 10 minutes, nothing worked. Eventually, they had to abort the study and end the study. So then the physician was informed, and the physician went and did some talking to the parent about limit setting and how they should be, approaching the child. So that took some time. And I'm going to stop at this because I think I've already gone over. I'm sorry, I wish I had more time to talk, but yeah, thanks.
Thank you, madam. Thank you very much for this excellent presentation. Thank you.
Thank you, ma'am. I would like to request Dr. Tanir Garu to felicitate Dr. Ms. Lata Kasturi Garu. Thank you, ma'am. Thank you, sir. Moving on to the next session, I would like to invite the chairperson, Dr. K. Shailaja, Professor and HOD, Pediatrics, Pinna Maineni, Siddhartha Institute of Medical Science, Gannavaram, to introduce the speaker, Dr. Jyoti Prakash Reddy, for the topic, how to pick non-structural cardiac disease, searching for invisible enemy.
To pick up non-structural cardiac disease and searching for the invisible enemy by Dr. Jyoti Prakash Reddy. I would like to invite Dr. Jyoti Prakash Reddy garu to take up. Introduction is not given, sir.
Excuse me, this one. Okay, man. It's okay, sir.
Dr. Jyoti Prakash Reddy is a senior pediatric consultant, pediatric cardiology consultant at Ramesh Hospital in Vijayawada, madam. Thank you.
So, good afternoon, everyone. So, the topic provided for me is how to pick non-structural cardiac disease, the searching for the invisible enemy. Okay. So, it's a broad topic and tougher one, but I try to cover and will provide more sorry, it's not working. Oh, sorry. Okay, I'll try to cover the maximum and will give more time for the discussion. Okay. Before proceeding into the topic, I'll like to give some examples. Okay. So is this not connected? Sorry. The laptop is not connected. I don't know. Across sir, but no, I want to. Actually, I added a little few more slides. I want to. No, this is connected, sir. Okay, now it's connecting. Okay, thank you. So, a 10-day-old male neonate brought with poor feeding and subcostal retractions. On examination, the child is having signs of congestive cardiac failure. ABG is suggestive of mild metabolic acidosis, and echo is suggestive of severe biventricular dysfunction despite structurally normal heart. So, the actual clue lies here in the ECG. So, if you see, marker you can see, sorry. Okay, there is a prolonged QT interval with T-wave inversions. So, which is suggestive of most of the times it's a hypocalcemia, one of the most common acquired cause of prolonged QT in newborn. So, the QT interval usually is inversely related to the level of serum calciums. The low level of calcium, the QT interval will be prolonged. So depending on that, we can assess the severity of hypocalcemia. Okay, and another child, 6 years child, presented with palpitations at nights, particularly, which is on and off, and there are no other complaints. And echo was structurally normal heart. So, can anybody guess the diagnosis based on your ECG? So, I don't think there are PGs. Okay, so it's a short PR interval with the pre-excitation. So they say WPW syndrome presented with infrequent episodes of SVT. So another 13 years female child presented to the emergency room with suspicious peripheral circulatory failure. So echo done elsewhere was suggestive of severe LV dysfunction. So hence refer to us. On examination, the child is having structurally normal heart, but there is severe LV dysfunction and severe aortic regurgitation and mitral regurgitation. Despite structurally normal walls and no structural abnormality, the child had severe LV dysfunction and aortic regurgitation, which is mostly suggestive of the outflow tract abnormality. So we look for the aortic arch. There is no coarctation and interruption. So when you see and there is similar kind of presentation, one more child, 8 years girl with fever since 3 weeks. So initially suspected myocarditis with as echo suggestive of severe LV dysfunction. When we did the CT, it is showing the Takayasu arthritis. So another condition, 14 days male term baby with breathlessness and feeding difficulties. On examination, the child had signs of congestive cardiac failure and the JVP is grossly elevated and pulsatile. The echo is suggestive of routine like LALV dilatation, grossly dilated LALV, but there is no other structural abnormality we noticed. So, but the only clue we got is flow reversal in the aortic arch. The presence of flow reversal in aortic arch indicates it's a high output cardiac state. So most probably we see in PDA, AP window, systemic AV fistulas. It's nothing but the vein of Galen malformation. Okay, there's a CT report of the child. So the routine non-structural abnormalities we see here, like metabolic abnormalities, rhythm disturbances, myocarditis, cardiomyopathies, systemic AV fistulas, inflammatory conditions like Takayasu, pulmonary hypertension, and pericardial diseases. So I think most of you are aware of these metabolic conditions like hypercalcemia, hyperkalemia, hyponatremia, uremia. And inborn errors, particularly like glycogen storage, POMPs, Fabry's, Coris, all the and mitochondrial disorders can be associated with structural cardiac abnormalities. Though there won't be any structural abnormality, they can present with silent congestive cardiac failure. And not to forget anemia and hypothyroidism also. The other rhythm abnormality we routinely notice are bradyarrhythmias, tachyarrhythmias, and prolonged QT syndrome. So they can present with like irregular heartbeat, inappropriate heart rate, congestive cardiac failure, palpitations, syncope, and pre-syncope. So after taking an ECG, we should routinely check for the rate, whether there is a brady or tachyarrhythmia, or is the rhythm is regular or irregular, how are the P waves, how are the PR intervals, how QRS complexes are, whether they are narrow or wide, and there is any association between RR interval. Is it dissociated with the P wave or associated? So once you are diagnosed like some tachyarrhythmia, so always it's better to evaluate. After that, most of the times we come across with like atrial fibrillation, atrial flutters, SV, AVRT, AVNRT. So routine adenosine testing will differentiate the tachyarrhythmia. So after giving adenosine, if there is no change in heart, it is most probably a ventricular arrhythmia. So it could be even inadequate dosage. If there is gradual slowing, then again reacceleration. It indicates the junctional rhythms or sinus tachycardia. If sudden termination, it indicates it's mostly AVRT or AVNRT. And if there is persistent atrial tachycardia after a transient high degree AV block, it is most probably a flutter.
So routine diagnosis, if the symptoms are infrequent, you have to go for the whole term monitoring, where the ECG leads will be attached to the patient for 24 to 48 hours. And we see the frequency of symptoms, how many episodes of ventricular ectopics, how many atrial ectopics, how many episodes of atrial flutter we see. So based on if there is, if any time in any 24 hours period, if there is more than 20%, it is definitely a significant one. Here you can see the atrial fibrillation episodes are only 0.1 to 0.2%. So that is, it is insignificant. If you see the myocarditis, it's acute or chronic inflammation of the myocardium, recognized like possible myocarditis, clinically suspected, cardiac MRI confirmed, or biopsy proven myocarditis. So mostly acute myocarditis will present with like recent onset of heart failure symptoms, poorly functioning ventricles, or high necessity of inotropic supports. And even it can present with tachyarrhythmias, like anything, atrial fibrillation, flutter, or complete heart block. And fulminant myocarditis can present with cardiogenic shock. So when there are any recent signs of congestive cardiac failure and echo suggestive of LV systolic dysfunction, we should look for another associated clinical features like viral prodrome history, anything within 1 to 4 weeks, or STT changes, presence of chest pain or ventricular arrhythmias, elevated biomarkers, or LV dysfunction should be confirmed with cardiac MRI or myocardial biopsy. So to see if you see the etiology for myocarditis, there is vast list, viral, bacterial, fungal, anything can cause, and even non-infectious causes like autoimmune and drug-induced. So the routine lab investigations we do in myocarditis are CKMB and troponins. Though troponins are very sensitive, they are not specific to myocarditis. That can be elevated before onset of dysfunction and failure. And BNP and NT-BNP are indicative of actual cardiac myolysis, cardiomyocyte lysis, and it can be associated with signs of cardiac failure. And there, for some viruses, there is prior genome PCR is available. And if the routine ECG will show you the tachycardia, ST changes, and low voltage complexes in limb leads. And the pathological QAs are seen mostly in chronic myocarditis, like in parvovirus B19. And any type of arrhythmia can be expected in myocarditis. And if you see the echo, there will be indirect evidence for ventricular enlargement, ventricular dysfunction, myocardial edema or thickening, pericardial effusion, and particularly in pyogenic conditions, you can see pericardial effusion and intracardiac thrombus, and functional valvular regurgitation can be seen in myocarditis. And the cardiac MRI is one of the preferred one in adults, but in children, it's the outcomes, the myocarditis involvement is less noticed. So the cardiomyopathies, it's nothing but a spectrum of heterogeneous myocardial disorders that can be characterized by ventricular dilatation and depressed myocardial performance in absence of congenital valvular hypertensive or ischemic heart disease. And most of the times it is dilated cardiomyopathy, and in children mostly it will be idiopathic. So there are many classifications for cardiomyopathy. The routine we follow is European Society classification. That is like dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy, and arrhythmogenic RV cardiomyopathy. And each is subdivided again into familial and non-familial forms. There is a latest classification called Moses classification. It is based on the morphological phenotype, organ involvement, genetic inheritance pattern, etiological annotation, and functional status of the child. If you see the routine etiology of cardiomyopathy, mostly more than 2/3 of the patients are idiopathic. Only 1/3 patients only we can identify some etiology. And the next most common reason will be myocarditis, and mostly myocarditis will lead to dilated cardiomyopathy only. And if we come to the individual and the hypertrophic cardiomyopathy, it can be familial as well as syndromic and inborn errors of metabolism. And dilated cardiomyopathy, mostly it is myocarditis, secondary to post myocarditis. And the least number of patients can be expected in neuromuscular and inborn errors of metabolism, like in Duchenne's and Becker's. Restrictive cardiomyopathy, most of the times it will be familial or idiopathic. So how are they going to present? They present with effort intolerance, fainting, syncopal episodes, and abnormal auscultation when there is any outflow tract obstruction or valvular regurgitations, and can present with arrhythmias and congestive cardiac failure. How do you evaluate? So the routine ECG will rule out the any associated arrhythmias, and echocardiogram will always differentiate between the cardiomyopathies. In case of dilated cardiomyopathy, you can see there is a dilated LALV with a severe LV systolic dysfunction. In case of restrictive cardiomyopathy, it is the main diastolic dysfunction, which is noticed by biatrial dilatation and severe mitral and tricuspid regurgitation. And in case of hypertrophic cardiomyopathy, there will be specific chamber thickening and myocardial edema will be noticed. And there, in case of obstructive cardiomyopathies, you can see there is obstruction at the LV outflow tract. And other tests we can do is stress test. And routine our OPD practice to differentiate, we advise the patient to do treadmill test with inclining at a certain degree angle, particularly for around 30 to 45 degrees angle. And we'll advise them to walk for few minutes. If there is any effort intolerance, that indicates there is obstruction at the level of cardiomyopathy. And sometimes drug induced like dobutamine stress test also can be done. And even it can be picked in nuclear scanning and PET scanning. And when you are suspecting inborn errors, genetic testing, exome sequencing can be useful. And cardiac catheterization is mostly useful, particularly when there is associated coronary involvement. And cardiac MRI and myocardial biopsy are the other modalities. So when come to the systemic AV fistulas, most of the times it will be vein of Galen malformation in neonates and infancy. And this can present with congestive cardiac failure in first week of life itself. Okay. And it can present with seizures and hydrocephalus on follow-up. So to evaluate for vein of Galen malformation, neurosonogram or CT brain with contrast or cranial MRI or cranial angiography are mostly useful. So coming to pulmonary hypertension, and most of the times pulmonary hypertension is idiopathic and it can be sporadic, genetic or familial. It has slight female preponderance, and most of the times the familial forms are associated with bone morphogenic protein receptor gene abnormalities. To define a pulmonary hypertension, it is the mean PA pressure which is more than 25 mmHg at rest or more than 30 mmHg on exercise, or capillary wedge pressure more than 15 mmHg, or aortic to PA ratio more than 40% in any child. PVR more than 3 Wood units is considered to be a pulmonary hypertension. And most of the times they present with breathlessness, effort intolerance, poor endurance, syncope. And on examination, we can see there is a parasternal heave, loud P2, peripheral edema, all features of right ventricular failure. So the routine bedside clinical diagnosis we can do in pulmonary hypertension are 6-minute walk test. We advise the child to walk at his pace for 6 minutes, and we see the difference between saturation and the pulse before and after the procedure. So, and if you are provided with treadmill, you can walk, ask them to walk on the treadmill also. And echocardiogram, many people routinely the bedside echocardiogram shows that TR jet, which is suggestive of the RV systolic pressure, and RV systolic pressure with RA pressure, it indicates the PA pressures. And angiogram mainly for the pulmonary hemodynamics, and also it is useful in ruling out associated pulmonary AV fistulas. So coming to the pericardial diseases, it is many in children mostly like acute pericarditis, constrictive pericarditis, pericardial effusion, or tamponade. Usually pericarditis presents with retrosternal or precardial pain, which is radiating to neck, back, or shoulder, and mainly worsens with cough, swallowing, or inspiration. And it will be maximum in the supine position, but can be relieved with sitting and leaning forward. And on examination, you can have a pericardial rub, which is better heard in the left lower sternal border with patient sitting and leaning forward. And constrictive pericarditis is mostly idiopathic and can be post-cardiogenic, post-cardiac surgery or post-radiation, post-infectious, and can be associated with this connective tissue disorders. Mostly it presents in the emergency room with hypotension or shock. And it can have an examination, you can have raised JVP, hepatomegaly, ascites, and peripheral edema. One of the most common presentation in children non-structural is pericardial effusion. Many times it might be unnoticed even sometimes. It can be seen in serious transitive conditions like congestive cardiac failure or even routine serositis infections like dengue. Also you can see the transitive effusions, and suppurative effusions you can see in the pyogenic forms, and hemorrhagic infections, malignancy, trauma, all. So always before ruling out there is no cardiac involvement, you should have high index of suspicious and think from more common to less common and rare presentations. Thank you. I finished fast. I just want majority people to discuss. That's why I finished in the first.
Yeah.
So you.
But even then you have covered everything, sir. But I have a doubt.
Sure.
How frequently this myocardial biopsy is being practiced now?
Yes, madam. So in particularly pediatrics, we are not routinely advising because high chances of sudden deaths, arrhythmias can occur on the table. So less than 6 years, routinely we don't advise myocardial, but it is more common in the infancy and it has worst prognosis, particularly when it is presented in the less than 1 year. And most of the times we rely on the cardiac biomarkers or MRI.
Okay.
It's not myocardial biopsy. Of course, it's the gold standard, but we don't routinely recommend for the children.
Right. Otherwise, people are doing myocardial biopsy, not in India otherwise. Because it is a risky procedure.
So routinely like in restrictive cardiomyopathies, hypertrophic cardiomyopathies also, just to rule out the myocardial biopsy we are doing routinely. So, but because the myocardium is very thin, particularly in dilated cardiomyopathies or prolonged cases, so there is high chances of ventricular rupture. So that's why we routinely don't advise. But in little older children, we can advise.
Okay.
So it is easy to do perform the procedure, but needs cath lab. That's all.
Okay. Thank you, sir. Thank you for the elaborate lecture.
Thank you.
Thank you, sir. I would like to request Dr. K. Shailaja Garu to felicitate Dr. Jyoti Prakash Reddy Garu.
Thank you, sir. Let me announce the winners of the paper presentation of postgraduate students. Gold medal winner, Dr. Niharika Nagabattula, Ashram, Eluru. Silver medal winner, Dr. Soumya Y, Sri Ramachandra Children Hospital, Guntur. Bronze medal winner, Dr. Krishna Sai BV, Rainbow, Vijayawada. I request all the students has to be here in hall 1 after completing the scientific session. And for the poster presentation, Dr. Harun Hasini and Dr. Junaid from KIMS Kurnool. And silver medal winner, Dr. Harshavardhan, SVNC Tirupati. And bronze medal winner, Dr. Shrikar, Nelluru Narayana Medical College.
Moving on to the next session, I would like to invite the chairperson, Dr. S. Subbareddy Garu, Pediatric Medical Superintendent of District Hospital, Markapur, on the stage to introduce the moderator, Dr. Yashwantra Garu, for the topic Vitamin Story, the deficiencies, hypervitaminous D.
Good evening, everybody. I thank the IAP AP State Branch for giving us an opportunity, and the team, Ongol team, for doing this program. And it's a really academic fees, but the last one, which is very relevant to all of us, which are really treatable. So we have Dr. Karthik Nalluri. I invite Dr. Karthik Nalluri to come over to the dais and talk on hypovitaminosis. This is a relevant topic. He has done his MD Pediatrics from Amrita Kochi and did his fellow in endocrinology from Leeds, Auckland. He is presently practicing at Children's Clinic for Growth, Diabetes, Thyroid and Problems at Vijayawada, Guntur, Bhimvaram. So your attention to Dr. Karthik Nalluri. Before that, we all know that vitamin D deficiency, our sir was there. Dr. Bala sir, he introduced the concept of vitamin D into our practice in 2005 and 10. He used to tell vitamin D is everything. Really, we realized that why it's so important. There was a study recently conducted in 2016 by Department of Family and Health Welfare, which showed that demography of vitamin D deficiency is same across the spectrum, and it's very common. That's around 18% in school age children between 1 to 14 years. And in adolescents, it's around 24%. Let our speaker go into the depth and interact. So I'd like to request Karthik Nalluri to start on.
Thank you, sir. I thank IAP for giving me this opportunity. So, yeah. So today's topic is hypovitaminosis D. My topic is based on three statements. One is the global consensus of nutrition rickets in 2016. The second is 2020 consensus statements on controversies. And the third is 2.0 vitamin D deficiency update in 2021. So the low vitamin D status is an emerging condition worldwide. So we all know that vitamin D is a prohormone which has an endocrine, paracrine, and an autocrine function. So it's one of the highly prevalent, underdiagnosed, and undertested nutritional deficiencies which can occur irrespective of the age, gender. And even though in tropical sunlight-rich countries like India, it's widely prevalent. So let's get to a brief history. It is in 1920s by Adolf Windorus, discovered after the anti-rachotic properties. So 25-hydroxylation and followed by 125-hydroxylation is appreciated in the early 1970s. Whereas the role of vitamin D receptor present in the multiple organs such as kidney, small intestine is subsequently recognized. So VDR is present in almost all tissues of the body, like the skin, colon, brain, breast. So which is giving us the importance of vitamin D among the different extraskeletal effects which were lately discovered in the 1980s. So this is the basic metabolism. It is by the sunlight. So ultraviolet B rays fall on the skin and they form the provitamin D. And even the second source of vitamin D is through either to the D2, which is the ergocalciferol, or the cholecalciferol D3. So which undergoes the first hydroxylation in the liver, followed by the second hydroxylation in the kidney. And by the action of the vitamin D receptor, it acts on the bone, increasing the calcium mobilization in the intestine, increasing the absorption and decreasing the PTH secretion, and thus promoting calcium absorption. So from the slide, we can see the role of vitamin D, where the intestinal calcium absorption is solely dependent on the vitamin D, whereas the mobilization of the calcium from the bone or reabsorption from the urine is dependent on both PTH and vitamin D. So these are the recent the deficiency. So we need to say what is deficiency. So 25 hydroxylase vitamin D is the best marker compared to 125 because it has a longer half-life. So different guidelines have given, different societies have given different ranges, but the range below 30 nanograms per ml is considered as a deficiency. Whereas if the levels are below 12, it increases the risk of nutritional rickets and osteomalacia. This is the severe deficiency. So Endocrine Society and the Institute of Medicine have stated as 50 nanomoles per liter as below that to be a deficiency. But we should prevent values going below 12 to prevent the nutritional risk. So it's widely prevalent all over the world. So even in US 5.9. So the thing to take is even the tropical countries like India, Pakistan. So we almost more than 20% of our population have severe vitamin D deficiency, not counting the insufficiency. And so coming to the critical illness, so PICUs. So critically ill have highly prevalent vitamin D deficiencies. So it's associated with higher mortality in both adult and the PICU. So it is due to the hypovitaminosis is dependent on multiple factors such as hemodilution. There's reduced production and conversion. There's reduced vitamin D binding protein and increased demand and catabolism in the critically ill. So how much do we need to replace? So bolus dosing is not recommended except in critically ill patients where they need more because of the increased demand. So we need to give an bolus followed by daily dosing only in critically ill patient. For optimal levels, supplementation by sunlight or dietary is not sufficient. So we need supplementation. There are no international consensus which range from around 400 to 2000 IU daily, but the safe over-the-counter medications rise the level by 15 to 25 nanomoles over weeks to months. So the risk of over toxicity is less. So when we say toxicity, we need to know about the upper limit. Still, there are no international consensus. So different societies, so the Endocrine Society are labeled as 10,000 IU per day, whereas IOM or the European Food and Safety Association wanted to keep it below 4,000 IU per day. But several countries, to be on the safer side, they want to keep it below 2,000 IU per day. All these studies, majority of studies are based on several small studies. So in one of the few studies that taking twice weekly of 50,000 IU for several years still didn't cause hypercalcemia. So in general, 800 IU daily supplementation will achieve the levels of 20 nanograms per ml, whereas 2000 IU, what we commonly say given adults, will achieve around 30 nanograms per ml. So this is from the 2016. What is nutritional rickets? The common thing. It's a disorder of defective chondrocyte differentiation and mineralization of the growth plate, whereas osteomalacia is the matrix abnormal mineralization in an established bone. It can be either due to the deficiency, vitamin D deficiency, calcium deficiency, or both. So diagnosis is based mainly on the history and physical examination, then followed by radiological and the biochemical picture. So there are different clinical features which we commonly know. There are different osseous signs like swelling of the wrist, delayed fontanelles, frontal bossing, craniotabes. Radiological features such as cupping and fraying, widening of the growth plate, pelvic deformities. Non-osseous features which present later such as hypocalcemic seizure or tetany, failure to thrive, poor linear growth, and delayed gross motor development. So the labs commonly, what we see, the low lab, we see the vitamin D levels are low, calcium, phosphorus, and urinary calcium will be low. Whereas in contrast, the serum parathormone will be higher, ALP will be raised, and urinary phosphorus will be raised. So what happens when there's low calcium? So there's immediate flux of parathormone, which acts on the bone and causes efflux of calcium from the bone. And in the kidney, it promotes reabsorption of the calcium and enhance absorption, thus increasing the concentration of calcium in the blood. So this is from the 2016 and the IAP 2017 guidelines, which says sufficiency is greater than 20 nanograms per ml, whereas insufficiency is between 12 to 20 nanograms per ml, and deficiency, it is less than 12 nanograms per ml. So the toxicity, we say when the levels are more than 250 nanomoles per liter, along with hypercalcemia and a suppressed PTH, that is when we say toxicity. So infants get at a very higher dose, so that is 2 to 4.5 lakhs. So the high vitamin D concentration can cause hypercalcemia or calciuria, and in a prolonged state can cause nephrocalcinosis or renal failure. Even though systemic toxicity is not caused more than 500 nanomoles per liter, but consensus have limited to keep it at a safer side at 250 for a safer margin. This hypercalcemia can occur in a normal individual too because of genetic variation of the vitamin. So that's why we require hypercalcemia and a suppressed PTH along with these two to say it's a vitamin D toxicity. So this is a simple cartoon to show how is the growth plate and mineralization. So when one of it is normal or insufficient, the otherwise growth plate is normal. But when both are insufficient or one is normal or deficient, they can be early markers. But one is insufficient or both are deficient, it results in the typical features of rickets or osteomalacia. So along with vitamin D, it's important to emphasize on the calcium intake. So it's 0 to 6 months, 200 to 260, and at 6 to 12 months, 260 milligrams per day is required. And over 6 months, the sufficiency is more than 500 milligrams per day, and deficiency is less than 300 milligrams per day. So what is it with deficiency and fractures? Children with radiologically confirmed rickets have increased risk of fractures, but simple vitamin D deficiency, they are not at increased risk of fractures. So there are various maternal factors, infant factors. So we all know sun exposure, it depends on the latitude, vitamin D supplementation. So what are the recommendations by the society? So 400 IU per day between birth to 12 months, irrespective of the mode of feeding, be it mother's feed or the supplementary feed. So beyond 12 months of age, at least 600 IU per day is recommended by IOM. In healthy children, routine screening is not recommended, and no specific threshold is told by the society. So in absence of food fortification, it should be given to those children with a history of vitamin D deficiency requiring treatment, and adults at risk of factors, and those who have reduced synthesis of vitamin D and should be supplemented in all pregnant women. So the dose is 2000 IU per day of 50 microgram for a minimum of 3 months, along with the daily calcium intake of 500 milligrams per day. So the society recommends oral treatment, which is more rapidly restores the levels than the intramuscular treatment. For daily effective doses, both D2 and D3 are equally effective, but for larger dose, as D3 appears to preferable and has a longer half-life, D3 is more preferable. So vitamin D treatment is required for a minimum of 12 weeks, and some children might require it for a longer time. So this is the same thing which I have told. This slide. So maternal deficiency is required to take 600 IU per day. Pregnant women, along with their iron and folic acid, this is to restore their normal levels, not for the child. So we all know the ultraviolet rays. So environmental factors. So it depends on the latitude, longitude, and also the personal factors such as how much time they're spending outdoors, their body composition, their genetics, which influence the intake of the vitamin D. There is no safe threshold for UV exposure, which is documented till now. And currently it is impractical to provide perspective advice on solar exposure. So during pregnancy, they require 600 IU per day. This is to prevent elevated cord ALP, increase fontanel size, neonatal hypocalcemia and congenital rickets, and improve dental formation. So there's little evidence that maternal supplementation will influence the birth anthropometry of the kid. So coming to the lactating mothers, so lactating mothers should get around 600 IU per day for their own needs, but not for the needs of the infant. Maternal calcium intake during pregnancy or lactation is not associated with increase in breast milk concentrations. So a very short note on congenital rickets. So babies presenting with the first 4 weeks. So it's a very rare condition associated with poorly treated hypoparathyroidism, renal failure, or received phosphate containing edemas or magnesemia. So only 80 cases have been reported. So this is just a table. So there are two types of vitamin D dependent rickets, which are type 1 dependent rickets, which is due to the defect in the 1-alpha hydroxylation, and so that 25 is not converted to 125. And there's type 2, which is an end organ resistant to calcitriol. It's a very rare autosomal disease. So a short note on the non-skeletal functions, it has effect on multiple organs. So like you can see in the immune system, where parathyroid regulation, blood pressure, and the blood sugar control. So it promotes innate immunity, whereas increased expression of calcidin, so which is a peptide capable of promoting innate immunity and induces destruction of infective agents. So the activated vitamin D inhibits T proliferation cells, and it's produced in the kidneys, downregulates renin production, and stimulates insulin secretion of the beta pancreas, and thus helping in an endocrine manner. So short note on glucocorticoids. So glucocorticoids cause vitamin D deficiency and or resistance. This is a multifactorial. So supplementation with vitamin D and calcium improves the skeletal health in glucocorticoid-induced osteoporosis. Coming to obesity and diabetes, both of these conditions do have vitamin D deficiency. Supplementation may not improve the outcome, but will definitely improve the morbidity as per several studies. Bariatric surgeries due to the poor absorption, so higher doses are recommended. Deficient patients have increased risk of fractures compared to others. So this is as per the study. So just a picture of the clinical features of vitamin D rickets. So these are the few the rachitic rosary, the Windsor deformities. So this is the widening of the. So the last is the hungry bone syndrome. This is a phenomenon due to vitamin D therapy. So where we give only vitamin D but not supplemental calcium. So it causes worsening of hypocalcemia after starting vitamin D therapy. It's important to consider supplementing therapy with calcium to prevent the possibility of hypocalcemia and seizures to hungry bones. So let's go outside and get some sunshine. Thank you.
Thank you, sir. Very elaborately, sir has taught everything regarding vitamin D, vitamin E. Only very simple, we have to give awareness to the people. Only 5 minutes of exposure out of 24 hours, you won't have any adverse effects or whatever may be deficiency of vitamin D. So we have to make aware of people. Just exposure of only 5 minutes in a sunlight, you can 100% reduce the deficiency of vitamin D. Okay, thank you, sir. Thank you very much.
Karthik, are there any studies suggest you how many minutes?
In SPM book, park is there, no park. There they have mentioned a little bit of 5 to 10 minutes, maybe, sir.
Recent consensus guidelines on the IAP vitamin D says 15 to 30 minutes in an infant or child for half an hour between 11 to 3 p.m.
Yes.
And children more than 45 minutes between the same time may give, but it does not warrant or.
Yeah.
Does any maternal hypocalcemia have a role in treating the osteopenia of prematurity? Or how do you treat osteopenia of prematurity? Do you screen every baby for osteopenia prematurity or
No.
any kid who is less than 1.5 kgs?
Sir, normally we do only the premature kids. Yeah. So, but we ensure that adequate vitamin D supplementation should be taken by the mothers for their own health. And there's one study that it will improve the fontanelle size and the bone formation if the mothers are. So, because I'm telling you from the experience that we have seen severely vitamin D deficient mothers. So the kid has presented with even hypocalcemic seizures on day 2 or day 3. So not talking about the premature kid. I'm telling you about the normal.
Okay,
the
thank you.
normal.
I request Dr. Professor Kiriti, Professor of Pediatrics, SVMC, Tirupati, who is now the present EB member of the Central IIP, to discuss on scurvy. Over to Dr. Kiriti, sir.
Thank you, sir. Good evening, all. I'm overwhelmed to present on this August gathering of PEDICON, APPEDICON, sir. I'm grateful to the organizers for giving me the chance to present before you. Actually, scurvy is a disease often forgotten, sir. So, whenever you see a case like this, you may think of rickety rosary. Just now we can finish the vitamin D. Whenever you see this, your mind will think of hyperplasia, gum hyperplasia. It may be due to phenytoin toxicity. Whenever you see like this, it may be any drug reaction. And you see like this, it may be petechial hemorrhage like that. But always think of scurvy also. From now onwards, you think of scurvy also. Why we should know about scurvy? Because scurvy is a disease caused by chronic deficiency of vitamin C. Because it is being rare, so we seldom suspected, that leads to delayed recognition of the scurvy. So if you diagnose early, you can give appropriate treatment, the results will be very gratifying. So these are the two gentlemen we have to remember on this day, because he is James Lind is a man who helped to conquer the killer disease. He reported experiment on board a naval ship in 1747 showed that oranges and lemon were a cure for scurvy. And this gentleman, Captain Cook, he solved the problem of scurvy on his ships by issuing vitamin C in the form of lemon juice and fresh fruit and vegetables for the passengers. Why vitamin C should be taken in diet? Because in humans, the enzyme gluconolactone oxidase is deficient, and that is not present in humans, which is essential for the conversion of the glucose to ascorbic acid. But it is there in other mammals, unlike humans. So therefore, we have to supplement the vitamin C in the form of fruits and vegetables. So in what way vitamin C is useful? So vitamin C is involved in the synthesis of collagen at the level of hydroxylation of the lysine and proline in pre-collagen, and also involved in the neurotransmitter metabolism in conversion of the dopamine to norepinephrine and tryptophan to serotonin. In cholesterol metabolism, it is involved in the conversion of the cholesterol to steroid hormones and bile acids. In also it is helpful in the biosynthesis of the carnitine. This carnitine is useful for the transport of fatty acids to mitochondria for conversion to energy. It is highly effective antioxidant because it is a powerful electron donor. And also it regenerates other antioxidants such as vitamin E. So in that way, vitamin C is very important. We need vitamin C always. And sources, all of you know, it is citrus fruits mainly, and all vegetables also, tomato, potato, green chilies, cabbage, like that, broccoli, all contains vitamin C. And human milk, when compared to animal milk, human milk is rich source of vitamin C. But many foods can lose their vitamin C content because of cooking, storage or oxidation. So because it is not stored in humans. And also by boiling the milk, suppose a bottle fed baby, bottle fed, but by boiling the milk, animal milk, the vitamin C will be lost. Very less amount will be there, but that also will be lost. And so by boiling, they will lose the vitamin C. So requirement for vitamin C is increased during infection and inflammatory conditions. It's a well-known fact. And newborn infant vitamin C levels are related to the mother's maternal levels. That is, the vitamin C it is transmitted to the through placenta as well as through milk. So recommended daily dietary allowances for the vitamin C more in infancy and also in pregnant mother and lactating mother. And for smokers also vitamin C supplementation is required. Who are the high-risk people? Vitamin C deficiency. The infants who are fed evaporated or boiled milk or pasteurized milk, and exclusive meat feeding, and children with the dietary restrictions due to neuropsychiatric or developmental disorders such as autism and all that, and children with intestinal malabsorption syndromes, and patients with end-stage renal disease undergoing chronic hemodialysis, and patients on ketogenic diet. We'll come to a case so that you can understand how important the vitamin C is. So 8 months male child who is irritable, unconsolable, loss of appetite, bottle fed, on examination bilateral painful knee swelling, petechial hemorrhages are there, bleeding gums are there. By seeing the posture of the baby, hip and knees are semi-flexed and feet externally rotated. So many, we can find similar signs and symptoms in so many cases. It mimics, but from now onwards, you have one of the differential diagnosis you should think of, it is scurvy. So clinical symptoms of this scurvy can manifest if a child or any adult is not taking sufficient or inadequate intake of vitamin C, even for 8 to 12 weeks, that leads to vitamin C deficiency. So clinical spectrum of the scurvy starts from the early stage, early symptoms of irritability, appetite loss, fever, petechial hemorrhages, dermatological condition, various dermatological conditions, and gum hyperplasia, easy bleeding gums, and ecchymosis, and loosening of the teeth, any bony, that means joint swellings, limp, arthralgia, myalgia will be there. And in advanced stage of the scurvy, you will find psychological changes, poor wound healing, ultimately it leads to death also sometimes. So early changes, there is a capillary leak because capillaries are very fragile and there is tendency to hemorrhage because collagen metabolism is in deranged. And initial manifestations are like non-specific such as child will be irritable, loss of appetite, low-grade fever may be there. And there may be petechia, ecchymosis, hyperkeratosis, and this is corkscrew hairs. So that is perifollicular hemorrhage. Perifollicular, that hair around the hair follicle there will be hemorrhage. Perifollicular hemorrhage, that is called corkscrew hairs. And gum hyperplasia, and they will easily, I already told you the dentin formation is defective, that leads to poor dental formation and easily bleeds. And you see the joints are symmetrically involved. Both joints will be involved. Leg swelling, suppose if you say in majority times, if mother complains of both joints swelling, you have to think of vitamin scurvy also. And there will be hemorrhage occurring beneath the periosteum and into the joints, and fractures can occur around the growth plate. And we can see like rickety rosary, there is for the rosary for the vitamin C also, that is scorbutic rosary. So for this photo I already shown to you. So usually we think of rickety rosary, but it is not. How to differentiate the rickety rosary and the scorbutic rosary? Scorbutic rosary is very sharp, whereas rickety rosary is not that sharp. That is the only difference. So a more frequent presentation bringing the child to the medical attention by the mother is the deficiency of vitamin C results in poor formation of the bone osteoid, causing disruption in the endochondral bone formation. And the infant may have features of pseudoparalysis. This is very important, pseudoparalysis. So it is like how to diagnose pseudoparalysis. It is pitted frog. While doing a dissection in the intermediate or +2 stage, we have to dissect the frog, no? So the lower limbs of the frog will be like this, pitted frog, semi-flexor of the hip and knee, and external rotation of the feet. And a child usually irritable, it does not like to handle. It is very unconsolable cry will be there. So again, we'll come back to the case. Now you see, with this background, you go through this case scenario. 8 months baby, irritable, unconsolable cry, loss of appetite, bottle fed because boiling of the milk causes vitamin C we lose vitamin C, and bilateral painful swelling, that is symmetrical involvement of joints, I already told, and petechial hemorrhages, and bleeding gums, and posterior is pitted frog, like that is hip and knees are semi-flexed and feet are externally rotated. So if you come to the diagnosis, proper diagnosis, usually in many cases, the serum estimation of the vitamin C, we may think of that serum estimation of vitamin C, we can know the vitamin C deficiency, but it is very insensitive. It is not recommended. So next definitive diagnosis, lymphocytes vitamin C levels. Lymphocyte vitamin C levels equal to 10 milligrams, less than 10 milligrams, then it is definitely the case of scurvy. But it is not routinely practiced. It is very difficult to estimate. It is not available in all centers. And the next thing is we can give 100 milligrams of vitamin C IV. And if you collect the urine, you estimate the vitamin C in the urine. If 80% of vitamin C, that is 100 milligrams, 80 milligrams we recover from the urine, then child is not having any vitamin C deficiency. So this is also not practical. So leftover is, so diagnosis of the scurvy, only two things we have to think. One is clinical high index of suspicion on the clinically, and second one is radiological findings. These are the two things we can able to diagnose rickets. So for the purpose of the postgraduates, unfortunately there is no postgraduate here. So this is a white line of Frankel, all of you know, and there is a Wimberger sign, that is sclerotic rings at the epiphysis, sclerotic, that is Wimberger sign, circular one, and ground glass appearance of the shaft because of loss of trabeculae, and pencil cortex. Cortex is the thin cortex, pencil-like cortex, and Pelkan spur is at the end of the this thing. We will see ZD is there, no? ZD, that is zone of destruction, where the lateral side, that is a gap, spur-like gap, that is called Pelkan spur. And see the large subperiosteal hematoma, that's SH is subperiosteal hematoma, big hematoma. So that is the cause for the swelling of the joints. And then areas of calcification, that CAL is the areas of calcification, and LD is the epiphyseal separation seen in the both knees, and the linear displacement, that is see the left femur, lower end of the femur, that is linear displacement of the bone. And CE is the compression against the shaft of the right knee, right side. See the right knee, it is compression. This is for the purpose of the postgraduate. I prepared this slide, and entire thing, the radiological findings we can see in a single slide. That is most common radiological finding is the osteopenia, and we'll see the ground glass appearance due to absence of trabeculae in the shaft, and more prone for fractures because bones are very fragile. So a lot of callus formation will be there, and pencil cortex in the diaphysis, and irregular thickened white line, that is white line of Frankel at the zone of well calcified cartilage. We see at the diagram, pictogram at the probitic zone. I mean, that white line, thick white line. And then just below the thick white line, there is rarefaction. That is called Trummerfeld zone. And there is a Pelkin spurs at the lateral end of the line of Franklin. And Wimberger sign, it is a round ring epiphysis, Wimberger sign. Okay. So treatment is very easy, very simple. If you diagnose early at the level of spontaneous bleeding and constitutional symptoms, if you supplement vitamin D, the results, you can get the results within days. So at the level of bone deformities and ecchymosis, still, if you supplement vitamin C, we'll get the result within weeks. So it's very easy to treat scurvy. Only thing, we have to clinical acumen at the high index of suspicion of scurvy. So dosage is infants and children, vitamin C 100 to 300 milligrams daily, and adults 500 to 1000 milligrams daily for 1 month, or until the full recovery occurs. So supportive treatment also, that is symptomatic treatment also in the form of analgesics and rest also we can give. And majority of times we will complete remodeling scene, and very rarely we'll see the residual deformity and growth disturbances, even though epiphysis are all involved. So to conclude, although scurvy is a rare disease, but becoming more common in developing countries where malnutrition is quite prevalent, it can present in various forms and can mimic many common diseases. So high index of suspicion is required, and detailed clinical history, including dietary history, comparative bilateral radiographs, diagnosis can be made. Thank you.
Any questions, sir? So sir has made it very crystal clear. To add on, vitamin breast milk only contains 25 international units in the first 3 to 6 months. As sir has clearly said, in the first 6 months, 40 milligrams is required. Subsequently, 50 milligrams is required. And whoever baby is taking a pasteurized milk or boiled milk, see that our practitioner should supplement vitamin C. That is what is important. High index of suspicion is very, very, very important, and it's treatable. Continue in 300 milligrams for 3 months. As sir has said, 8 to 12 weeks. So have suspicion, look at the factors. Pasteurized milk or overcooked or boiled milk is a case where you have to supplement vitamin C. Thank you, sir.
Thank you.
Thank you for taking your time.
Thank you.
Thank you.
Postgraduates have missed.
Sometimes differential diagnosis is also very important. As sir told, sometimes osteoarthritis, they may think of sometimes osteoarthritis. So very important to rule out first scurvy, that is vitamin C. Later you have to go for osteoarthritis and all, because they will go on giving all steroids and all. That track of treatment will go differently. So first you have to rule out and think of scurvy, later you can go. Sir, very excellent, sir. Thank you.
Thank you, sir.
Seen this, the COVID outbreaks, vitamin C supplementation being followed in adults. Even children, initial recommendations, vitamin C was recommended. So in any acute infections, is there specific apart from routine prophylaxis or prevention?
Yes.
Or recommended daily allowance?
Because vitamin C requirement is more in inflammatory conditions. That's why they supplement the vitamin C in acute inflammatory conditions. And infections, inflammatory conditions, invariably every time, in every infection or inflammation, some amount of vitamin C requirement will be slightly increased requirement. So that's why. So because during COVID season, we don't know what is the pathology and all that in initial stages. That's why they prescribe vitamin C.
So in COVID Has
That may be,
reminded
that may
us
be.
supplementation.
Yes.
So usually we
home isolation
we-
kit and all.
We didn't see much of vitamin C being prescribed
Yes,
from so many.
Yeah.
ఎక్కడ చూసింది లేదు సార్ apart from routine.
Because there is no medicine for at that time.
Yes, sir.
They thought, sir, this is infection, inflammation is there. That's why we supplement vitamin C.
And the
That's why.
problem in pediatrics, we never had that formulations. Only tablets are available.
Yes.
But recently,
So
if
it is best is not the pharmacological vitamin C. Best is vegetables and citrus fruits.
Earlier, Secon was available, sir. Secon company was available. 1 ml used to have 60 mg.
but
And
it's-
even
it was not widely available, sir. I
no,
think.
it's not available. I think Dr. Reddy's also had vitamin C.
Yes, sir. Last 1 year, they have come. So many companies have come with the C, D, and zinc formulations. And even adults were using
Adult we are having,
injectable.
sir. Adult we are having, but adult and all we are having, but pediatric doses are not available. That Glenmark and all, Glim CD3.
Yes,
They will have vitamin D, vitamin C, and B complex. Glim CD3. But
And even,
pediatric
adults like in injectable forms.
not a big role in injectable
Oral
forms.
is always better,
Always
and
better.
that too natural source is always better. In vitamin C, natural. That's why in 1734 itself, that Robert Cook and those persons, they supplement only fruit juices because they weeks together, months together on the sea. So they notice even insufficient intake of natural source of vitamin C for 8 to 12 weeks, that manifests vitamin C deficiency features. So they supplemented fruit juices and vegetables. So they conquered that problem of scurvy.
Thank you, sir.
Thank you, sir.
Thank you, sir. I request Assistant Professor Dr. Spandana Garu, SVMC Medical College, to speak over vitamin A.
Yeah.
Thank you, sir. Good evening. I thank APPEDICON Ongole for giving me this opportunity. Vitamin A deficiency, this is not a new problem, but still it is a problem. Globally, 5 lakh preschool children are becoming blind every year, and half of them are dying within 12 months of losing their sight. And prevalence worldwide, it is 30% and 50% in Southeast Asia region. This prevalence is based on serum retinol levels. In spite of this, only 2 out of 5 children in need are receiving life-saving benefits of vitamin D supplementation in the year 2020 as per WHO. The recent prevalence of vitamin A deficiency in India has fallen to 15.7% from 60% in the year 2005 with effective implementation of vitamin A supplementation program. The forms, dietary forms available are, it is preformed vitamin A available as retinol, and retinoic acid, and provitamin A is available as beta carotenoids and beta cryptoxanthin. RDA is retinol equivalent is 1 retinol equivalent is equal to 1 microgram of retinol. It is all-trans retinol, which is active, biologically active form of retinol, which is equal to 3.3 international units of retinol, vitamin A. Coming to the dietary sources, in animal sources, it is available as retinol, preformed retinol, which has 90% absorption. And the richest source is liver, that is organ meats like liver. The other sources are fatty fish, egg yolk, cheese, and milk. Among the plant sources, it is available as carotenoids. It is richly found in green leafy vegetables and yellow and orange fruits and vegetables. Coming to the etiology, it is due to reduced intake of vitamin A as in malnutrition, impaired absorption of vitamin A as in small bowel disorders, inflammatory bowel disorders, as well as cholestasis. In cholestasis, because of lack of bile salts, micelle formation is affected. So vitamin A is not absorbed properly. That's why we supplement more doses of vitamin A in case of infantile cholestasis. And also seen in reduced storage of vitamin A, as in liver disease, cirrhosis, and liver failure, cystic fibrosis also because of biliary cirrhosis. Coming to the risk factors, low socioeconomic status, malnutrition, maternal malnutrition, and zinc deficiency. See, zinc is very much essential for the synthesis of retinol binding protein, which is a carrier protein of vitamin A, retinol. And it is also essential for conversion of beta carotene to retinol. And coexisting infections like measles and respiratory infections can cause deficiency. Vitamin A retinol absorbed from the intestinal mucosa, it is transported to liver in the form of chylomicron, and it is stored in the hepatic stellate cell as retinol, and it is carried to the target tissues with the help of retinol binding protein. It has a vital role in vision cycle in replenishing the rhodopsin. So if there is any deficiency of all trans retinol, it will cause delayed dark adaptation. So this rhodopsin pigment, visual pigment, is essential for dark adaptation. So in the absence of, in the deficiency of all trans retinol, the replenishing of rhodopsin will not occur. That will cause delayed dark adaptation time, increase the delayed dark adaptation time. If not treated promptly, it may progress to night blindness. And it has vitamin A is a ligand for certain nuclear receptors, RER and RXR receptors that act as transcription factors in cell proliferation and differentiation. And it has a role in glycoprotein synthesis, important glycoproteins like immunoglobulin, collagen, and mucus. And its role in immunity, apart from the synthesis of immunoglobulins and differentiation of lymphocytes, it maintains the integrity of body's first line defense mechanism, that is skin and mucous membranes. And retinol binding protein is a negative acute phase reactant. So any severe infections and inflammation like post-measles state that cause acute severe vitamin A deficiency. Apart from the above roles, it is also important in iron metabolism, skeletal growth, fertility, and beta carotenoids are scavengers, free radical scavengers. So, as per ICMR standards, in infants, RDI is 350 micrograms of retinol. In children less than 6 years, it is 400, and more than 7 years, it is 600. It is a table showing grade of xerophthalmia and peak age group affected and type of deficiency. In this, acute deficiency can cause directly corneal xerosis, corneal ulceration, and keratomalacia, that is X1B, X1 and D stages. So, and chronic deficiency, long-standing deficiency can cause blindness and conjunctival xerosis. XN is night blindness. This is the vision of a night blind child. This is conjunctival xerosis. Conjunctiva becomes dry and non-wettable, described as emerging like sand banks of receding tide when the child ceases to cry. And bitoid spots, these are described as foamy elevations on the temporal side of the conjunctiva. It is due to squamous metaplasia and keratinization of the conjunctival mucosa. This X2 is corneal xerosis. Until this stage, if it is treated promptly, it is reversible, xerophthalmia, without any complications, without any sequelae. X3A is corneal ulceration or keratomalacia involving less than 1/3 of corneal surface. X3B is keratomalacia more than 1/3. This is corneal scarring. Xerophthalmic fundus, it shows small, wide, deep retinal lesions in the posterior pole. It is a feature seen in adult population. Other features of vitamin A deficiency: skin changes like phrenoderma and follicular hyperkeratosis due to keratinization of the hair follicles. And also growth retardation, faulty epiphyseal bone formation, susceptibility to infections. And it can cause defective tooth enamel, anemia, apathy, intellectual impairment, increased ICT, reproductive failure, and fetal abnormalities if mothers are deficient. And coming to diagnosis of vitamin A deficiency, it is mostly clinical, and one should assess the dietary intake of vitamin A, eye examination, and dark adaptometry. It is helpful for early diagnosis, and conjunctival impression cytology, which shows decreased number of mucus secreting goblet cells. And Rose Bengal stain test is for diagnosis of conjunctival xerosis. And serum retinol levels, if it is less than 10, it is suggestive of, it is mostly associated with ocular symptoms. This is a WHO prevalence criteria of xerophthalmia as a public health problem. Serum retinol levels more than, if it is less than 10 micrograms in more than 5% population, it is considered as public health problem. If it is more than 20%, it is severe public health problem. Treatment of xerophthalmia, 3 doses are given immediately at diagnosis, the next day, and after 2 to 4 weeks. Dosage is in less than 6 months age group children, 50,000 international units, 6 to 12 months, 1 lakh, more than 12 months, 2 lakhs. And all children with corneal ulcer should receive vitamin A, whether or not deficiency is suspected. And coming to parental preparation, these are indicated when there is impaired oral intake, persistent vomiting, or severe malabsorption. And the dose is 3/4 of the oral dose in less than 6 months children, half of the dose in more than 6 to 12 months children. Remember, parental water soluble, water miscible preparations, they cannot replenish the liver stores of vitamin A. So it should be followed by oral oily preparations also. These are the preparations available, water miscible as well as oil miscible preparations available in the form of retinyl esters. They are available as chewable tablet, capsule, oral solution, as well as injectables. Coming to the vitamin A prophylaxis program, since 2006, with the recommendation of National Institute of Nutrition, government has started 9 mega doses of vitamin A prophylaxis between 9 to 5 years age group children. First 2 doses are integrated with measles vaccination and DPT first dose. Rest of the doses given 6 monthly interval. And the dose is 1 ml per infants and 2 ml for more than 1 year children. Apart from this, measles also we should give 2 mega doses of vitamin A and 2 on consecutive days. And SAM children should receive 1 dose of vitamin A. If the child is suspected to have zinc deficiency, as in malnutrition, we should supplement zinc also. And WHO no longer recommends universal supplementation in children less than 6 months age group. What are the outcomes of vitamin A supplementation? Previously, in 2005, it is 61%. With effective implementation of this 9 doses strategy, it has fallen to 15.7% as per 2018. And in Andhra Pradesh, as per recent data, there is 80% coverage of vitamin A supplementation program. All over India, it is 71% coverage. Is it the time to revisit the policy of vitamin A supplementation program? Yes. National Institute of Nutrition, they have called for a policy change to implement the program as a targeted state-based supplementation program to avoid toxicity from megadoses, because it has fallen to 15.7% prevalence, which is far less than the high prevalence range of less than 20%. So to prevent the toxicity from megadoses, National Institute of Nutrition has recommended that. Even Indian Academy of Pediatrics, they advised India, the government of India, to stop the universal supplementation of vitamin A prophylaxis program rather than concentrate on only high prevalence states and where the coverage is less. Coming to the hypervitaminosis A, it is due to excessive intake of preformed vitamin A, either as supplements or organ mates like liver. Headache and vomitings are the early signs. Anorexia, dry itchy desquamating lesions, hyperostosis with bony lesions, cirrhosis of liver, hypercalcemia, pseudo tumor cerebri, and teratogenicity in the form of craniofacial abnormalities. Serum retinal ester concentration, if it is more than 10% of total vitamin A pool, then it is considered as hypervitaminosis, toxic levels. See, these are the National Family Health Survey 5 indicators, nutritional indicators, which shows only 10 to 12 in all over India, only 10 to 11% of children are getting adequate diet. And in Andhra Pradesh also, it is same. Only 12% of children less than 6 years age, less than 2 years age group are getting adequate diet. This shows that there is a need to improve the diet of the children to prevent all the subclinical features of this deficiency, subclinical vitamin deficiencies. To conclude, vitamin A is the most essential vitamin which supports basic structure and functions at cellular levels. It has its role in vision is incredible. There is a need to improve the diet of under 5 children to prevent subclinical vitamin A deficiency. And hypervitaminosis is a problem not only with excess supplements, but also with regular intake of organ meats. Thank you very much.
Thank you, madam. And also other features also like all white spots, corneal xerosis, and corneal ulceration also is there. So all the findings will be in the vitamin A deficiency, madam. Okay, very thank you. Elaborately expanded the teach, madam. Thank you. Thank you, madam.
Thank you.
Thank you, ma'am. We go on to next topic. Zinc, how relevant we are. Dr. P. Sirisha will enlighten us. She is an assistant professor of pediatrics at Fatima Medical College, Kadapa, and consultant at Chennai Children's Hospital, Kadapa. Over to you, ma'am.
Thank you, sir. So my topic is zinc, how relevant. I'm sorry to say it is under subheading of vitamin stories, but I want to make sure that you all know zinc is not a vitamin. But what is zinc? It is a vital mineral. So it is an essential trace element, in fact. It is recognized as essential trace element in 1960s when they found that there is dwarfism in Iran due to zinc deficiencies. So there are n number of functions of zinc in our body. Few of them important here are immunological, cellular, dermatological, metabolism, growth and development. So one word about each. Immunological, if you see, zinc is very important for T cell immunity, that is cellular immunity. How it is important is, as we all know, thymus gland secretes a hormone called thymulin. For the proper secretion and function of the thymulin, we need zinc. When there is zinc deficiency, the hormone secretion of thymulin is interrupted. Further interrupts the T cell functions and natural killer cells, and there is decreased cytolytic activity of the T cells. So at the cellular level, if you see, the zinc functions can be categorized into 3 levels. First and foremost is catalytical. In our body, nearly 300 different enzymes, zinc acts as a cofactor, and structurally, zinc acts as important component of a cell membrane, and it prevents the oxidative damage to the cell. Regulatory, there are zinc finger proteins, which are very important for the hormone secretions and release and nerve impulse transmission. So about oxidative stress, zinc is very important antioxidant. How it helps exactly is, as I told earlier, there is a component in the cell membrane and it stabilizes it, further preventing the oxidative damage, and also maintains an adequate level of metallocyanins. These are the free radical scavengers. Other thing, the oxidized dismutase, it is a very important free radical scavenger. Further to function properly, zinc should be there. So dermatologically, in every other skin ointment, we'll see zinc oxide. How exactly the zinc helps in skin healing is, it promotes the connective tissue formation. As my earlier speaker, she also denoted this point, actually, transport of vitamin A from liver to skin, requirement of zinc is there. So if there is zinc deficiency, there will be no proper healing. And if any damage is there, there will be no proper healing even if there is vitamin A. So growth and development, knowingly or unknowingly, we are supplementing zinc to all the young infants because it is very important for the growth and development. How it exactly helps is, zinc improves the taste and further increases the appetite. Also, metabolically, it improves the metabolism of carbohydrates and lipids At the bone ends, it helps in chondroblast replication and differentiation. For the hormone mediation of important things, the growth hormone and testosterone, which are important for the linear growth, proper quantity of the zinc should be there in your body. So how much should be taken? According to the age group, up to 6 months, it is 2 mg per day. In the pregnancy and lactation, more amount of zinc should be taken because the fetus also requires for proper growth. And in children for up to 3 to 5 years, around 5 mg per day is okay. So where exactly we get the zinc in our diet? If you see, there are very little zinc in our diet which we take. Oysters is the highest rich sources. It is 25 mg per 100 kilocalories. Most of them don't take the oysters. And in the plant sources, only nuts and legumes have relatively good sources. And fish, fruits, and etc., they'll have very minute quantities of zinc. So we have seen all the physiological functions of zinc and how we are using that physiological functions in our clinical treatment. We can see under 3 headings, that is adjunctive treatment. The zinc is used as adjuvant to the proper treatment going on. And second one is supplementation or preventive treatment. And last one is definitive treatment. So what does the adjunctive treatment means? For the disease, there is a particular treatment going on. But if we add zinc as adjuvant to that treatment, there will be decreased length of the hospital stay and the decreased complications. So where all we are using as adjuvant, we'll see. So diarrhea, as you all know, diarrhea is the leading cause of under-5 mortality, even after introducing the low osmol ORS. So it is causing worldwide 1.5 to 2.5 million deaths. So in vitro, zinc has some mechanism, that is, it inhibits the basolateral potassium channels. Thereby, it improves the absorption of water and electrolytes and improves regeneration of the intestinal epithelium and also increases the level of brush border enzymes. Also some immune response it will help, which will help in the better clearance of the pathogens. So with this in vitro physiological function of zinc, many RCTs were conducted. Most of them are positive, denoting that there will be lesser duration of diarrheal episodes in the cell, about 18 to 20 hours. Recently, one study in Bangladesh has also concluded there is lesser use of concomitant antibiotics when zinc is used as the adjuvant treatment in diarrhea. So who should be given? So when any child with diarrhea can be supplemented with zinc during that diarrheal episode, but most of the studies, stronger evidence is there when used in more than 6 months. As of now, less than 6 months, only fewer studies show positive benefit. So when to start in diarrhea and how soon to start? Anywhere between 1 to 7 days of diarrhea, we can give zinc. It will have a positive effect. Particularly in the persistent diarrhea, there is more positive benefit. So how long to give? Current recommendation, they say it is for 14 days. In practice, consistently, if we give for 10 days also, it is beneficial. So what dose to be given? WHO has framed less than 6 months old, it should be 10 mg per day for 10 to 14 days, and more than 6 months, 20 mg per day. So with zinc salt is best. So many preparations are available commercially. Some will have zinc gluconate, some will have zinc sulfate, zinc acetate and all. So as for now, no proper comparative studies have been done in these salts, but fewer studies state that zinc gluconate is best in showing the benefit and zinc acetate has comparatively less benefit. So how safe is it? Can we supplement zinc to all children without any side effects if we ask? Some children will have vomiting and regurgitation with the first dose because of that metallic taste. So whether zinc is helpful in all the causes of diarrhea, if you see, studies recommend that if the diarrhea is caused by Klebsiella, Vibrio cholera and Shigella, zinc will have more positive benefit. But when it comes to ETEC diarrhea and rotaviral diarrhea, it may not have such positive effect as in dysentery. So challenges, it is very easy to formulate the recommendations or giving the guidelines, but when it comes to community level, caregivers should be given awareness that not to go to the curative treatment of taking the antibiotics for simple diarrheas. We should counsel them about the consistent treatment for at least 10 days. So other adjuvant treatment where we are using zinc nowadays is respiratory infections. First thing is pneumonias. Many studies are conducted outside India whether zinc is helpful as adjuvant treatment in pneumonias, but there are no positive studies outside India. But recently in India, a study was conducted with 700 young infants from 7 to 120 day old. They have supplemented zinc who had pneumonia 5 mg twice daily for 21 days. What they have observed is there is lesser duration of hospital stay and less complications of severe pneumonia. So for common cold, zinc was used from ages. Zinc was used within 24 hours of symptom onset of common cold. They were used as zinc lozenges. One bad thing is it would have a bad taste with that high dose. So other thing from adjuvant treatment, that is zinc and Wilson's disease. So Wilson's disease, as we all know, it is autosomal recessive disorder where there is hindrance to the copper metabolism and there will be excess accumulation of copper in the liver and there will be some neurological symptoms also. If you see, the particular treatment will be copper chelators, that is D-penicillamine, but along with that zinc was used, particularly the zinc acetate was used. How it is helpful in that Wilson's disease is, it prevents the absorption of copper from intestinal mucosa and also increases the hepatic metallothionein synthesis. As I told earlier, this metallothionein is a free radical scavenger. It helps in the damage, further damage by the excess copper because of the free radical scavenger activity. So skin, in nappy rash, acne and some skin irritations and all, zinc oxide is used because it has a anti-inflammatory activity. So for this nappy rash and all, many commercial formulations are available, but if we use zinc oxide formulation, it will be very effective in healing that nappy rash. So COVID-19, all these 2 years, there was an extensive study for curative treatment or whatever is available with some benefit they have used. Zinc also has some in vitro activity. Theoretically, it has antiviral activity inhibiting the AC2 enzyme, which is important for the binding of this COVID. And also it has the property of improving the ciliary morphology and the mucociliary clearance so that there will be faster recovery from that pneumonia. And if we see, the zinc also has anti-inflammatory activity. So it has a capacity to prevent the cytokine storm in COVID-19. So I think everyone knows that zinc supplements along with vitamin C was recommended during that COVID-19 pandemic. So we have finished that adjuvant treatment. So second one is preventive or supplementation. So whom to supplement? So during that acute episode of diarrhea, we have given the zinc for 10 to 14 days. So why to give again supplement is, after that acute diarrheal episode, if we give the zinc in the low dose for a period of about 4 to 6 months, there will be decreased episodes of this diarrhea. So again, we have this infancy and during pregnancy, as I have stated, because of the fetal requirement, we should supplement. And why to supplement? We are giving along with multivitamins. Zinc will be there in all the multivitamin syrup if you see properly. Why? Because breast milk has very little amount of zinc secreted. So first one is actually required by the child and the second one is actually secreted in the breast milk. As the age progresses, there is less secretion of the zinc into the breast milk, but there is more requirement of zinc. So we should supplement the young infants with zinc to prevent these deficiencies and also to maintain the proper immune response because they are more prone to infections and diarrhea during that period. So how to supplement? Less than 5 years, we can give 5 mg per day, and older than 5 years, 10 mg per day. Pregnant women, 10 to 15 mg per day. If there is associated protein energy malnutrition, we should give 4 mg per kg per day. So how long to give? Many studies have conducted. Approximately they are giving for 6 months. Many studies are mostly they were done around 6 to 35 months. What benefit they have seen through these studies is there is less the prevalence of diarrhea and pneumonias when they were supplemented with this low zinc for a period of 6 months. So definitive treatment, this means zinc is the only treatment. When we'll give this, there is zinc deficiency. So 3 types of zinckemias are there. Type 1 is a genetic deficiency, that is acrodermatitis enteropathica. There will be defective absorption of the zinc from the gut. And type 2 is there will be defective transfer of zinc into mother's milk. And type 3, because of underlying conditions like Crohn's disease and some preterms who are on prolonged TPN and liver diseases, there will be deficient zinc. These are the 3 types. So clinical manifestations, if there is mild zinc deficiency, there will be impaired taste and low immune response and mild form of dermatitis will be seen. And if it is severe zinc deficiency, we have, I think everyone might have crossed this clinically, scaly vesiculobullous and pustular lesions will be seen in perioral and perianal areas, and sometimes on the extensor surfaces of limbs, and alopecia also is seen in severe deficiency. So treatment in type 3, if there is underlying problem which is causing this zinc deficiency, we should give 1 to 2 mg per kg per day for 4 to 6 weeks. If it is a genetic defect like acrodermatitis enteropathica, we should give 3 mg per kg per day. That is for lifelong. We should be giving, monitoring the zinc levels every 3 to 6 months for adjusting the dose up and down. So how to prevent the zinc deficiency is, young infants, when they are shifted to complementary feed, they will not be taking this immediate meat and liver, because zinc is very rich in red meat. We will not be giving that, and mother's milk will also have less zinc in the breast milk. So we should supplement them. One thing we can do that, and we can counsel the parents about the sources of food which have zinc. And food fortification is another thing. Nowadays in foreign countries, they have food fortified the cereals and all with this zinc to prevent the deficiencies. So till now we have seen what we already knew. Something is also there which is new and yet to come about, benefits of zinc. Some of the things I'll state here. So in diabetes, nowadays, zinc is, we all know zinc is an important hexameric unit of insulin. Zinc is a component and it is required for the storage and secretion of insulin. Now, few genetic lines of evidence say that there is an insulin degrading enzyme which is zinc dependent, and that might be the pathogenesis of diabetes mellitus, and also some degenerative diseases like Alzheimer's disease. Another thing, zinc is very much required for the proper brain homeostasis. Some cases of depression, they are showing benefits if they are given antidepressants along with zinc. So aging, during aging, everyone is susceptible to diseases because of the lower immune response, and also very much infection relapses are seen in them and degenerative diseases. As zinc has this immune effect and also anti-inflammatory activity. If we supplement them with zinc, they have lesser probability of getting this infection relapses due to good immune response. So take home message is, zinc is very important micronutrient. Supplementation has a positive effect on diarrhea and pneumonia as of now. Very much useful if zinc is supplemented to the infants in resource limited countries, and many more yet studies to come to prove the benefit of zinc in future. Thank you, sir.
You justified your talk, ma'am. Thank you. Any questions?
And also zinc deficiency in the pregnant also little bit of effect, sir. That is in pregnant women linked with preterm deliveries and also intrauterine growth retardation, neural tube. So it's better to supplement to the pregnant women also. It's better to.
Yes, sir, because the requirement of zinc in pregnant women is much more higher.
Yeah.
They'll
So,
not be taking that much diet.
Yeah, 10 to 15
Yes,
mg
sir.
per day.
Yes, sir.
Thank you, sir. And the next and the last topic is PICA by Dr. Raviteja. Dr. Raviteja is completed MD in PG, Chandigarh, Assistant Professor, Department of Pediatrics, GGH and Ongole. Most welcome, sir, for your last topic of the session as well as the APPEDICON program.
Good evening, sir. Good evening, everyone. And thanks, IAP Prakasham chapter, for giving me this opportunity. I know this would be very hard after exhausting day to concentrate, so I made it very simple. So my topic is PICA. So basically, just go with the definition of PICA according to the DSM-5 criteria: eating non-nutritive, non-food substances over a period of at least 1 month at an age which in this behavior is inappropriate, which is more than 2 years, must not be socially normative or culturally acceptable behavior. And if this behavior occurs within the context of another psychiatric disorder or medical condition, it is sufficiently severe to warrant independent clinical attention. So PICA, this is derived from the word pica. This is a magpie bird. Because of this bird gathering and out of curiosity, it gathers and eats a variety of objects. So basically, this pica is commonly seen in infants and toddlers because of that exploring behavior. But more than 2 years, it needs assessment. In pregnant women, it is common intellectually impaired, autism, ADHD, depression, and schizophrenia. Culturally acceptable in some parts of the world, mostly Africa and Southern America. So certain types of pica named, there's amylophagia, pagophagia, which is ice, and geophagia, which is common consumption of dirt or mud or soil, trichophagia, which is hair, xylophagia, which is wood. And recently I have crossed over a beautiful article also regarding cotoperiophagia, ingestion of the burnt matchsticks, a recent article from PGI. So basically, coming to the history, this practice has been known to occur since some 2000 years back. And pregnant women in the rural south of the USA were known to travel to specific river banks and gather clay and baked in the clay oven and eat. So, and pagophagia is eating ice is much more common in the US, and in Asia and African countries, geophagia, eating mud is more, dirt is more common. So coming to etiology, basically it's a correlation with iron deficiency is more like a simple proverb, chicken or egg, what comes first? I wonder someone knows this answer. Like that, iron deficiency causes pica or pica causes iron deficiency. So there are different hypotheses, mainly 3 hypotheses for causing pica. So nutritional deficiency, body crave for a substance that is deficient and compensates for its lack. So in certain studies from Japan also, they try to prove this. In pagophagia, Japanese studies hypothesize that when a patient with anemia chews ice, it increases the perfusion, thus by increasing brain function. But this theory fails in geophagia. Ingested items actually hinders the iron absorption. So still the link between what body needs and what it craves, it seems weak. So next is adaptive hypothesis. Protection from enterotoxin or parasites by reducing the permeability of the gut wall or binding directly to the toxins. So finally is non-adaptive hypothesis by Young et al. There would be no benefit from geophagy, which instead could be an epiphenomenon of neurological problems, possibly caused by the nutrient deficiencies. So there is no good explanation, however, for why an eating behavior is a manifestation of iron or other micronutrient deficiency, maybe due to a disordered mind caused by biochemical deficiency. So coming only with iron deficiency or some other micronutrient deficiencies causing pica. So there's a meta-analysis. There's a study of 47 children with iron deficiency, anemia, and pica, and iron deficient children without pica. So they have seen lower levels of selenium and zinc and significantly higher oxidative stress index in the iron deficiency pica group as compared with other control groups. So the role of selenium and zinc is also established. So risk factors for pica we have already explained. The pregnancy, which is a state or stage of nutritional deficiency, and younger women with first pregnancy are more prone. Child with parental neglect, poor supervision. Recent studies showing learning disabilities and sickle cell anemia showing more incidence of pica. And obviously poor socioeconomic status. So on a whole, the etiology could be nutritional deficiency or cultural or psychosocial. So what is the magnitude of the problem? Why it is important? So pica is still, there's a recent meta-analysis, still 28% of pregnant women have pica. And so iron deficiency, pica is associated with 2.35 times more chances in anemia and lower zinc concentration. There are recent studies from 2015 and 2016. So coming to a case, how is coming to history taking, detailed caregiver interviews, the type of substance he eats, amount, duration of exposure, settings where behavioral usually happens, the source of the substance, any co-ingestions to lead for look for complications and symptoms of toxicity, and other development and socioeconomic history is definitely warranted in case of pica. So how will you diagnose pica? So definitely pica is a clinical diagnosis according to what we have seen in the first slide, and investigations may be useful in screening for potential causes and complications. So how will you evaluate the case? So after as we have discussed, more than 2 years of age, assessment for developmental delays and ASD, and basic CBP with differentials and MCV, the indices, and some studies showing iron studies should be done in all cases of pica. But in resource poor settings, we can directly go for CBP. And lead and zinc levels wherever appropriate, based on the history. If it eats on the flaky paints, the child is taking one of the paints, so blood levels are appropriate. Simple abdominal X-ray if abdominal symptoms are present. So radiologically, if we suspect in lead poisoning, the lead lines, which is increased metaphyseal densities. So what are the hidden dangers or complications in pica? So iron deficiency anemia, as we all know, lead poisoning, the flaky paints, the child removed from the walls and the doors. Previously, all the indoor doors were made of these paints. Later, whatever the organization, they stopped the paints making with lead. And parasitic infestations, dental injury, mechanical bowel problems like trichobezoars, intestinal obstruction, perforations, electrolyte disturbances like hypokalemia, hyperkalemia, and hyperphosphatemia. And pica and pregnancy, how we relate, any effect on fetus. So there is a huge study. Pica is frequent, as we know, it's frequent in pregnancy, and many consider it is considered a sign of beginning gestation in the old age. Biochemical parameters during the course of pregnancy are assessed in Washington, and gestational age, body length, and body weight were not different, but head circumference of infants delivered to pica women were smaller than those of non-pica women. So, and maternal geophagy has been associated with childhood motor functional delay. So coming to treatment, how can we treat pica? So most important is parent education, decreased exposure to the craved substances, and supplementing with the iron, zinc, and other nutrients. The craving for non-food substances usually responds to iron therapy in weeks, even earlier than does hemoglobin. And dietary counseling, definitely, and behavioral interventions, what we can do as in behavioral interventions. First positive reinforcement, discrimination training between edible and non-edible substances, visual screening with eyes covered for a short period of time if pica is attempted, and aversive presentation like a bitter taste of lemon if pica is attempted. Physical intervention is more of holding hands, which is not possible. So I will end this here. Take home points that more than 2 years, just assess and evaluate the child. Always look for complications based on the history of ingested substance. Iron supplementations very well control the cravings. Thank you. Thank you for giving me this opportunity.
You've covered everything.
Sir, covered all points. Main is iron deficiency anemia and including zinc also. Second one is OCD, that is obsessive stimulator disorder, and mental health. Children also, they will have this type of attitude. So you have to counsel the parents, and you have to rule out iron deficiency anemia, and you have to supplement iron as well as zinc. So that the sir told, first one is iron deficiency or pica, maybe vice versa. So anyhow, you have to rule out iron deficiency anemia, and counseling of the parents also will help more in the prevention of pica. Thank you, sir. Thank
you. I hand over the mic to the organizers.
Thank you, sir.
Very well organized this APPEDICON, but the last 5 topics are very, very useful, but no delegates are very low, because all 5 topics are very, very important. Not visible, but they are more effective in the body. That means for our vitamin D, vitamin A, zinc, as well as pica, they are very, very important to our micro elements. So, okay, whatever may be, very good topics are covered, all the 5 doctors. And thank you, sir, for Ashton, sir, and all the organizing team. Will by this will wind up the program. Thank you, sir. Thank you, madam.
Thank you, sir. I would like to request Dr. S. Subba Reddy Garu, Dr. Yashwant Rao Garu to felicitate Dr. Karthik Nalluri, Dr. A.S. Kirti, Dr. V. Spandana, Dr. P. Sirisha, Dr. Ravi Teja. Dr. Karthik Nalluri Garu. Dr. A.S. Kirti Garu, Dr. V. Spandana Garu, Kiriti, sorry, sir. Dr. Raviteja Garu.
Announcement, please. Validatory function will be run in Hall B. Please assemble there.